You are live now.
You are live. All right. Good morning, everyone, and welcome to the UP chapter of WOS Residents Program. It is my privilege to welcome our WOS Secretary, Dr. Mohita Sharma ma'am, UP State Chapter Heads, Dr. Nilima Mehrotra and Dr. Smita Agarwal ma'am, all our esteemed judges, distinguished speakers, all faculty members, mentors, and the young presenters from various medical colleges of UP to today's program. Now, the Women Ophthalmologists Society, as we all know, continuously aims to boost and provide opportunities to young ophthalmologists all over the country. Today's program is the perfect platform for the young presenters to showcase their talent in front of their peers, which includes distinguished ophthalmologists from all over the country. We are lucky to have about 20 presenters from different medical institutions of UP. Apart from that, we have a great lineup of esteemed speakers who are going to enlighten us with their talks. I am Dr. Manupriya from Bareilly. Dr. Gargi Nagpal and I will be your moderators for the day and will be taking you through today's proceedings. I would first like to introduce our WOS UP state chapter heads. First, I'd like to introduce Dr. Nilima Mehrotra, who has also been my mentor and guide. She is the Dean and the Professor and Head of Department of Ophthalmology, and also the Medical Director of SRMS IBAN at SRMS IMS Bareilly. Ma'am has initiated the department single-handedly and consistently worked towards making it as a tertiary care center in the area. Ma'am has won various awards, appreciation awards. Ma'am has done over 40,000 cataract surgery and a huge amount of charitable work for blindness eradication and public awareness. Now I would like to introduce our other state head, Dr. Smita Agarwal. She is the director and consultant at Pragyan Health Center at Moradabad. She has been the WOS UP state chapter head for 2 consecutive terms. She is the joint treasurer at UPSOS. Ma'am has been the organizing secretary of UPSOS annual conference in 2017. She has more than 20 years of experience in clinical work, and she has multiple publications in various journals, and she has been actively participating in WOS and UPSOS related activities. I would now like to invite Dr. Nilima Mehrotra ma'am for the official welcome address.
Thank you, and I hope I am audible and visible at the same time.
Yes, sir.
So good morning to everybody, and a very, very hearty welcome to all of you. Thank you, Manupriya, for the kind introduction. And I would like to say that now that we are beginning this program, we're getting together on Sunday. And I must welcome you all, and I must also initially thank you and pay my regards that you have all taken out spare time on a Sunday to listen to judge, and to guide, and to inspire our junior residents of ophthalmology of our state of Uttar Pradesh. So you will be getting a glimpse of the enormous clinical work which they are doing in various medical colleges of the state. Though UP is perhaps not the largest in terms of area, but it is the largest state of our country in terms of population. So you can imagine how much clinical and surgical load these residents must be exposed to, and how well they will learn ophthalmology through their residency programs. I remember when I was a medical student in UP, we had 7 medical colleges and 2 central universities. But now when NEET UG and PG results are out, and this year the counseling and admissions are going on, you know, we have, I was amazed myself to see that we have 70 medical colleges in UP, including 2 AIIMS, 33 government, 2 central universities, 1 deemed universities, and 32 private medical colleges. So all of these are doing very well, and we have today residents who want to present from 11 medical colleges along with their mentors. We also, this is a very popular program. We also have people who were coming in and asking me to present, even though they are not now in UP and we could not accommodate them, of course. But the feeling is, it is really happy to, you feel really happy to know that people want to participate in this program. So Women's Ophthalmological Society has pioneered this mentor-mentee concept. This is a very beautiful way of showcasing the transfer of academic, clinical, and surgical skills from the protege to the protege. So this is the mentors who make you grow better and help you, with their own experience, which is the most invaluable thing as far as medical profession is concerned. So at the outset, it is my pleasure to welcome to this platform today Dr. Mohita Sharma. She's very busy herself, not only with WOS, with UP State, and also with All India Ophthalmological and other societies. And she's aptly the very capable leader who leads us from the front. She has envisioned not only the birth, but also the growth of Women Ophthalmological Society in our country. So kudos to you, Dr. Mohita, and welcome to the WOS UP chapter of Residents Competitive Presentations. I'm also very happy to welcome Dr. Shweta Walia. She's the untiring force as the WOS Residents Program Coordinator, and she's helping successfully steer these programs to become fulfilling and grand events. I can hardly express my thanks for my very good friend and my partner as the UP State Head. I'm so lucky to have her with me, Dr. Smita Agarwal. She clearly sees through confusing situations and solves problems in matters of minutes. Welcome, my dear Smita. I'd also like to take this opportunity to express gratitude to inspiring women at the helm of WOS and their leadership, which helps us grow as a society. Though I will not be able to name all of them, but Dr. Madhu ma'am, Dr. Swati, Dr. Aarti, and everybody, welcome to this program, and we are happy to have you with us all the time. We have today a galaxy of stars of ophthalmology as the judges for this program. So the residents, all my dear students, you will be not only be judged, but also be learning a lot during this presentation. And I welcome Dr. Ragini Parekh, Dr. Nilesh Parekh, Dr. Rima Rawal, Dr. Vinita Ramnani, Dr. Rajwinder Randhawa, Dr. Sanjay Thakur, Dr. Shweta Walia, Dr. Sudipta Ghosh, and Dr. Shanti Pandey. On behalf of UP chapter of WOS, I welcome you all today. Also, we have in our part of our program today is talk from eminent women ophthalmologists of UP, including Dr. Pragati Garg, Dr. Gayatri Ahuja, Dr. Jimmy Mittal, Dr. Sividha Meher, and also Dr. Vibha Singh. I welcome you all today also to this program. I must also welcome the CIPLA people, and I'm happy they are supporting this academic program. And to office workers of WOS, Mr. Bhageshwar and others, they do so much unseen yet very, very crucial work. I'm also very happy to welcome participants and their mentors today. So the participants, the residents, like I'm happy to have a few of my own students here. And let me tell you something. I really firmly believe in this about mentoring and teaching. So, it is said that when you really need a teacher appears. And when you really, really, truly need a teacher disappears. Even this, when the teacher is there with you or when the teacher leaves you to do it on your own, that is also teaching you. So understand and just place your faith in your mentor, understand your mentor, follow your mentor to have your growth accelerated and to learn from their experiences, which you will not probably find anywhere else. And my very sincere welcome to all the mentors who have put in efforts to get their students to present on this platform. and to become worldly wise. They at one time they leave us and go and they become worldly wise. So as mentors, we all know that the true formula to be a mentor is to just be like you would have wanted someone to be with you. So without much further ado, let me step away, holding you from this academic feast, and hand over the stage to our very young, charming, all of us are young here, but even younger, and very capable, very charming moderators, Dr. Manupriya and Dr. Gargi Nagpal. Welcome you all once again. Thank you, Manupriya. And you and Dr. Gargi can take over from now on and lead on this program. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am. I would like to briefly go over the program. So the program is basically a competitive case presentation session where residents from different medical colleges of Uttar Pradesh will be presenting their case in front of a panel of judges. So the whole program is divided into 3 sessions, and we have around 3 to 4 colleges in each session. Now the presentation will be of 4 minutes, followed by 2 minutes of discussion. The mentors of the residents will be involved to defend and support the resident. Now, a warning bell will go off at 3 minutes and 30 seconds and another one at 4 minutes. Kindly note that marks will be deducted if you exceed the time limit of the presentation. I would also like to request all the judges to kindly keep the discussion part for 2 minutes since we have a scheduled time for the whole of the program. For the residents, please note the marks will be awarded out of 50. The residents will be judged on the following criteria: way and quality of presentation, clinical acumen, originality and uniqueness, adherence to time, and discussion. The results shall be announced at the end of the 3 sessions. I request everyone to stay with us till the end of the program. WOS has already held multiple state sessions in other states like Madhya Pradesh, Maharashtra, Delhi, etc. The winner of this program will get to compete against other states during the finale, which will be held during the annual conference of WOS in October. I would now like to request my co-moderator, Dr. Gargi Nagpal, to begin the session.
Thank you, Dr. Manupriya. Good morning, everyone. Our respected state heads, Dr. Nilima, Dr. Smita, our role model, Dr. Mohita, and our coordinator of WOS session, Dr. Shweta Walia ma'am. I extend heartfelt welcome to our honorable judges for the 3 competitive sessions and our presenters and their respected mentors. I'm overwhelmed to have some good speakers also amongst us who will be throwing light on the burning topics of the hour. Now, our first speaker for the session, Dr. Mohita Sharma ma'am, is participating in another parallel meeting. So we will have to catch her up in a while. As well as Dr. Devi Ashwarya Das is unable to participate right now. She will also be joining us sometime later. So beginning with our competitive session 1, I will like to welcome our judges for the session.
Yes.
Yes, I'm just trying to share my screen. Can you all see the competitive session 1 judges?
Yes,
My
yes.
screen. So I'd like to welcome Dr. Ragini Parekh ma'am, Dr. Reema Raval ma'am, and Dr. Nilesh Parekh sir. And I'll introduce with Dr. Ragini Parekh ma'am. She is currently working as a director in Manorama Netralaya, Mumbai, has performed more than 80,000 surgeries, has received 100 Women Achievers Award by Honorable Shri Pranab Mukherjee, President of India. She has worked in more than 500 camps, worked for leprosy patients, then received more than 50 awards for community ophthalmology, had worked in Grant Medical College and Sir J.J. Hospital. And she has been the scientific chairman of Bombay Ophthalmologist Association, presented papers and instruction courses, and has been faculty at major conferences in India. and international too. Taught UG, PG students and numerous medical officers also. She has served as examiner and inspector for various medical colleges in Maharashtra and India, has participated as invited guests in numerous TV and radio shows, has been the president of prestigious Bombay Ophthalmologist Association and IRSI. Her Manorama Netralaya is a step forward to continue to provide best and complete eye care to every patient with expertise. I welcome you, ma'am. I hope you have joined.
Thank you, Dr. Gargi. Yes, I have joined. Thank you for the invite. Thank you, Dr. Nilima, ma'am. Thank you, Mohita, for being the heart and soul of WOS. And thank you, Manupriya. And thank you, Dr. Shweta. This is a wonderful program. All the best to all the participants and a warm hug to both the judges, Dr. Nilesh Bhai and Dr. Rima, ma'am. Thank you so much, Dr. Gargi.
Most welcome. And for your information, ma'am is already attending another conference, parallel conference, and
Yes.
she has consented to be our judge, also taking out time for us. Thank you, ma'am.
Thank you. Thank you so much. Thank you, Dr. Gargi.
Now, I welcome Dr. Rima Rawal, ma'am. She is a professor and HOD at NHL Municipal Medical College, Ahmedabad. Her teaching experience is 19 years and PG has been PG teacher for last 13 years. She has many national and international publications, including IJO, and she has authorship of 2 chapters in glaucoma, book of MSO series of Khurana. I welcome you, ma'am. Dr. Rima, ma'am, I hope you have joined. Ma'am, we cannot hear you.
I just hello everybody. Actually the internet just went for the seconds. Ragini madam completed and you started my introduction. But I already know myself, so I missed my introduction. That's fine.
Okay.
I thank you for giving this opportunity, and it's a great thing to join the platform with Ragini ma'am and Nilesh bhai, both my great favorites, and learning from them also a lot. And cannot complete without thanking Dr. Valia, who's such a great friend, and I look upon her for working so much towards this PG program, and all the organizers and the WOS team. Thank you so much, and looking forward to this discussion. Thank you.
Thank you, ma'am. I welcome now Dr. Nilesh Parekh, sir. He is professor and HOD of Government Medical College, Bhavnagar. He has authored the book Practical Ophthalmology Made Easy, received IMA HQ Award for Academic Excellence in 2023. He has been examiner at various universities all over India and National Board of Examinations. He is member of Executive Committee of Gujarat Medical Council and has numerous scientific papers, posters, publications, clinical researches to his name, and has been faculty in various conferences and CMEs. I welcome you, sir. Dr. Nilesh, sir.
Yes. Hello.
Yes, sir, we can hear you.
Yeah, you can hear me. All right. Good morning to everyone. And thank you so much to the organizers, and especially Nilima ma'am and Gargi and Dr. Gargi Nagpal and Dr. Manupriya also. Thank you so much for inviting me and to be a part of this wonderful event. And it is also good to be virtually with Dr. Ragini Ben and Dr. Rima Ben also. And thank you so much. Yeah, over to you.
Thank you, Nilesh Bhai. Thank you,
Thank
Rima
you.
Ben. Thank you.
Hello.
Hello, sir. Hello.
Hello.
Hello. Yeah. Hello. Yeah.
Yes, now we should proceed with our competitive session 1. And we are having 7 presenters from 4 medical colleges, starting with SNMC Agra. As Dr. Poonam is not there, I request the judges to please cut her name from the list. And we'll be starting with Dr. Preeti Dubey, under the mentorship of Dr. Anu Jain. Dr. Preeti, can you hear me? Dr. Preeti?
Preeti, you need to unmute yourself.
Yes. Yes, she's there.
Preeti, are you ready with your presentation?
Yes, ma'am.
I hope your mentor, Dr. Anu, is also there.
Yeah, I'm there.
Ma'am, okay, welcome. Let's start with your presentation. And as you know, the rules, the timings are 4 minutes. So we'll give a bell at 3:30, and you are ready to start with your presentation now.
Ma'am, the screen is not shareable. It's saying the host isn't allowing multiple presenters to share
Dr.
the screen.
Gargi, you
I
have
am
to
stopping the share.
stop sharing your presentation.
Yes.
You can share now, Dr. Preeti.
Good morning, respected judges, my mentors, and everybody else present here. Today, I'm going to present my case. Case of 27 years old female, a student at Manpuri. The chief complaint was drooping of left upper eyelid since 2 years. The history of present illness. According to her, she was apparently well 2 years back. Then she noticed drooping of left upper eyelid, which was insidious in onset, painless, and non-progressive. There was a history of a small mass of the left upper eyelid, which was associated with itching 2 years back, for which the patient took some medical treatment, but there was no documentation present. There was no history of any diurnal variation of drooping, any febrile illness, or any neurological event. There was no history of any diplopia, ocular trauma, or surgery. There was no history of dysphagia, dysphonia, or any uneven sweating over the face. There was no history of any weight gain, weight loss, heat intolerance, or the cold intolerance in the patient. The birth history and personal history were non-conclusive. Past history showed a small mass over the left upper eyelid, which was associated with itching. The family history was non-conclusive. General examination, the patient is of average build, well oriented to time, place, and person. There was no icterus, pallor, sinuses, clubbing, pedal edema, and lymphadenopathy noted. BP and pulse rate were in normal range. She was afebrile to touch. There was no generalized muscle weakness. The examination of neck revealed no swelling, and all other system examinations were in normal limits. Coming on to ocular examination, the head posture is erect, face is symmetrical. The eyebrow is slightly elevated on the left eye. The orthophoric alignment is there. The eyebrow in the left upper lid shows ptosis with a higher upper lid crease, and there is a scar mark on the upper lid crease. The orbital margins in both eyes were intact. Coming on to the vision, both eyes had a 6:6 partial vision, but attained BCVA 6/6 with the use of -0.25 dioptric spherical lens. The pupil was normal shape, normal reacting. Rest other corneal sensation tremors were in normal limit. The axis was aligned in both the eyes. The slit time examination revealed ptotic upper eyelid in the left eye. Rest all other conjunctiva, cornea, iris, pupil, AC, and the lens were in normal limit. The fundus examination was also normal, except for few myelinated nerve fibers superior to disc in the left eye. Coming on to ptosis workup, the palpable aperture was 10 mm in right. In left, it was 7 mm. MRD1 was 4 in right, 1 in left eye. MRD2 was similar, 6 mm in both. Pre-task to show was 3 mm in right, 9 mm in left. Margin crease distance was 6 in right, 7 in left. Margin limbal distance was 9 in right, 5 in left. And ocular movements were full and painless in both the eyes. LPS function was 12 mm in right and 8 mm in left. The Bell's phenomenon was good in both the eyes. The Marcus gun jaw winking phenomenon was absent. So my provision diagnosis is left eye moderate aponeurotic ptosis with fair levator function with good Bell's phenomenon. Thank you.
Judges, please note the participant was well within the time limit.
Yes. So we are done with our first presentation by Dr. Preeti. And is there any question to ask?
No, but I have a comment. So I'm really happy with the presentation. I really appreciate the mentor's efforts with putting in proper pictures and videos and demonstrating the Bell's phenomenon, the Marcus jaw winking phenomenon. So being a resident and having this quality of presentation, presented it very, very lucidly. I really appreciate you, Dr. Preeti, and the mentored both. Thank you so much. It was well done. So now what, Dr. Preeti, how will you go ahead with this patient?
Ma'am, as the LPS function was fair, 8 mm in the left eye, and there was a moderate ptosis, that was 3 mm. So we will go for, ma'am, LPS resection, and following the BATS guideline, we will do moderate LPS resection, that is 13 to 17 mm.
Okay. What will you be careful post-operatively? What are you scared of post-operatively?
Ma'am, there may be an undercorrection. Then we will have to go for revision surgery.
But immediate post-operative with regards to the cornea, what are you afraid
Ma'am,
of
there
in
can be
any
exposure
process?
keratopathy. Ma'am, for
Oh.
that we did ma'am Bell's phenomenon. It was good. So ma'am, we are pretty sure that that should not be present, but we will then take care that cornea should not be hampered.
Okay. Thank you.
Thank you, ma'am.
Any more questions, or shall we start with the next speaker?
No more questions. I mean, ma'am has already covered the things, but congratulations from my side also. And good to see Dr. Anu Jain also. And she has mentored so well.
Yeah, thank you, sir. Thank you, sir.
Yeah. I'd been to your place.
Yeah, definitely,
Yes,
sir.
yes.
We still talk about you here.
Okay. Thank you so much. Okay.
Yeah, one question may I ask, ma'am, if there is time? Hello, am I audible?
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Yeah, beta, you started with a lid swelling, right? Can you just tell me very quickly the common clinical lid swellings differential diagnosis?
Ma'am, there can be plexiform neuroma, or ma'am, there may be multiple lesion or giant papillae which can be present in VKC. Ma'am, they can cause mechanical ptosis.
Anything else? Very good. Anything else? Okay. Yeah. And one last question. Had it been Marcus done one positive, how your management would have been then? You said, na,
Ma'am, if
Marcus
it
done
is-
negative?
Yes, ma'am. Yes, ma'am. If it is significant, ma'am, we will go for LPS resection plus link surgery. And if it is not significant, then we will, ma'am, follow the basic rules, only LPS resection. But it is to be noted that undercorrection is common, and we may need a higher side of LPS resection. It means, ma'am, if 13 to 17 mm was desired, but if Marcus gun is present, then we will go maximum LPS resection. Ma'am, it is more
Very
to be
good.
resected, but undercorrection is common.
Okay, perfect. So we have to counsel the patient that he may have a different result than a normal ptosis. Very good. Excellent. Thank you.
Yes, ma'am.
Yeah.
So the time for discussion is also up. Continue.
Let's move to our next speaker from LLRM Meerut. She is Dr. Shivi Srivastav under the mentorship of Dr. Alka Gupta ma'am. Shivi, are you there?
Yes. Am I audible?
Yes, Shivi, you are audible. Alka ma'am has joined.
Yes, I am here.
Okay, welcome.
Already
ma'am.
joined. Okay,
Welcome.
thank you. Thank you.
Okay, Shivi, you can. Are you ready with your presentation? You can start sharing it. Shivi, just below the screen, there is an option of share screen. In the yes. So, are you ready? You can start.
Good morning, everyone. I'm presenting the case of a 14-year-old female, a resident of Lakhimpura, Meerut, who is a student of 4th class and presented to our OPD with the chief complaints of protrusion of eyeballs since 5 months, redness and photophobia since 3 months, watering from eyes since 20 days. The patient was apparently asymptomatic 5 months back when she developed protrusion of eyeball accompanied by excessive sweating, easy fatigability, weight loss, palpitations, heat intolerance, and fine tremor in both the hands. She also complains of redness, photophobia, and watering from eyes Parents also noted a midline swelling in the neck since 5 months, which was painless and progressively increasing, but now it is of constant in size. For these symptoms, she visited endocrinology department and was diagnosed as a case of Graves' disease and was admitted in our hospital on May 29 and was started with treatment carbimazole tablet 5 milligram TDS, propranolol 20 milligram TDS, and calcirol sachet 60,000 international units once a month. She then presented to our OPD as a referred case. There was no significant past and family history, and personal history was also normal. The general examination shows that the patient was all the systems were within normal limits, but the thyroid gland was diffusely enlarged, normal in shape, soft, non-tender, smooth, mobile, with normal overlying skin, and it moves with deglutition with no pulsation and no bruit present. There was fine tremors in hands. This is the neck showing goiter in the patient. The ocular examination showed uncorrected visual acuity was 612 in the right eye and 612 partial in the left eye. Best corrected distance visual acuity was 66 in the right eye with minus 0.75 diopter sphere and 66 in the left eye with minus 1.25 diopter sphere. The ocular movements were free, full, and painless in all directions of gaze. MRD1 and MRD2 for the right eye was 6 and 8 mm respectively, and 5 and 8 mm for the left eye. Palpebral fissure height was 14 mm for the right eye and 13 mm for the left eye. Levator function was 11 mm in the right eye and 9 mm in the left eye. Bell's phenomena was good. Exophthalmometry was 23 mm for the right and 24 mm for the left eye. On retropulsion test, resistance was felt, but there was no bruit on auscultation and crepitations were absent. This is the photograph performing Hertel's exophthalmometry. The patient showed the positive following signs which were positive in the patient: Dalrymple sign, Steelwalk sign, Cocker sign, Geoffroy sign, Goldzieher sign, Rosenbach sign, and she has positive arterialization. Conjunctiva showed temporal and superior conjunctival injection in both the eyes. The caruncle were mildly inflamed. Phenylephrine test showed that there was blanching present. Hirschberg corneal reflex test was central. Visual axis was aligned and there were no diplopia. IOP in both primary and superior gaze was 17.3 mm Hg. Cornea, AC, iris, lens, and fundus were all within normal limits. We performed the thyroid function test for the patient. Her T3 and T4 were elevated and TSH was low. USG and CT scan of the head and orbit show normal extraocular muscle thickness with no apparent increase in orbital fat volume. So my diagnosis is thyroid-associated orbitopathy secondary to Graves' disease with myopia in both the eyes. Clinical activity score being 0 out of 7 in the right eye and 1 out of 7 in the left eye with mild severity. The treatment I would prescribe is refractive correction, eye drop carboxymethylcellulose 6 times per day, lid taping at night, head and elevation, use of dark goggles when outdoors, and regular follow-up with endocrine department for maintenance of euthyroid state every 4 to 6 weekly. Thank you.
Judges, please note the participant was well within her time limits.
Yeah, thank you. Thank you.
Judges, please, Dr. Ragini ma'am, any question?
No, I think it is once again a wonderful presentation, demonstration of all the signs. Very good learning for all the residents because it's a clinical case. Congratulations for a lovely presentation and thank you to the mentor, Dr. Alka ma'am, for helping you out with making such a wonderful presentation.
Dr. Nilesh sir?
Yeah, again, congratulations for very good presentations and regards to the mentor Agrawal ma'am also. So what is the plan for this little girl?
Sir,
What is the advice?
Sir, since she is having mild severity of disease in the clinical activity score and there is no active inflammation, so we will advise her, we'll keep her on conservative management and advise frequent follow-up with the endocrinology department. For the exophthalmos, we can prescribe lid taping at night and also head end elevation to decrease the edema and lubricating eye drops to prevent exposure keratopathy.
All right. And for a very severe dysthyroid ophthalmopathy, what is the newer medical treatment?
So the newest advancement in this field is a monoclonal antibody,
Yes.
teprotumumab,
Yeah.
which is an insulin-like growth factor receptor inhibitor, which
Fine.
is
So people have got very encouraging results with this monoclonal antibody. Fine. All the best to you.
thank you so much, sir.
Dr. Reema ma'am.
Yeah, I would like to ask one question. Very good presentation, Beta. Can you give me differential diagnosis of such presentation at this age of a 14-year-old? What other things come to your mind if you don't have thyroid eye disease?
Ma'am, a significant differential diagnosis would be optic nerve glioma because the age of presentation is around
Very
this
good.
age.
Yes, yes.
Ma'am,
Anything else?
other differential diagnosis is since the clinical activity score, there is no active inflammation. That is why the other causes of inflammatory proptosis can be ruled out here.
Exactly. One last question. That is female ratio more common than male in thyroid eye disease, or severity is more in which gender?
Ma'am, the ratio is more for females, but the advanced disease and the age of presentation is more for the male gender because smoking and diabetes is a significant risk
Excellent.
factor.
Very true. Very true. Yeah, great. Thank you. Yeah. Both the men, teachers, I really appreciate both the cases so far. The teachers have really taught them well, and the students have done well. Thank you. Yeah.
Thank you, ma'am.
Okay. Now we are moving to our next speaker again from LLRM Meerut, Dr. Shilpi Kumari, under the mentorship of Dr. Jayashree Dwivedi. Is Dr. Shilpi here?
Yes, ma'am.
Ma'am, are you there, Doctor?
I am here.
Welcome, ma'am. Dr. Shilpi, are you ready with your presentation? Can we start sharing your screen? Dr. Shilpi, there is an option of share screen underneath your video option. Yes. Yes. Yes.
Hello, shall I start?
Yes, start.
Good morning, everyone. I'm Dr. Shilpi Kumari, and I'm going to present my case. I'm presenting the case of Shimla Devi, 55-year-old female resident from Meerut. She presented to our OPD on 11th of June 2024 with the chief complaint of a growth of mass in the outer aspect of left eye since 2 years. She was apparently asymptomatic 2 years back when she developed slow-growing conjunctival mass in the outer aspect of left eye, which was progressive in nature and associated with diminution of vision and foreign body sensation since 2 years. In negative history, she has no history of mass since birth, restriction of ocular motility and proptosis, no similar episode in the past, redness and discharge in the eye, no history of weight loss in the past or any medication in the past, and no pallor icterus. In the past history, she had no history of any ocular trauma or any abnormal growth in any other part of the body or any skin disorder or any organ transplantation or any immunosuppressive drug intake history. In personal history, she is vegetarian by diet and a housewife in a diagnosed case of HCV. In general examination, she is a middle-aged female, moderately built, conscious, cooperative, and patient systemically she is normal. Talking about ocular examination, in the right eye, she had 6/12 vision, round, regularly active pupil, IOP normal, head posture erect, retinoscopy in horizontal and vertical axis neutralized by +3 and +4 diopter sphere respectively, with best corrected visual acuity comes out to be +1.50 diopter spheres and the +1.50 diopter cylinder at 90 degree, giving acuity 6.9. And on the left hand, on the left side, for the left eye, the vision is 1 meter finger count, PL positive, PR accurate, reactive and regular pupil. Be normal. Retinoscopy, BCV, and ear correction could not be appreciated because of the obstructive media. Eyelid for the right eye, eyelid, conjunctiva, cornea, all are clear, and anterior chamber is white and clear. Iris normal color pattern, lens pseudophakic for the right eye, and the left eye we have a finding in conjunctiva. Palpebral was within normal limit. Bulbar there was a mass. Side temporal aspect, size 1.5 centimeter in length and 0.7 centimeter width. Fixity mobile over the sclera, margins were irregular, shape quadrangular, consistency was soft. We appreciated feeder vessels, which is 7 in number. Corneal conjunctiva was within normal limit. Cornea, there was a margin encroaching cornea from the 3 o'clock to 6 o'clock. Anterior chamber could not be appreciated due to the obstructive media. Iris and lens, up to the visualization, iris normal and pseudophakic. In the right eye, we see that the fundus, gonioscopic, lacrimal system, and lymphadenopathy absent. That is normal finding. But in the left eye, fundus could not be appreciated due to obstructive media. Gonioscopy could not be attempted, and lacrimal system patent, NLD, and lymphadenopathy absent. This is the corneal drawing showing the conjunctival mass encroaching cornea. So this is again the description of a mass, ill-defined margin, pigmented, raised, soft, mobile, comprised of feeder vessels, which are 7. This is the picture of the mass, and these are the number of feeder vessels, which was 7 in number. Talking about the investigation, we have clinically evaluated. It is a papilliform mass that is through the morphology, routine investigation. The findings were normal. The blood investigations were normal, but on viral marker, we find the patient to be HCV positive. We cannot for impression cytology, ultrasound biomicroscopy, and anterior segment OCT. But in my case, I opted for histopathological examination, which suggests microinvasive squamous cell carcinoma. In further evaluation, we can start the investigation for CT, MRI, and immunohistochemistry for confirming the histopathological diagnosis, PET scan if MACs are suspected. According to that TNM staging, in my case, it was found that the tumor invades structures excluding the orbit, that is T3 level. There are no regional lymph node mats and no distant mats, and the tumor is poorly differentiated. So TNM staging in my case is T3, N0, M0G3. Differential diagnosis can be pterygium, pinguicula, pyogenic granuloma, limbal dermoid, conjunctival papilloma, penis, keratoxanthoma, conjunctival melanoma with vitamin deficiency. So my final diagnosis is a freely mobile, raised, pigmented, progressive, slow-growing mass with dilated tortuous feeder vessels, microscopically confirmed case of ocular surface squamous cell neoplasia left eye with compound hypermetropia right eye. The treatment, we opted for excisional biopsy by no-touch technique followed by conjunctivoplasty. Post-surgically, symptomatic treatment was given in the form of antibiotic, anti-inflammatory, and anti-PPIs. And adjuvant chemotherapy was added. Hydroxymitomycin 0.04% QID in the two technique form, like 1 week on and 1 week off. But it can also be given 4 days a week for 4 weeks, followed by a gap of 2 weeks. Follow-up visits are required for first year 3 monthly and for second year or 6 monthly, and annual follow-up thereafter. These are the post-surgical images. Thank you.
Judges, please note the participant took 4 minutes and 15 seconds.
Oh, that is not good because it was such a lovely presentation, a complete presentation from the diagnosis, the differential diagnosis, the treatment, the plan of action. So I think next time you have to present it and time yourself. But it was a wonderful presentation.
Madam, you're not audible. Yeah.
There are some weak signals from her side, I think.
She's traveling. Probably she is in car.
Yeah.
So could you hear me?
Yes, ma'am. Now you're audible.
Now, yes.
Could you hear me? Okay.
Yes.
So I was saying it was a wonderful and a complete presentation from start to finish with post-operative pitch. Sad about the 15-second overtime, but we have to keep time, which is very, very important. So next time she can practice presentation within 4 minutes, but a wonderful, wonderful presentation. I think the quality of presentation has been wonderful today and always in WOS, and keep it up. I must congratulate the mentor too for the lovely surgery and the post-op and the management of the patient.
Thank you, ma'am. Dr. Nilesh, sir.
Yeah, many congratulations, very well presented. But as ma'am said, that the material was too much for the time limit. So she had to keep on moving back and forth, and she had to skip certain things. But it was really very well presented and well managed also. My question is that what is the role of interferon? You have not considered using
Yes, sir.
interferons?
Sir, interferon works in three ways. It acts as an immunomodulator, immunoreduction, and as an immunotherapy. That is, we can reduce the size through immunoreduction. Through immunomodulation, we can hamper the progression of the tumor. And as a therapy, we are using it. So there are three roles through which we use it. And yes, there is. It has been seen that there is a role of interferon alpha 2b as a
So,
adjuvant chemotherapy. As a chemotherapy, we can use it.
so why you did not considered? Why you considered mitomycin
Because
C?
it is because of the readily availability of mitomycin C and also the cost effectiveness of mitomycin compared to the interferon.
All right, okay. All the best.
Thank you, sir. Now, Dr. Reema, ma'am.
Yeah, just one question. First of all, wonderful. You guys have raised the bar of clinical presentation. All the three cases have been amazing so far. One last thing, if you did not have any fancy investigations or nothing for that matter, what science would support a clinical diagnosis of this situation? Give me only positive clinical signs, which you will arrive if you don't have much of investigations at your, availability.
Ma'am, through slit lamp we can see the invasion, how much it's the invasion, and
Very
ma'am,
good.
and the involvement of underlying structures, and also ma'am, we can stain this.
But why
Rose
only this
Bengal through the
diagnosis?
rose Bengal
Yeah,
staining. Through
yeah,
the
I
rose
know. But
Bengal
how will you
stain.
rule out? Yeah, how will you rule out other other rare conditions? This is a very unique case.
Yes, ma'am.
So encroachment and all.
Through
Anything
the
else
through
from
the clinical
history?
evaluation.
Huh.
Yes, ma'am. Through history, that it is a prolonged case, a chronic case. Like she is giving a history of 2 years. Since 2 years, she is having, and it's growing, and it's increasing in size, shape, and the appearance, the papilliform appearance. Because we have seen that OS, ocular surface squamous neoplasia, are present in various morphological variant. We have nodular variant, papilliform, placoid, gelatinous,
Very good.
corneal,
Yes.
nodular.
Yes.
So these variants are clinically appreciated through slit lamp, and we can clinically see them, and without the investigation we can rule out other things.
Okay. Thank you. Good. Very good. Yeah.
So we now move to our next speaker from Subharti Medical College, Meerut. She is Dr. Sagarika Singh under the mentorship of Dr. Malvika Dhar, ma'am. Dr. Sagarika, I hope you have joined.
Ma'am, hello.
Ma'am is there.
Am I audible?
Yes, you are very much audible. Dr. Malvika, ma'am, are you here?
Yes, good morning. I'm here.
Good morning, ma'am. And Dr. Sagarika?
Yes, ma'am.
Can we see your screen?
Morning, Dr. Malvika, ma'am. Morning.
Is it visible now?
Yes, it is visible. So, are you ready?
Yeah.
So let's start.
Good morning, everyone. I will be presenting the case presentation of a 17-year-old male presented with gradually progressive bilateral drooping of upper eyelids.
Can I interrupt, Dr. Sagarika? We would like to see you. Okay, go ahead.
Good morning, everybody. The topic I'm presenting a case presentation of a 17-year-old male presented with gradually progressive bilateral drooping of upper eyelids, restricted eye movements since 4 years, and the visual acuity of both the eyes is 6/6. On examination, we found out the severe ptosis in both the eyes. Right is 6 mm and left is 5 mm with poor Bell's response with fair LPS function. Both the LPS function is 5 mm was observed. Patient has adopted a chin-up position head posture. The extraocular movements were present but severely restricted in all the gazes bilaterally with maximum 10 degrees of movement from the primary gaze. By 10 degrees exotropia and 4 degrees hypertropia was also noted. Rest ocular and systemic examination was within normal limits. Of the past history, there is no diurnal variation of drooping of eyelids, restriction of eye movements, pain, and distal muscle weakness. No history of trauma, fever, ocular surgery, systemic illnesses, and other immunocompromises illnesses. There is no significant family history. So as we can see, all the extraocular movements are restricted in all the gazes. In primary, there is ptosis right more than left with the exotropia of 10 degrees and hypertropia of 4 degrees is seen. So to rule out the other DDs of the disease, so we have given the investigation first for the myasthenia gravis. The curtain sign was negative. Cogan lit twitch test is negative. Eye spike test is negative. Penicillin test is negative. For thyroid rule out, thyroid profile was within normal limits. For congenital fibrosis of extraocular muscles, we have asked the childhood photo, which looks like normal, as you can see, to check the cardiac conduction abnormalities associated with the Kern-Chiari syndrome. The ECG was normal. For any anatomical abnormalities, MRI and brain and orbit was done. Findings were suggestive of bilateral symmetrical atrophy of extraocular muscles. So as we can see, there is atrophy of the extraocular muscles in both the eyes on MRI. So the differential diagnosis will be the chronic progressive external ophthalmoplegia, myasthenia gravis, congenital fibrosis of extraocular muscles, thyroid-associated ophthalmopathy, and myotonic dystrophy. So the probable diagnosis will be chronic progressive external ophthalmoplegia. So on the treatment, we have given right eye frontalis suspension sling operation was done, followed by left eye frontalis suspension sling of surgery was done at an interval of 2 weeks. Post-op, we have advised TAP pantoprazole 40 mg 1 time a day, doxycycline 20 mg 2 times a day, and TAP serratiopeptidase, paracetamol, and aceclofenac 3 times a day. To prevent the exposure keratopathy, we advised carboxymethylcellulose 4 times, and BCL was also applied. Post-operatively, since the right pupil was covered due to severe ptosis and left pupil was not covered, so the patient did not complain of diplopia. But post-surgery, the patient complained of diplopia, so we have given the prism glasses were prescribed. Strabismus correction surgery was not opted. That's the progressive nature of the disease. So this is the post-op picture, and it has improved a lot. Right eye ptosis has improved. So the conclusion is CPO is a rare condition with no definitive cure, but the management of symptoms play an important role in patients with CPO. EO. In our cases, the surgical management of the ptosis led to the improvement of patients' quality of life as patients stopped up chin-up position, head posture, and also resulted in better cosmetic appearance. Thank you.
And judges, please note the participant was well within the time limit.
Thank you, Dr. Sagarika.
Ma'am, any comments? Dr. Ragini ma'am, any questions?
I would have liked you to mention a neurological reference being done, because you see these chronic progressive ophthalmic conditions are associated with neurological problems. So the MRI was done, but a neurological reference would have been great. Management of this case with the neurologist would have been really helpful. And I'm happy that you mentioned about the cornea, because there would have been elevation defect in this problem with a very, very high likelihood of exposure. So something, and it was a nice presentation. Thank you so much.
Thank you.
Hello.
Dr. Nilesh, sir.
Yes. Congratulations, Sagarika.
Thank you,
And
sir.
what was the pulse rate?
Sir, it was within normal limit, 78 beats per minute.
I think that CPO usually is associated with some conduction defects in the heart also. So
Yeah, sir,
was
in
a proper ECG done and
Yes, sir.
reported?
Yes, sir. Yes, sir. A proper ECG was done because we have to rule out the Kearns-Sayre syndrome. So that it was in normal limits, and we have consulted the medicine department also for the same.
Fine. And audiometry?
Audiometry was also done, but sir, it was in the normal limits.
Okay. All right. So fine.
Dr. Reema, ma'am?
Yeah, I would like to. Can you go to your differential diagnosis slide? One
Yeah.
question from there. Yeah. Can you, why, how did you rule out the other condition? Just this question. You have posted 5 or 6 things in your differential diagnosis. Can we see your slide?
Yes. Yes, ma'am.
If you have gone out of it, just speak it out. Don't waste time. Just speak it.
Ma'am, yeah, ma'am. Yeah, ma'am, I have ruled out myasthenia gravis, thyroid, congenital fibrosis of extraocular muscles, and then ma'am, and Kearns-Sayre syndrome. So for myasthenia gravis, I have done 4 tests. Curtin sign was negative. Fogan-Littwich test was negative. IcePack test was also negative, and
Okay,
TENS test was negative. Then thyroid, the thyroid was within normal limits. The thyroid profile.
So thyroid can be normal in TED, but yeah, clinically it doesn't appear. So okay, third.
Yes, ma'am. And
differential
Kearns-Sayre
diagnosis.
syndrome. Ma'am, Kearns-Sayre
Okay.
syndrome, in that also the conduction, cardiac conduction abnormalities to rule out. We have done the ECG, and we have also seen the fundus because it has a salt pepper appearance in the fundus,
In the
which is
fundus, very
normal.
correct. Yes.
Yeah, which is normal in the CPO. So that was within normal limits.
Next, the fourth one, congenital.
Congenital fibrosis of extraocular muscle. Ma'am, we have this congenital fibrosis of the extraocular movement. So I have asked the patient for a childhood photograph, and the patient photograph seems to be appears normal since.
So we have seen the childhood photograph in this patient, right? Yeah.
Yes, ma'am.
You could have posted that. That would have been great. And the last.
Yeah, ma'am. It has posted.
Yeah. Okay. The last one.
Yeah. Last one, ma'am. MRI orbit I have done.
Okay. Great.
Just
Very
to
good.
rule out.
Congratulations. Yeah. Yes. I got my answer. Great, beta. Yeah.
Thank you so much, ma'am.
So, and now we are moving to our next speaker. Dr. Yukti, are you ready?
Good morning, ma'am.
Good morning. Dr. Yukti is from Subharti Medical College, Meerut, and again under the mentorship of Dr. Malvika Dhar.
Ma'am, is my screen visible?
Your screen is visible.
Ma'am, should I start?
Yes, Yukti, you should start.
Good morning, ma'am. My presentation. Good morning, ma'am. I will be presenting a case of a 41-year-old male presented to the OPD of Subharti Medical College with sudden onset painful diminution of vision in the right eye since 2 days, which was associated with severe headache and nausea. On examination in the right eye, the vision was 2/60 with no improvement with glasses. In the left eye, it was 636 with no improvement with glasses. Digitally, the eye was hard. It was normal in the left eye. On Shaw's, it was 54.7 mm of Hg in the right eye, and it was 17.3 mm of Hg in the left eye. Eyeballs and eyelids were of normal shape, size, position in both the eyes. Ocular movements were full in all the gazes. There was a mild congestion present in the right eye, and there was no congestion in the left eye. Cornea. There was generalized haze with a mild epithelial edema in the right eye, and generalized haze with fewer nebular opacities in the left eye. Lens was anteriorly dislocated in the AC in the right eye, and it was mildly cataractous in the left eye, NS2. Phacodonesis was present, iridodonesis was present, and inferior subluxation was present. In AC, in the right eye, it was deep with lens present, dislocated, anteriorly dislocated lens. In the left eye, it was normal. Iris was of normal shape and pattern in both the eyes. Pupil was round, regular, and mid-dilated in the right eye, and was round, regular, and reactive in the other eye. The fundus findings were normal. It was just a little hazy media present in the right eye. The patient was short-statured with stubby fingers. There was no history of hypertension or diabetes. There was no history of any ocular trauma or surgery. As you can see here, there is anteriorly dislocated lens in the right eye and inferonasally subluxation in the left eye. The blood reports were normal. Hemoglobin 13.2, TLC 7600. Homocysteine levels were normal, within the normal limit, and there was no homocysteine present in the urine. The ECG and X-ray were also within normal limits. We can see the patient is of a short height, 144.5 centimeter, and he had brachydactyly present in the fingers. Differential diagnosis, Weil-Marchesani syndrome, secondary glaucoma, it can be due to secondary to blunt trauma, homocystinuria, and Mauffin syndrome. So the diagnosis is right eye secondary glaucoma with bilateral ectopia lentis, most probably Weil-Marchesani syndrome. On admission, because of the raised IOP, we gave tab-acetazolamide 500 milligrams stat, and we also gave injection mannitol 1.5 to 2 grams per kg of 20% solution infused over 30 minutes. After that, we gave tab-acetazolamide 250 milligrams 4 times per day, both eye drop, moxifloxacin, flurbiprofen 4 times per day, and we glaucoma drug, right eye drop brimonidine 2 times per day. Apart from that, syrup glycerol was given 6 tablespoon and half glass lime water with 3 times per day. Surgically, the patient was managed with the right eye intracapsular lens extraction, vitrectomy with ACL implantation. All the glaucoma drugs post-operatively, and after the surgery, the patient gained a vision of 6/12 visual acuity in the operated eye, and there was no rise in intraocular pressure post-operatively. So a prompt control of raised IOP and definitive surgical management in a patient of ectopia lentis and anteriorly dislocated lens with secondary glaucoma helped the patient to gain near normal visual acuity and proper visual rehabilitation. Thank you.
Judges, please note the participant was well within the time limit.
Thank you, Dr. UP. One thing, it was a good presentation, and one thing I would like to ask is, before giving mannitol, what would you do? You can hear me?
Sorry, ma'am, I cannot hear you.
Before giving mannitol to the
Ma'am, your voice is breaking.
What precaution
Ma'am, we usually ask a history of BPH in male patients.
Any kind of would you do a medicine reference, and why? Yeah, so normally you would do a medical reference for clearance with mannitol. You would have to do a cardiogram or an echo because it overloads the intravascular volume and it can be very dangerous. So for every time that you give mannitol, a medical reference with a ECG and if necessary an echo is very necessary, and especially in ectopia lenses, like say for example, some cases would be associated with heart disease also. Like if in this patient, you know, there is no height and it doesn't look like a Marfan's, but there can be ECG changes. So it's mandatory to do a ECG and get a medical clearance before giving mannitol, because when we were residents and in the past, there have been, deaths related to mannitol and the dosage of mannitol. And that is how recently mannitol has been discontinued or used much lesser. So that is one thing that I would like to assist you with. And, and any other choice, like instead of the ACIOL, do you have any other options after intracapsular cataract surgery today?
So, ma'am, scleral fixated lenses can be used, or ACIOL, scleral fixated lenses.
Okay. Okay. Thank you.
Excuse me, doctor. One question. I am Dr. Shanti Pandey.
Good morning, ma'am.
Good morning. You have made the diagnosis of the Weil-Marchesani syndrome. Why not it is the Ehlers-Danlos syndrome? Why not it is Marfan? And why not it is the microspheropecia? What are the causes? Can you elaborate the causes of the
Ma'am, it won't be Marfan's because of the height, as I've already mentioned that the patient has short height and they were brachydactyly present. Ma'am, then when it comes to one more in homocystinuria, I mentioned the levels because of the enzymes I've already mentioned. Then, ma'am, Ehlers-Danlos, ma'am, in Ehlers-Danlos also there is hyperextensibility of joints that is present. The patient gave no such history to us. Further, there is blue discoloration of sclera that is present. We couldn't actually find any of such findings.
Okay. What are the other causes might be possible to the ectopia lentis, for ectopia lentis? What are the other things responsible for that? Other than, why not it is the microspherophakia?
Ma'am, microspherophakia might be the reason. Actually, the lens, the size of the lens, well, it is smaller in size. We can see that there is thick. It might be having a centrally thickness increase. The anterior posterior diameter might be decreased. We tried checking it on the B scan, but we were not able to go to a proper conclusion of was it completely microspherophakia or not. We tried checking it on anterior segment OCT and B scan that the thickness was more than 3.5 mm or not.
Have you done the pachymetry? Have you checked the lenticular thickness or not? Have you? What is the normal size? What is the normal size of the lens?
Ma'am, the diameter is
normal person.
Sorry, ma'am.
Normal person में lens का size क्या होता है? What is the
diameter?
normal size?
Ma'am, the normal diameter.
Just wait. My question for you: what is the normal size of the lens nucleus in a normal adult? And what is the antero-posterior diameter, and what is the other parameters? What are the other parameters?
9 to 10 mm. Ma'am, 9 to 10 mm of diameter. The diameter of the lens normally is 9 to 10 mm. The thickness is 3.5 mm. In a young lens, adult mate is around 5 mm. The central thickness of the lens.
Yeah, there is always be a range. There 3.5 to 5 mm. And
Yes,
have you checked your lenticular thickness or not?
Ma'am, actually, we couldn't do it because the anterior segment OCT and B scan was not functional. So we have asked the patient to come for follow up in the next week, and we would be doing it then.
My question for you: you have made the diagnosis of the secondary glaucoma. What are the glaucoma developed because of the lenses? What do you think? This glaucoma is because of the lens or something else? And why?
Ma'am, as the fundus changes, there were no predominant fundus changes present. So it might be because of the lens positioning causing the pupillary block and leading to glaucomatous changes and pressure change. Right.
Sometimes if I microspherophakia and when your pupil size is small, and what kind of the glaucoma occurs by that? What you reverse glaucoma? Do you know what is the reverse glaucoma?
Ma'am, because of pupillary block, reverse glaucoma.
Microspherophakia only. Okay, well, okay, microspherophakia mein hota. My question for you: how many types of the glaucoma occurs because of the lens? What is the phacotoxic glaucoma? What is the phacomorphic glaucoma? What is the phacoanaphylactic glaucoma?
Ma'am, because of the
phacolytic glaucoma. Most common.
Ma'am, phacolytic is because of the lens particle when they clog the trabecular meshwork, then it is phacolytic glaucoma. If it is an anaphylactic reaction, then it is phacoanaphylactic glaucoma. Then we can have
okay, leave it. And you have done the ACIOL. Nowadays, we prefer that much ACIOL implantation. What are the complications may be possible after that? And we usually not prefer the ACIOL nowadays. Nowadays, trend is not a SFIOL. Most of the person preferring the iris claw lenses. Because if your AC depth is very important, your size of the eyeball is also important. If your anterior chamber is very shallow, high hypermetropic eye, you are implanting the ACIOL. What is the most common complication occur after the AC implantation, ACIOL implantation? क्या हो जाता है सबसे ज्यादा most common complication of the AC lens implantation?
Ma'am, pressure would continue to be raised, so it can lead to
pseudophakic villus keratopathy havelis. Okay, fine. Okay, fine. That's it. Thank you.
Thank you, ma'am. And I think so our discussion has gone a bit longer. So any further questions, if anybody has to ask, can be asked in a very short duration.
Yes. Relating, congratulations for a good presentation, but you have not shown us the post-op photograph.
Yes, sir. Sir, I couldn't take the post-op picture.
So
I
that
had
makes your
gone.
presentation incomplete. And regarding mannitol, Dr. Ragini ma'am already elaborated, but the dose is 1 gram per kg.
1.5.
How much you have given, you have not specified. In one patient, you cannot give a range, no? You said I gave 1.5 to 2 grams per kg. How can you give 1.5 to 2 grams? You can give 1.5, you can give 2.
So we give 200 ml of mannitol to the patient.
नहीं, आपने कहा मेंशन किया है 200 ml. And you have given it IV slowly.
Yes. Yes, sir. So over
Mannitol
30
is
minutes.
given IV fast, no?
बच्चों ने किसी ने नाश्ता किया है?
मैं चेक करूंगी.
अच्छा ठीक है, तो तुम आंटी से पूछ लो, वो जो कहें बस एक चावल बना लो और एक
All
सूखी
right,
सब्जी
okay.
बना लो. बच्चे जो खाएंगे ये चावल जरूर बना लो.
Fine.
तो औलाद रखी तो चावल तो चलेंगे ना. एक चावल और एक हरी सब्जी बना लो कोई सी. पूरा सारा काम
Fine, over to Rima ma'am. Yeah.
Yes, ma'am. Yes, sir. I think all the questions have been asked enough. I don't want to ask anything. Good, beta. Good presentation. Thank you.
I think we can move on to the next resident now.
Yes.
काम करके जाओ.
Smita ma'am, you'll have to switch off your mic.
और आंटी कुछ और बोले तो वो करके जाओ. बस खत्म. आटा बहुत सारा मला हुआ है, रखो.
Dr. Smita ma'am.
Please switch
थोड़े
off
से
your
बना दो.
mic.
बहुत थोड़े से.
Okay, now we are having the last speaker for the session 1, Dr. Ayushi Bansal from Rajshri Bareilly, under the mentorship of Dr. Vimlesh Sharma. Is Dr. Ayushi ready here?
Yes, ma'am, I'm ready. Am I audible?
Yes, you are audible. Dr. Vimlesh Sharma, is she there? Okay. So, Dr. Ayushi, are you ready? You can start sharing your screen.
Yes, ma'am. Okay. Ma'am, is my screen visible?
Yes, yes. No, your screen is not yet visible. Sorry. You are audible. Can you see share screen option?
Yes, ma'am.
Yes,
Is
it has
visible
started.
now? Okay.
Yes.
Okay. Good morning, everyone. Today I'll be presenting on the case report on the topic medial cancers mask a diagnostic dilemma, and I'm very honored to present my college today on this platform. I'll be presenting under the guidance of Dr. Vimlesh Sharma, ma'am, head of the Department of Thyroidology, RMM Bareilly. We have no conflicts of interest and interest to just a minute. Mom, just.
Dr. Ayushi, please share your screen again.
Are you ready? Ayushi, we are not able to hear you. Ayushi, your voice is...
She's not audible, yeah.
She's... check your speaker, check your mic.
Dr. Ayushi, your mic is on mute. Okay. Sorry, ma'am. Sorry for the inconvenience. Today, I'll be presenting a case report on the topic of vital cancers mass, a diagnostic dilemma under the guidance of Dr. Ramesh Sharma, head of the Department of Cellularology, RMR. We have no conflicts of interest or financial interest to disclose. Consent was taken from the parents to use the patient's photographs and medical records for educational purposes. A case report: a 14-year-old female presented in OPD with complete or swelling near the vital cancers of right eye since 1 year, which was non-progressive, painless, and insidious in onset, associated with watering on and off from the right eye, and there was no history of pain, photophobia, headache, diminution of vision, fever, serious mucopurulent or backoid discharge, and there was no history of any ocular trauma. Past ocular history, there was no record documented, and such on personal history, patient was on mixed diet, no history of consumption of uncooked meat or raw vegetables, sleep and appetite normal, power bladder habits normal, and no history of any addiction to substance abuse. On general physical examination, patient was conscious and well oriented to time, place, and person. Vitals were within normal limits, and pyloric teres, clubbing cyanosis, skin retinopathy, and edema were absent. On ocular examination, patient's vision was 6.6 in both eyes, near vision was N6, and on examination of rectangular apparatus, position of puncta was normal, and on right eye rectangular sac area, swelling was present, and plus was negative in both eyes. Left adnexa was normal, and fundus was within normal limits. On syringing, it was found to be patent in both eyes. On inspection, there was swelling that was noticed inferior-medially to medial canthus of the right eye, which was slight bluish and apparent, approximately measuring 2 by 2 centimeters in size and round in shape. And on palpation, cystic swelling was felt inferior-medially to medial canthus of right eye, which was not tender, soft in consistency, free from the underlying skin, no changes in temperature from the surrounding skin, and non-reducible in nature. On consultation with the ENT department, they found no relation between the nasolacrimal of the inferior turbinate on endoscopy, and there were also no signs of any relation of swelling with the lateral wall of nose C. So my provisional diagnosis comes out to be acute acrocystitis, mucocele, and cryocystocele, dermoid cyst, and lacrimal sac tumor. Now further investigation order was CBC. In this, there was nothing significant, and also AEC levels were also within significant limits. RBS and viral markers was nothing significant found. On imaging, CT findings suggested well-defined cystic mass without any intraregional density, and they suggestive of the cryocystocele. On B scan, showed an echoic cystic swelling without any internal hyper or hyperfoci with no internal vascularity, findings suggestive of simple cyst, hence roots of cysticercus. Now management. A patient underwent surgery and a curvilinear incision was given on the site as shown in this video. Okay. Now the mass was excised in toto and measurements were noted with the help of the caliper as shown in the video, and it was around 17 mm into 11 mm. The patency was tested before the skin closure by syringing to ensure there is no damage to the canalicula. Incision by site was secured with 6 vacuum suture as shown in the image, and the sample was sent for histopathology. Histopathology report suggestive of the epidermoid cyst and that the cyst is lined by the keratinized squamous epithelium. Now, hence the final diagnosis comes out to be right-sided epidermoid cyst below the medial canthus. This is a beautiful follow-up picture of my patient after 5 days of surgery. Sutures have been removed under aseptic conditions. Surgical site is healthy and there are no fresh complaints. Take-home message: medial canthus swellings, we think a diagnostic dilemma because of other swellings having more or less similar presentations, and we do not have to fully rely on surgical investigations. Basic history and clinical examination also plays a vital role. Thank you very much. Judges, please note the participant took exactly 4 minutes.
Very lucky. Congratulations. Congratulations, Dr. Ayushi, for a beautiful presentation and well in time. Otherwise, you would have lost precious 5 marks because this is going to be an all India competition and you have to reach the annual WOS conference. So one thing I really appreciate is what you mentioned about taking consent of the parents, because we never pay importance to the medical legal or those implications. And I think it was a very important point to note and a point of learning for everybody. So I really appreciate that slide. And it was a complete presentation with the differential diagnosis, with the surgery, the mass being seen, the post-operatives, a wonderful presentation. I must appreciate it. And of course, the mentor's efforts to do the surgery and to help you with the presentation. It cannot be done without all the teachers present here today. So a big salute to all the teachers here.
Dr. Nilesh, sir.
Yes, congratulations, Ayushi. And this was exactly what I was going to say also, that it is really very essential to take the consent of the patient or the parents as applicable. Congratulations for that. And what are the important structures which can get damaged during such surgeries?
Actually, basically, in this veins and vessels, because these bring the medial cancers and upper lip and the nose. So we mainly have to look after that it should not get danger. It should not get danger.
Yeah, I think I'm not able to hear well to your audio.
Am I audible, sir?
Yes.
So actually, angular veins should be looked after while considering such a mass near the medial cancers, because these are the vessels which drain the medial cancers inside of the nose and upper lip. So we have to make sure that these does not get under the danger.
Yeah, okay. Over to Rima, ma'am.
Yeah, thank you, sir. Very good and a complete presentation, Ayushi. Only thing, your internet is not helping you much today. So, but we are trying to forget that part. Can you tell me what will happen if you don't operate this patient? What is this equally? I don't operate this patient.
Yes, ma'am. Actually, ma'am, in my patient, there was nothing as such infectious, and there was no signs suggestive of any inflammation, and there was no history of any fever also. Only my patient concern was cosmetically. And since we continued further and saw the investigations and clinical history, so she was like mainly considered regarding her cosmetic appearance only. Otherwise, it was a cyst which was cystic in nature, no any history of fever. And
Beta. What will happen in future if you are not? What all can go wrong if you don't operate?
Okay, ma'am, actually, it may be infectious also. Then further in the long run, it may be infectious, which may
Okay.
lead
So
to
secondary
acute
infection. Yes.
cystitis. Yes, ma'am. And it may lead to malignancy also, or mucocele. We can see mucocele also. But ma'am, in my case, there was nothing suggestive of malignancy because there was no crossing of the swelling above the medial tendon.
Yeah. Okay, fine. Very good presentation. Yeah, thank you. All the teachers, I think, have done a wonderful job. This is one of the finest, basket of cases you all have presented. I appreciate teachers and the students. Really great work.
So here we are done with first competitive session, and it was a fantastic session with almost all topics on oculoplasty, and the presenters presented well. We have covered it very much in time, and it's 11:25, and I hope judges are in the process of making the sheets, and I will like to thank the mentors for taking out time for this session. Thank you all the judges, Dr. Ragini ma'am, Dr. Rima Raval ma'am, and Dr. Nilesh Parekh sir for taking out time for the session. And it's now time for our next talk. So I'll like to call upon Manupriya for the next speaker introduction.
Thank you, Dr. Gargi.
Thank you. Thank you so much. Thank you.
Thank you to all the judges, all the
Thank you so
mentors, and all
much.
the speakers.
Thank you. Thank you so much.
I'd still like to request everyone to stay till the end of the session. Dr. Komal, can you please stop sharing your screen? Yeah, thank you so much. All right. So before we move on to the next session, I would now like to invite Dr. Jimmy Mittal, ma'am. Ma'am, are you here?
Yeah, good afternoon, everyone.
Good afternoon, ma'am. So now I'd like to invite Dr. Jimmy Mittal, ma'am, for a talk on Project Shakti. So Dr. Jimmy Mittal is a senior consultant and head at the Department of Ophthalmology at Vivekanand Hospital, Lucknow. She had done her MBBS, MS, Honours in Ophthalmology from MS from KGMU in 2007. She had done a short-term glaucoma fellowship at Arvind Eye Hospital, Madurai, followed by IOL training at AEH, Madurai. Ma'am has worked as a consultant medical officer, anterior segment and glaucoma at Indira Gandhi Eye Hospital till Feb 2011. And ma'am joined Vivekanand Polyclinic and Institute of Medical Sciences as senior consultant from March 2011 till date. Ma'am has been the secretary of Awadh chapter of WOS since 2017, and she has been the joint secretary of Lucknow Ophthalmological Society since 2021. Ma'am has been in academics and teaching DNB and optometry students at VPIMS and has guided and co-guided various thesis and presentation papers and lectures at various national conferences. Ma'am, I'd like to invite you and thank you for agreeing to be a part of this program and for
thank you so much,
enlightening us.
Manu. It's my privilege to be here in such an audience, and I would like to share my screen now.
Yes, ma'am.
Once you stop sharing, I'll be able to
Yes,
do that.
ma'am.
Yeah. So it's good to see 31 participants still showing interest. So just a moment. So is my screen visible to everyone?
Yes, ma'am.
So good morning, good afternoon, everyone. At the outset, I would like to thank Dr. Mohita, Dr. Nilima, and Dr. Manu, and Dr. Shweta again for giving me this opportunity. So I'm here to talk about a very important ongoing project of WOS, which is Project Shakti. So it deals with the identification of workplace harassment issues and how to deal the situation if you ever happen to land in one. So yes, workplace harassment actually exists throughout all types of workplaces. It can be from simple bullying to outright discrimination. It's important to understand workplace harassment or workplace challenge so you can avoid a hostile work environment and have a comfortable and a safe environment to work. So how does harassment affect an individual? It not only affects an employee's productivity at work, her comfort level at work, and safety at work, it also has some long-term effects in the form of physical and psychological effects, health effects, and financial effects. It can also expose an organization or the employer to legal liability if the employer does not handle any harassment case presented to the employer properly. So what are the types of harassment? The most basic types of harassment are the verbal or psychological harassment or the emotional trauma. There are also some serious forms in the form of physical and sexual abuse. So remember, all types of workplace harassment are illegal in nature and they need to be reported ASAP. This is a very important chart showing various types of workplace harassment, which you should all be aware about. Can be in the form of psychological harassment, sexual harassment, third-party harassment, discriminatory harassment amongst your colleagues or senior juniors, personal level harassment, physical harassment, power harassment by the superiors, and cyberbullying also comes under it. So what constitutes workplace harassment? Now, according to the Equal Employment Opportunity Commission, harassment can include anything from offensive jokes, slurs, epithets, or name-calling, physical assaults or threats, intimidation, ridicule or mockery, insults or put-downs by your colleagues or seniors, offensive joke or objects or pictures shown to you at your workplace. So anything which is actually interfering with your work performance can be a workplace challenge or a harassment. So why reporting workplace harassment is important? Now, it is important to understand to report any form of workplace harassment because there might be incidences that others might have already reported similar offenses by similar person or a similar group of people previously also. So making your complaint may either strengthen it further and also give a propulsion to the previously made complaint. So many organizations have formal policies for reporting workplace harassment. So whenever you're getting employed at a new place, make sure you check your employee handbook and talk to the HR department as to how to go about such a case of scenario if it ever happens to you. So it's time to speak up not only for yourself, but also for your colleagues who are going through the similar kind of an ordeal. So Garvin, who's a social activist, has rightly said, if you know someone who's being harassed at work, you cannot lose your job simply by reporting it yourself. So remember, not only are you protected by law from the person who's harassing you at work, but you're also protected from your employer failing to protect you. So it's a moral duty of your employer to protect you from all these kinds of harassment. So what should you do if you feel harassed? So workplace harassment is a very serious issue with a lot of gray areas. So all of you should tread very carefully. So if you witness a crime or experience harassment or challenge at your workplace, it's your moral obligation to report it to the authorities. If you're worried about losing your job in retaliation, please remember that you're always protected by the workplace harassment laws which are in place in every country. So yes, proactive steps should be taken to identify and prevent workplace harassment. Companies, hospitals, institutions should have a person of contact who is easily approachable so that the victims and witnesses can report harassment issues to him or her, and maintaining the anonymity, confidentiality, and sensitivity towards the issue in a very high manner. So how to report workplace harassment? First of all, you need to decide to speak up for yourself. The thing has to come from inside of you that this is enough and I need to speak up. Take up the issue with your family members, your mentors at work, your professional seniors. And if the matter is a very serious one, you can approach a lawyer or a psychologist also. Please be very firm and specific with your approach. Remember that if you are the employer, for example, and an employee comes to you and says that about some unprofessional conduct or inappropriate behavior, please ask your employee to describe the conduct more specifically in a detailed fashion. Keep detailed records of each indiscretion that has happened, the people who were involved in the harassment issue, what was said or done to you, where and when the abuse had occurred. Now document each incident in detail to bring it on record later if it is required, the date, the time and the place of the harassment, preferably through mails or written applications. Now it is important to understand that written applications have a much more value in the court of law in comparison to oral or verbal communication. So it is always better to have written evidence against the problem. Share the problem with the authorities, your colleagues at work, the HR committee at your hospital, and now you have Vishaka committee at every hospital, be it private or government. It is a mandatory committee and all of us should be aware about it. And we shall be having a very important Vishaka committee boardroom meeting in the annual WOS, and request everyone to please attend it because of the current scenarios going on. It will give you an insight how to go about such matters. Then you also have, now you have WOS for all of you. So please evaluate your workplace policies at least once in a year to ensure they are up to date in case such kind of harassment challenge happens to you. So what to avoid? I just briefed you what to do, but what you should avoid when facing a workplace challenge. First of all, do not retaliate, do not lose your temper, do not be angry and shout back or abuse back, because retaliation can escalate the issue immediately and it will often make the matters more complicated. For example, if the person is your senior, he might just complain against you for a disciplinary action. Instead, escalate the issue properly and let your HR professionals handle things from there on. Secondly, do not complain to your co-workers and co-colleagues because your colleagues are sailing in the same boat and they do not have much power to change anything in the present scenario and will likely to water down your version of events if they're asked to testify against the senior. Last but not the least, the most important one, please do not keep quiet and suffer in silence. You have to speak up for yourself, otherwise the only option you'll have is to back out. So you have Project Shakti for all of you. It has a committee of expert panelists, which incorporates a panel of senior female ophthalmologists and male ophthalmologists, a lawyer, a human rights activist, and a member of the National Women Commission and a psychologist on board. So what do we do when we receive a complaint? Well, we at WOS take every complaint in a very serious fashion. We investigate every complaint in an unbiased way. We share and discuss the situation of the complaint made to us with our expert panelists. We maintain total confidentiality and sensitivity towards the issue and also anonymity of the person making the complaint. We try not to make any credibility judgments based on the reputation of the person complaining or the person who is accused of harassment. We'll not assume that the person making the complaint is being oversensitive and over emotional. Every individual is different and reacts to a different situation differently. And we'll not leave it to both the parties to work it out for themselves. We'll actually intervene. And once the complaint has been verified and found to be genuine by our expert panel, we take up the issue with the concerned hospital, institution, authority, requesting for a formal inquiry and required action against the harasser. We'll decide if any psychological, legal, or professional help is required in the matter, and if yes, we'll help the person connect with one. WOS encourages a zero-tolerance harassment policy at every workplace. Why is it important to have an anti-harassment policy in place? Because it will be a deterrent to such future issues. It will outline methods of use in case such kind of scenario arises. It will raise awareness of your intolerance towards unwanted behavior. It prevents legal liability and also strengthens your complaint once we have a policy in place. So remember, all of us deserve a safe workplace. So please feel free to report any kind of workplace challenge or harassment which you are facing at iwosindia@gmail.com. This email is open to everyone. You can share it with every one of your colleagues at work. So we at WOS are here for you, and together we can and we will definitely make a difference. Thank you very much for your patient hearing.
Thank you so much, ma'am, for that wonderful presentation. And my first question was supposed to be how to contact anybody at WOS or anybody. You mentioned it in the second last slide, actually.
Yeah, actually,
iwosindia@gmail.com.
I'll share that email on the chat also, the personal chat also.
Yes, ma'am.
And we're also having a survey which is open since past 3-4 months regarding any kind of keeping the anonymity of the person in place. So Google survey is actually focusing on different kind of challenges which women are facing. And I'll again circulate that survey in that WhatsApp group also. So anyone who wants to share their experience, then can do the survey and get in touch with the meeting and the expert panelists in our on the board here. So I'll share that also in the group, and also this email I'll post in the chat group also. Any other questions, inputs?
Yes, Dr. Jimmy, hi.
Hello, ma'am. How are you?
Yeah, good, Jimmy. So good to hear you, and with your zeal for Project Shakti. I just want to put in a word also here in the same on the same lines. I'm also the chairperson of the Vishaka committee at SRMS Medical College. So everybody should know that, as you already said, Vishaka committee is the government ensures that every institute will have a Vishaka committee, and the Vishaka committee takes up such complaints at emergency. They deal with it the very same day or as soon as possible. It is like an emergency. So whenever, if anybody has any issues, so it is good to go to your Vishaka committee, give a written complaint, as you have already said. But then with so many people in the program just now, some of us may already be on the Vishaka committee or even in the WOS Project Shakti. So one thing I want to say after my experience of dealing with these complaints of harassment, Vishaka committee is specifically for gender harassment.
Yeah, sexual harassment will be more specific.
At workplace, yeah. So, but whenever there is such a thing, out of experience, I'd like to say that it is not always the complainant which is who's aggrieved. Sometimes people don't speak up, and they keep tolerating, and then they are harassed more to this extent that they are being complained against. So it is important that to see both sides of the story every time.
So, ma'am, that is what I highlighted. The committee which we have formed will be looking into it unbiased in a very, we'll listen to both the sides of the parties. And then once it has been mutually, decided that, yes, what the problem was, this is not that the complaint de di gayi hai, so we'll act against the, the person who
has. But it is a good idea to speak up, as you have already said, because, somebody else who's actually harassing you might be complaining against you at the same time.
It can be both ways. And this can be for both the genders, not only female, gender specific.
Correct.
This Project Shakti which we have made, madam, it is basically gender non-specific. So we see a lot of, even the male residents also face a lot of humiliation in certain different kind of scenarios. So they also can come forward with their problems, because it is not basically for female gender, it is for both. And the
Absolutely.
Vishaka basically is now much more in talk because of this current mishappening which happened. And now we
Yes.
want to sensitize and take it up as an opportunity to tell more people about it. Because
Right, right.
issue, at least our residents should be aware of this presence of this Vishaka committee at every hospital. जहाँ पे भी 10 से ज़्यादा employees हैं, Vishaka committee has to be implemented. Guidelines have to be implemented. So that is what we want to just give a large message. More than 10 employees, you need to have. That is what the guidelines say. So that is the thing I want to say. Anything, any comment or any seniors want to say?
गुड मॉर्निंग मैम। मैम इस जो विशाखा कमेटी है इसमें मेल फीमेल सभी रेजिडेंट्स सभी everyone can do the complaint on that portal Vishaka committee.
Yes.
This is specifically for the female or male can complain on that portal?
Anyone.
Ma'am, anyone? Yes, madam. Ma'am, we'll be having a separate session on Vishaka in the annual WOS. पूरा आधे घंटे का we have designed a session on Vishaka guidelines in Project Shakti. So anyone who is interested can register for that.
Okay, मैम उसमें complain करने के लिए prior to that they will do register themselves on that Vishaka committee portal, and after that only they can do the complaint. And
Ma'am, आप जहाँ पे भी
how much time they will take to resolve the?
जैसे मैम ने बोला जहाँ पे भी अब एम्प्लॉयड है हर जगह विशाखा NABH भी कहता है अगर आपका हॉस्पिटल इंस्टीट्यूशन है और आपके वहाँ पे विशाखा कमेटी होना मैंडेटरी है गवर्नमेंट के हिसाब से, आपको कहीं बनाने की जरूरत नहीं है और आपको इमीडिएट आपको कंप्लेंट करने के विद इन 24 आवर्स यू हैव टू टेक एक्शन। वो एक्शन इमीडिएट होता है। इट इज नॉट कि इट इज टेकिंग अ पेंडिंग इंक्वायरी फॉर years and years. It has to be very very immediate and very prompt, the action, after the investigation has been done by the panel who's on board.
Thank you.
Can you hear me, Dr. Jimmy? Good morning.
Good morning, Dr. Hi, how are you?
I'm fine.
Yeah.
So I just wanted to know, at my institution, we don't have on the name of Vishakha, but we have institutional sexual harassment committee.
Maybe in the form of like institutional ethical committee, maybe it might be in that form. But you just need to just, certain institutions don't highlight it. They don't want such kind of, agar koi bhi institution hota hai, which I have found out from my experience, many hospitals keep it in a subdued fashion कि अगर पता होगा कि ऐसा पोर्टल है तो और complaints आएंगी हमारी बदनामी होगी. That is a very very simple way to go. But once people are aware कि हाँ भाई ऐसा है, then people do, you can always ask your institution कि भाई ऐसा है क्या papers पे जरूर होगा, आप जरूर पूछिएगा. Because when I tried to find out at my hospital, there was no paper पे था, but there was no committee in place.
Actually, I'm a part of that committee, sexual harassment committee, but I have not heard this term, Vishakha committee.
Dr. Nilima can help her because she is one of the panelists, and these people, they are sensitized to, how to go about such a complaint is made to you. They have an entire kind of a panel involved. It is not a single person. They have a committee to look into the matter.
I have
So that is why I'm saying this Vishakha per se, I was not aware since 2 years back. I just got aware when I started this Project Shakti, when I got into it. Even I was not aware. So this is the main aim of our Project Shakti, to make people aware of this problem, and they need to speak up. They just can't keep quiet and go on with their lives, suffering in silence. And Dr. Nilima would definitely can give more light into it, I'm sure. So
yes, I'll be happy to help, Dr. Rajvinder. So thank you so much, Dr. Jimmy.
Thank you.
And it's a thing, all women connect with. And
Good
Dr.
morning, ma'am.
Manupriya, I
have
think
one question, please.
you can take up
Hello?
so that we don't.
Hello.
Hello.
Ma'am, myself is Dr. Aprajita Chaudhary. I am the chairperson of this Vishakha committee in ophthalmology department of MLN Medical College.
Great, great. Yeah.
Yes, ma'am. Ma'am, we have got a full committee, Vishakha committee, and we have got a member.
Dr.
Is it
Nilima,
mandatory to have one of the member is from the NGO in that committee?
Yes, the Vishakha committee definitely gives an important kind of.
Your voice is breaking. It's not audible.
Having a committee, you need to have certain government representatives also, and they should be from from your hospital, from other hospitals also. They have a representative, so that it is
how
not a
many
biased
members should
inquiry.
be there? And
आपकी inquiry biased ना हो, आपके hospital की inquiry यदि होगी तो आप biased होगी उसके लिए. तो इसके लिए एक एक्सटर्नल मेंबर जरूरी होता है. बाकी की डिटेल्स विल बी शेयरिंग ऑन दैट. We are planning a webinar also, so we can share that and you all can join in as a panelist, or your comments are very, very welcomed there.
Ma'am, what is the way when after preparing a one committee, what is the way to spread in a hospital there is some number is there, or what is the way to contact the sufferer with this committee?
Madam, you can have a awareness kind of a talk and tell people about. If you're the chairman, you can always have some kind of a session with the residents or the nurses or everyone who's involved. You can just have a small session at high tea with them and just spread the awareness that like we do in glaucoma.
Actually issue is this कि जैसे हम कमेटी बना लेते हैं, लेकिन जैसे अभी भी इशू ये आ रहा है कि लोगों को पता नहीं होता कि हमारे यहाँ ये कमेटी है भी
जी,
तो उसको हाइड करके रखा है. जैसे इसको हम कैसे हाईलाइट कर सकते हैं कि हाँ हमारा माय इंस्टीट्यूट इज द इंस्टीट्यूट इज हैविंग द विशाखा कमेटी, एनीबडी कैन कम एंड दे कैन रजिस्टर द कंप्लेंट फॉर दैट.
जस्ट टेक अप द इशू ऑफ जो अभी कलकत्ता में हुआ है, उसको एक एग्जांपल लेके आप अपना बता सकते हो कि जैसा वहां हुआ, वी डू नॉट वांट दैट काइंड ऑफ सिनेरियो टू हैपन इन आवर इंस्टीट्यूशन एंड आई वांट टू गिव एन अवेयरनेस टू the people in my department or in my hospital. You can just start a webinar or a meeting, a small
or you can just put out a circular to this
that's
effect.
all.
Put out a circular with your mobile numbers and your names.
Circular the people will going to be forget. Actually there is some way
I don't think so. Also
the people is reading actually.
एंटी रैगिंग कमेटी होती है, उसके भी
हाँ एंटी रैगिंग कमेटी का, लेकिन एंटी रैगिंग कमेटी का डिस्प्ले होता है, एक नंबर होता है,
हाँ बोर्ड्स वगैरह लगते हैं,
वो बोर्ड लगते हैं, उसको मतलब हाईलाइट किया जाता है कि हाँ दिस कॉलेज इज हैविंग द एंटी रैगिंग कमेटी. तो विशाखा कमेटी के बारे में ऐसा लोगों को इसीलिए पता भी नहीं चलता है.
विशाखा कमेटी का कोई सेंट्रलाइज नंबर तो नहीं है मैडम. इट हैज टू बी ऑन योर इंस्टीट्यूशन पैनल. आपका इंस्टीट्यूशन पैनल पे आएगा और उसमें आपका एक्सटर्नल मेंबर होता है. आप उसको हाईलाइट करके इंस्टीट्यूशन के अंदर ही कर सकते हो अपना काम जो कर रहे हो. इट इज इंस्टीट्यूशनल लेवल. इट इज नथिंग लाइक दैट यू हैव टू गो थ्रू द गवर्नमेंट. हाँ, गवर्नमेंट की मैंडेटरी गाइडलाइंस है कि जैसे NABH एक्रेडिटेशन इज मैंडेटरी, वैसे ही विशाखा भी मैंडेटरी गाइडलाइन है जो कि इम्प्लीमेंट होना चाहिए. उसके लिए यू हैव टू टेक अ स्टेप एंड यू हैव टू अवेयर. जैसे मैडम कह रही है पैम्फलेट्स के थ्रू, और मे बी यू कैन गिव अ सर्कुलर और यू कैन हैव अ स्मॉल मीटिंग कि विशाखा कमेटी की मीटिंग हो रही है, everybody can attend and then you can highlight.
See, I can tell you, Vishakha committee has to meet once in 3 months, even if there is no complaint. Exactly. If there is a complaint, they have to meet immediately. So whenever you have a meeting, they send out a circular that a meeting of Vishakha committee was held. These are the members, these are their contact numbers. So you can, if you send out circulars regularly, so I'm sure everybody will know. And they will be circulated to all departments, all staff. So that is a very easy way of doing it.
You can take an initiative and then it will follow every 3 months form, and that will
people. And then you can do anything.
Okay.
Thank you. I think.
Thank you.
Yeah.
Thank you, Dr. Jimmy Mittal, ma'am. That was a very interesting talk, followed by an even more interesting discussion.
Yeah, most welcome.
I would now like to start with session 2. All right. So first, I would like to introduce all the judges for the session 2. So Dr. Vinita Ramnani, ma'am. Ma'am, are you here? Dr. Vinita, ma'am. Dr. Vinita, ma'am, are you here? Dr. Rajwinder, ma'am, are you here, ma'am? Hello? Am I audible? Yes, ma'am.
Yes, you are audible.
Yes, ma'am. Dr. Vinita, ma'am, are you here, ma'am?
Yeah, I am here.
Yes, ma'am. Good afternoon, ma'am.
Thank you so much.
Yes, ma'am. So I'd like to introduce the 3 judges for session 2. Dr. Vinita Ramnani is the HOD at Eye Department at Bansal Hospital, Bhopal. She has done her MBBS, MS, and she's done a glaucoma fellowship from LV Prasad, Hyderabad. She is the chairperson scientific committee of MP State Ophthalmic Society. She has been the past secretary of Bhopal division of Ophthalmic Society. She has more than 30 years of professional experience in clinical work and performed more than 30,000 eye surgeries. She also has various publications in various index journals. She has been invited as guest faculty in various national and international conferences. And she has received several academic awards like Shri Narsingh Bahadur Award, Shri Sadguru Seva Sangh Chitrakoot Best Video Award, among others. Welcome, ma'am. Now moving on, our second judge for the session is Dr. Rajwinder, ma'am. So Dr. Rajwinder is the professor and head at Adesh Institute of Medical Sciences and Research at Bhatinda, Punjab. She is also the managing editor of Adesh Journal of Adesh University. She is the executive member of Punjab Ophthalmic Society and also the executive member of WOS, Punjab Ophthalmic Society, and MSICS. She has great interest in research-related activities. She was the winner of Best Free Paper Award in WOS 2017, DOS 2020, and IGO Platinum Award for being co-author in the Cosmic Study. She has various publications in Index Journal and has contributed in the Cosmic Study. She also has a special interest in retina. Welcome, ma'am.
Thank you.
Thank you, ma'am. All right. So our third judge for the session is Dr. Sanjay Thakur, sir. Sir is the HOD of Ophthalmology at College of Medicine and Sagor Datta Hospital. He has several awards, including the International Ophthalmic Hero of India at AIOC Kochi, the Srimati Satyarani Hazra Memorial Award given to him in West Bengal. He has 52 publications, including 39 in peer-reviewed index journals with more than 400 citations. He's the ex-international expert for National Institute of Health Research and NHS UK. He has also been the ex-reviewer of Clinical and Experimental Ophthalmology and the Nepalese Journal of Ophthalmology. He has been invited as chairman, judge, convener, guest speaker, moderator, panelist at more than 100 international, national and state conferences and CMEs. He has been the assessor for NMC and the NBEMS, and he has been invited as MS, MD, DNB and DO MBBS examiner at 17 universities across 14 states. Welcome, sir. Dr. Sanjay, sir, are you there? Sir, your mic is off. Yes, sir.
Thank you.
Yes, sir. All right. So now we are going to begin with session 2. Okay. So judges, I hope all the participants and the mentors are here. First, I would like to call upon Dr. Sameen Mansoor Mirza from AMU Aligarh. Dr. Sameen, are you here?
Yes, I hope I'm audible.
Yes, Dr. Sameen will be presenting under the mentorship of Dr. Shazia Arim. Dr. Shazia, are you here?
Yes, I have already joined.
All right. Dr. Sameen, you can share your screen and start presenting.
Okay, thank you. It's showing that someone else is already sharing, so I'm unable to proceed.
Sorry. I'm so sorry. Yeah, you can share now.
Just a minute. Okay. Good afternoon to everyone. I'll be presenting on the topic Occam's razor in a case of proptosis under the moderation of my supervisor, Dr. Shazia Ali. So our patient was a 30-year-old male who presented to us with the forward bulging and upward deviation of the right eye along with swelling of the right eyelids for the past 3 months. This was associated with double vision, discomfort on the right side of face along with watering from the right eye. And for the past 1 month, the patient also experienced diminution of vision. So for these complaints, the patient visited an eye hospital 2 months back, for which he was given lubricating eye drops and advised a CT of the brain and orbit. And it was diagnosed as a case of bilateral acute mastoiditis with pansinusitis, and then he was referred for an ENT consult. He was prescribed oral antibiotics and anti-inflammatories, but no relief was obtained. And 1 month back, he presented to us with diminution of vision. 1 month back, he developed a diminution of vision with increase of the swelling around right eye and watering from the right eye. and there are no other systemic complaints, there's no other medical history, there's no history of trauma, no significant family history, but the patient is a BD smoker for the past 8 years. He's been smoking 10 BDs per day. In the examination, just a minute. The general examination was within normal limits. The systemic examination revealed that there was reduced sensation over the cheek as compared to the forehead on the right side of the face. And on local examination, as we can see in the photo, there is a bulging forward of the right eye straight ahead as compared to left eye. So in the right eye, the upper lid and lower lid show swelling with lower lid retraction, and inferior scleral show. And HBCR was at the inferonasal pupil margin with a grade 1 RAPD pupillary reaction. So this is how we see our proptosis. And in the ocular movements, we can see that in the supraversion and infraversion, along with all the dextro gazes, dextroversion, dextro elevation, dextro depression, there is limitation of movement in the right eye. The uncorrected visual acuity was 612 in the right eye, and after correction it was 69 with a correction of -1 diopter cylinder at 180 degrees. Near vision was normal, color vision was nearly normal. Contrast acuity was reduced, he could only read up to 20%. Intraocular pressures were normal, and differential tonometry showed no significant difference. Schirmer test was normal, 1 was normal, while Schirmer test 2 was abnormal. Hertels showed a proptosis in the right eye, and lid lag and lagophthalmos was absent. In the slit lamp examination, we can see that there's a mild superficial congestion of the conjunctiva with a grade 1 RAPD. Corneal sensations were seen, and in both eyes it was intact and symmetrical. Visual fields on confrontation was same as the examiner. Cover test showed that the right eye was moving downward and inward to take up fixation on covering the left eye. On assessing the quantum of deviation, we saw that the secondary deviation is more than the primary deviation, as is seen in a non-combatant squint. This was a strabismogram which revealed a right eye hypertropia and a small amount of exotropia as well. The Worth 4-dot test revealed a vertical diplopia, and the diplopia charting shows that the maximum separation of images is taking place in the dextro depression. In the force duction test, the right eye showed that the depression was restricted while all other gazes were free. Fundus examination was unremarkable in both eyes. The blood tests were done and hemogram was normal, but mild eosinophilia can be seen. 9% eosinophils were there. Thyroid profile was also done and was normal. So based on the history and examination so far, our initial provisional diagnosis was thyroid-associated orbitopathy. Since the patient is in his 30s, it was an insidious, chronic, and gradually increasing proptosis, and it's also the most common cause of proptosis in adults, unilateral or bilateral. There was periocular swelling, there was restrictive strabismus, diplopia, there was evidence of optic nerve dysfunction, and the patient was also a habitual smoker, which is a known risk factor. But the fact was that bilaterality is more commonly seen. Lid retraction was not there. There was no congestion around the extraocular muscle insertions, and lid lag and upper lid retraction, which is classically seen, is not seen in this patient. Battery of other differential diagnoses were made, such as these, as you can see on the screen. This was orbital sarcoidosis. I'm sorry, I think it has disappeared from here. Orbital sarcoidosis, lymphoma, varix, and meningiomas. This, and last but not the least was cellulitis was also added, but since it was acute and an inflammatory condition, we put it very down in the list. So initial provisional diagnosis was thyroid-associated orbitopathy, and we advised MRI brain with orbit. So the first image that we see on the left is a T2 weighted image, and the other two are T1 weighted images. And as we can see, as I've marked over here, bulky bellies of the inferior rectus and lateral rectus are seen, and there is sparing of the tendinous insertion. So that is what is causing the crowding at the orbital apex and compression of the optic nerve. And but what is different here is that lateral rectus is early involved. So that is deviating a little from thyroid-associated orbitopathy. Next, we evaluated and we noticed here that the right pterygoid muscles appear slightly bulky as compared to the left over here.
Sorry, Dr. Samin, you need to wind up. You have already exceeded the time limit a lot.
Yes.
So just finish
and we can also see the expansion of the right Vidian canal and the intraorbital foramina here. and expansion of the right median canal with the thickening of the infraorbital nerve within it. So the chest X-ray was advised, and based on us on the MRI findings, we did an serum IgG4, and provisional diagnosis of IgG4 related ophthalmic disease was made due to gradual painless progressive proptosis, and there was early involvement of lateral rectus, the involvement of the infraorbital nerve, that is involving the trigeminal nerve, and there was sparing of tendinous insertions. So these factors were going in favor of maybe an IgG4 related disease. Even though IgG4 is normal, it is seen in 40. This is seen in 40% cases, even with biopsy proven disease. So our plan of management was right eye extraocular muscle biopsy, but the patient has not returned to us so far. Thank you.
All right, I would like to remind the participants again that you have marks for time. All right, so please stick to the time limit, that is 4 minutes. Judges, please note the participant took 6 minutes in total for the presentation. I'd now like to invite Dr. Vinita to start the discussion.
Dr. Sameer, how do you grade proptosis?
It's graded as mild, moderate, and severe. And
how do you grade it? What is the values for mild, moderate, and severe proptosis?
Proptosis is said when on Hertz you have a reading of more than 21 mm. So up to from more than 21 to up to 24 is mild, 24 to 26 moderate, and more than that is a severe proptosis. So that's what I remember. Yeah.
And you said RAPD grade 1. So how do you rate RAPD?
Yes, normal pupil reaction, you initially have a constriction followed by some oscillatory movements till it finally adjusts to the light. So in this patient, there was an initial constriction followed by there was a pupillary stall, sorry. There was initial constriction followed by a greater redilation. Yeah.
And what is grade 2 and grade 3 RAPD?
Then you have a pupillary stall followed by the greater redilation, and grade 3 you have a direct redilation. You don't even have the stall.
Okay. And you mentioned the force duction test. So can you elaborate? How do you do the force duction test?
I had initially taken consent of the patient and I described the procedure to him. So it was done under topical anesthesia, and I took a toothed forceps with both two forceps I took. And after instilling anesthesia, I asked him to look in the direction of the weaker muscle. That was, I was suspecting, because elevation is reduced. So I was asking him to look down. So I asked him to look down as much as he can. And then I grabbed the eyeball from the limbus on both sides, and I tried to push the eyeball down further. So I was not able to move it down. There was a resistance to moving it down further.
Okay. So from my side, as far as examination is concerned, this is okay. Probably the next judges can ask on a differential diagnosis.
Yes, ma'am.
So, you are telling me in this case that color vision and RAPD was present.
Yes.
Then from these two things, what do you suspect? When the color vision is
optic nerve dysfunction, because even the color vision, he was able to, out of 38 plates, he was able to read 36 correctly. So yes, there is definitely a deviation from the normal, but it's still, but contrast was also reduced. Contrast was significantly reduced. There was RAPD. So I'm expecting that because of the pathology, there was compression of the optic nerve, and that is why he was having diminution of vision, then RAPD and all these things.
The second thing, how you differentiate the pseudotumor and the thyroid ophthalmopathy on the MRI?
On the MRI. Ma'am, usually thyroid ophthalmopathy, when it involves the extraocular muscles, it spares the tendons, and you can see a fusiform enlargement. The tendon appears normal, but the belly is enlarged. But in orbital pseudotumor, it is a diffuse enlargement. There's no sparing of the tendon. So this is the main difference between the two.
Okay, the patient could not come back, but you gave him some oral medication or the oral medication in the form of something? Waiting for the biopsy only.
Yes, no, we were actually waiting for the biopsy. So oral medication was not given. For the congestion, he was given topical ketorolac and lubricants. That's all. So we had advised him that he would be, if the diagnosis comes out to be the one that we're suspecting, he would later be receiving steroids for treatment. But at present, oral treatment was not given to this patient. So he wanted to seek a second medical opinion. So for that, he did not come back to us.
Okay. Okay. That is done from my side.
Dr. Sanjay, sir?
Yes, I have a question regarding examination. You said contrast sensitivity was 20%. How did you measure the contrast sensitivity?
That was not actually a contrast sensitivity. The one that was done was a contrast acuity, that he could, the normal acuity that a person can read with the normal vision is up to 5%. That is the minimum contrast that he can read. And this patient, he could, from the left eye, he could read even the least contrast. But with the right eye, he could only appreciate up to 20%. But with contrast acuity, there is no actual grading or classification that can distinguish normal from abnormal. So, yeah.
No, but how did you measure? I'm still not clear.
Yes, this was actually done on the screen where we usually perform our refraction. And over there, each line, is like the highest contrast represents 100%. And from there, each line keeps on decreasing in contrast and it reduces by 10% each.
So what chart did you use? What chart did you use?
It was not a Pelly-Robson. It was not a Pelly-Robson. It was a slight variation of it.
Does it have any name?
I actually tried to find out and there was no name for it.
What is the instrument where you can measure this contrast 100% and 20%? What is this instrument?
Sorry, I don't remember. Sorry.
Okay. Now, another question regarding differential diagnosis is that based on your MRI picture, when you saw that there is a muscle involvement, so what is the differential diagnosis you make after seeing that MRI picture based on the muscle involvements?
Yes, the first differential that we had in mind was thyroid-associated orbitopathy because there was a tenderness sparing. The belly of the muscle was inflamed. It was quite boggy. So an inferior rectus was involved, which is seen in thyroid-associated orbitopathy. So that was a first differential. But what was different in this was that lateral rectus was getting involved very early in the disease. Usually in thyroid, you have an involvement of medial rectus.
You please tell me that you have already told. You tell me what is the other differential diagnosis you had in mind?
Yes, other differential also include, it could be some it could even be, since he's a young male, he could have orbital sarcoidosis as well. So it could be orbital sarcoidosis. There could be an intraconal orbital mets could be taking place. There could be intraorbital lymphoma also that can cause a diffuse infiltration of the muscles and it could cause enlargement of the muscles. There could be orbital pseudotumor is a possibility, unilateral proptosis in a young male. Orbital pseudotumor could be there. Orbital cellulitis could be taking place. Inflammatory swelling could be one reason. And then there is orbital sarcoidosis. Orbital schwannomas also tend to cause diffuse enlargement of the extraocular muscles. So yeah.
But most of these differential diagnoses which you are mentioning will not involve pterygoid, but you showed pterygoid involvement also.
So that is where our suspicion rose that it cannot be these differentials, so it has to be something else. So when we explored further, we saw that even the right pterygoid is getting inflamed. It's getting there's an increase in bulk, and even the infraorbital nerve is getting involved. So these findings were finally more suggestive of maybe an IgG4 related disease. So that is how we reached to that differential.
Thank you.
All right. Thank you, Dr. Samin. Thank you, judges. We will move on to the next presentation now. Judges, please note that the second participant from AMU Aligarh, Dr. Karuna Shri, she will not be able to present today. Okay, so she's not going to be participating. So judges, please again note, Dr. Karuna Shri is not presenting. So I'll now like to call upon Dr. Komal Priya from MLNMC Prayagraj. Dr. Komal?
Am I audible?
Yes, you are. Dr. Komal will be presenting under the mentorship of Dr. Prajata Chaudhary. Dr. Prajata, are you here, ma'am? Dr. Prajata, ma'am?
Yes, ma'am. I'm here.
Yes, ma'am. Okay, ma'am. Okay, Dr. Komal, you can share your screen and start your presentation now.
Is it visible?
Yes, it is.
Okay. Good morning, everyone. The topic of my case presentation is bilateral spontaneous anterior dislocation of the lens. I'm Dr. Komal under the guidance of Professor Dr. Prajata Chaudhary. She's the director and the HOD at Rio Prayagraj. So the patient was a 42-year-old male who was a resident of Pratapgarh. He came to our OPD with the chief complaints of redness, watering, blurring of vision, and pain in the left eye from past 1 month, and there was no history of trauma or no significant past history or medical history that was present. On examination, the uncorrected visual acuity in the right eye was finger counting at 3 meters, and in the left eye was hand movement. The projection of rays was accurate in all the quadrants. The intraocular pressure by the non-contact odometer in the right eye was 22 millimeters of Hg, and in the left eye was 34 millimeter of the Hg. The slit lamp examination findings in the right eye showed that the cornea was clear, pupil was mid-dilated, clear crystalline lens was dislocated into the anterior chamber after full dilatation of the pupil, which is reducible. There was no visible anterior zonal or fibers seen, and on gonioscopy, it showed that the angles were completely open. This is the picture which showed that in the first picture, we can see that the lens is well behind the iris, but in the left, on the right side of the picture, we see that when the pupil was completely dilated, the lens has dislocated into the anterior chamber. On the left eye, the conjunctiva was highly congested and the diffuse full thickness corneal edema was present. The pupil was not reactive and the clear crystalline had already been dislocated into the anterior chamber with the lenticular corneal touch and with the absence of zonules. The lens in the anterior chamber led to the pupillary block. The fundus examination in the right eye showed increased cup disc ratio of 0.6 in the vertical and 0.5 in the horizontal. And in the left eye, the fundus examination showed increased cup disc ratio with cupping of 0.8 in both vertical and horizontal. The B scan was done and the posterior segment was normal in both the eyes. With the above clinical examination and the history, we had 4 differentials in our mind. That was Marfan syndrome, Ehlers-Danlos syndrome, Weil-Marchesani, and homocystinuria. For that, we evaluated the patient for the other system. The patient had a tall stature. There was no skin laxity or joint hyperextensibility present. There was a negative thumb sign, arm span width, wrist sign, and no arachnodactyly seen. With the physician's reference, the cardiac evaluation was done and no abnormality was found. This is the evaluation of the patient. The patient had the Marfanoid habitus, but they did not fulfill the criteria of the systemic features that are present in case of the Marfan syndrome. We underwent the patient for the routine investigations, which was normal for the routine investigations. And in order to rule out homocystinuria, we underwent the patient for the serum homocysteine levels, which were around 114 micromole per liter, and the urine homocysteine levels were also positive. The initial management in the right eye was that with the gentle pressure, the cornea led to the repositioning of the lens behind the pupil, and the patient was then administered pilocarpine, and a laser peripheral iridotomy was performed to prevent the pupillary block glaucoma. As we were not able to perform the same procedure in the left eye, we needed to decrease the pressure. So we underwent the pressure with the patient with the intravenous mannitol of 350 ml. Topical hypertonic saline 5% was given 4 times a day. Anti-inflammatory prednisolone was given 1% 3 times a day. And to ocular hypotensive drugs like Dozox was given 3 times, and Provoprost Irux once at night. Under the coverage of the antibiotics, we planned the patient for the surgery without any delay. As the patient had homocystinuria was present, so we gave the patient sent the patient for the physician reference, in which the patient was started with pyridoxine and other vitamin supplementation of B9, B12, and betaine. We planned the surgery for the patient with lensectomy with anterior vitrectomy with iris floor lens implantation in the left eye after the control of the intraocular pressure with mannitol. The surgical treatment consisted of the MVR blade assisted 2 limbal entries at 10 and 2 o'clock positions. The blade was further advanced into the lens to create 2 stab entries in the lens capsule near its equator. A viscodispersive separation was done between the corneal endothelium and the anterior capsule of the lens. Bimanual irrigation aspiration of the lens matter was performed in the bag. The capsule was peeled with the help of the intravitreal forceps, followed by its removal with vitrectomy cutter. Limited anterior vitrectomy with ICL implantation and peripheral iridectomy was done, and the anterior chamber was formed with the air and the balanced salt solution. This is the post-operative day 1 picture in which we can see that the mild corneal edema and few Descemet's folds were present. The fundal lobe was present in the patient, and the air is well in the chamber is well formed. The first post-operative day, the visual acuity in the left eye improved to 3 meters in the left eye. After 2 weeks follow-up, the best corrected visual acuity in the right eye was 624 with minus 1.5 diopter spherical and 1.25 diopter cylindrical at 140 degree. And in the left eye, the patient had best corrected visual acuity of 6/60 with minus 2 diopter spherical and minus 0.75 diopter cylindrical at 90 degrees. As we know that the homocystinuria is a genetic condition, so we evaluated the patient for the history, in which we saw that the patient had a consanguineous marriage and his parents also had a consanguineous marriage. We could not elicit the history of the others, his sibling, but the significant history that he had 3 offsprings and all of them succumbed at a really young age. So my provisional diagnosis was homocystinuria with bilateral anterior dislocation of lens. So why this case was unique? Because anterior, mostly in homocystinuria, the majority of dislocation is present, that is inferonasal. But in our case, it was anterior dislocation, which is present in only 10% of the cases. The usual presentation is in the younger age group of 5 to 10 years. And even if it is adult, it is usually diagnosed by the age of 25 years. But in our case, the patient presented alone with the ectopia lentis at 42 years of the age. All his offsprings passed at a very young age. Probability of these genes running in the family is very much likely. Genetic counseling would help in early diagnosis and treatment to prevent the mortality. Thank you.
Dr. Komal, you exceeded the time by almost 2 minutes.
All right. We should start the discussion now. Dr. Vinita, ma'am.
Yes, well presented. I just wanted to know what is the type of dislocation normally you see in Marfan syndrome?
Marfan syndrome, ma'am, superotemporal dislocation is mostly common. Ma'am, the most thing important in Marfan syndrome that the complete zonal, because of the fibrinil gene that is affected, there is stretching of the zonules. So the dislocation can happen at superotemporal, superonasal, but the most common one is the superotemporal dislocation.
And why do you think that? What is the cause for the late presentation in your case? It's already very late presentation as well as the late stage of the disease. Like he was presented very late in the left eye.
Yes, ma'am. Firstly, ma'am, the patient came from a very low socioeconomic background. When the patient had already presented his eyes, when we evaluated the history, he said that he used to experience some kind of the pain in both his eyes, but he did not visit any of the ophthalmologists in the past. And when the problem became very severe, then only he visited to our hospital, in which we had seen that the disease has already progressed to an extent that the secondary glaucoma had developed in his left eye, in which the lens was completely dislocated.
And what did you do for the secondary glaucoma? Like, did you recorded the perimetry of that eye and the subsequent IOP visits, because you have to take care of in post-op IOP also?
Yes, ma'am.
You could have put an perimetry picture once you had the vision recovery in post-op period.
Yes, ma'am, because ma'am, patient was like initially the patient had hand movement vision, and when it increased to 3 meters, the vision improvement was 660, but the patient was amblyopic. We tried to perform the perimetry in one of the visits, but we did not get the conclusive results as the fixation losses were present. And we see that the peripheral iridotomy was prophylactically done in the right eye, and in the left eye we have already done the peripheral iridectomy. We are following up the patients, and at every visit we are recording the vision and we are assessing his the intraocular pressure, so that we can keep a check on whether the disease is further progress in the right eye. And if it does, because as we can see that right eye also, the lens was easily dislocated into the anterior chamber. So in future we plan, if it is done, then we can plan for the pars plana vitrectomy and 3-piece IOL implantation.
Okay, thank you.
All right. Dr. Sanjay, sir?
Yes, I just want to know, why don't you think this is a case of spherophakia?
So spherophakia is a condition in which the size of the lens is smaller, and because of which it gets dislocated. So the corneal diameter and the lens diameter and thickness was well within the normal limits. So this was not a case of pharophakia.
Okay. Now, while doing surgery in the left eye, you mentioned that you did a capsulotomy and then irrigation aspiration.
Yes, sir.
And then you removed the capsule, right?
Yes, yes, sir.
Was it done with dilated pupil or constricted pupil?
So initially, because the patient was, when we presented, the patient was dilated, but while performing the surgery, we tried to instill the pilocarpine, but the pupil did not react to that also. So it was done in the dilated pupil, and careful capsulorhexis was done. And the capsule of the anterior capsule was well adhered to the posterior surface of the cornea. So we had to first do a capsulorhexis, which was very difficult because none of these zonular attachments was present in the left eye. And after that, we did the capsulorhexis and we removed the lens, but the pupil was mid-dilated. It was not constricted.
No, you're saying anterior capsule was adhered to cornea.
Yes, yes, sir. Because while we were performing the separation was being done between the anterior capsule of the lens and the cornea, so we were facing difficulty, and we saw that the part of the anterior capsule was adhered to the posterior part of the cornea.
So you still could manage to do rhexis.
Sir, partly because we had put 2 stab entries at the and we advanced into the capsule from the lateral entries, and we separated then with the vitrectomy cutter we separated the capsule.
No, so did you do rhexis with the rhexis forceps, or you did it with the vitrectomy cutter?
We did it with the vitrectomy cutter because sir, we were not able to perform the usual rhexis in this patient.
So this was not the usual rhexis. This
No,
was
sir.
restricted rhexis.
Yes, sir.
Okay. So what were your plans in case the bag falls?
So
what were your backup plans?
So backup plan was that if we could have approached the patient from the posterior approach by doing the pars plana vitrectomy, but we could not perform this because of the adherence. So if the nucleus would have fallen into the vitreous, we would have underwent the patient for the vitrectomy, pars plana vitrectomy.
Okay. What was the post-op status of the cornea?
So the post-operative day 1, we experienced that the corneal edema was high and few Rismith folds were present. But in the consecutive post-op visit, we see that as the IOP is well within control with the prophylactic peripheral iridectomy that we done, and as the patient is on ocular hypertensive drugs, so the corneal edema has subsided to a significant limit from the presentation of the first post-op day.
I meant endothelial status.
So endothelial status was compromised initially. Also, in patient when presented had a initial corneal decompensation was present.
You have the counts.
Yes, sir. It was around 2,300, sir.
Pre-op or post-op?
Post-op, sir. Pre-op we were not able to do it.
So post-op, you mean to say the endothelial cell count was 2,000. And what about polymegathism and other criteria besides the cell count? Coefficient of variation and polymegathism, because they are more important rather than the count itself, absolute count itself, since the anterior capsule was adherent to the cornea.
Yes, sir. That we do not evaluate.
Okay, thank you.
Dr. Rajvinder, ma'am.
It was the good case discussion actually. So what is the reason for dislocation in these cases?
Ma'am, the most common dislocation in homocystinuria is that there is a complete zonular dehiscence, which happens mostly because of the increased homocysteine levels. It prevents the cross-linking, that is collagen cross-linking, that is important for the zonular strength. And also there is decreased cysteine levels, which is present in the zonular fibers, which makes them weak. So in this patients, like this differentiates from the Marfan syndrome, in which there is a stretching of these zonules, but still the zonular fibers are still present. So, but in the homocystinuria, we see that the majority patients have no zonules are present.
Okay. So in one eye, it was anteriorly dislocation, huh?
Yes, ma'am.
In the other eye, what was the diameter of the lens?
Ma'am, diameter of the lens was 4 millimeter. Sorry, was 8 millimeter.
Diameter of the lens.
Yes, ma'am.
And you
Diameter.
could see, you could see the margin of the lens?
Yes, ma'am. Complete margin of the lens was visible. Yes, ma'am.
So it means it must be then microphakia or
Ma'am,
microspherophakia.
9 to 10, 8 to 10 millimeters of the lens diameter is normal.
You could see the golden ring, na? In the
Yes.
other eye.
Yes, ma'am.
So it means the lens must be small. Then only you can see the golden ring of the lens.
Yes, ma'am.
Then it is only the anterior dislocation.
Yes, yes, ma'am. In the right.
Yes, in the left eye, what was the refractive status of the, as the lens was in normal position behind the iris only. So what was the refractive status of that eye?
It was with the best corrected visual acuity was 624 with the correction of -1 diopter spherical and -1.25 diopter cylindrical at 140 degrees.
So normally these cases, they have high degree of myopia.
Myopia, yes, ma'am. Yes, ma'am.
So what was the axial length of the eye?
Axial length of the eye was 26 millimeter in the right eye, and in the left eye was 27.34.
So what was the power of the lens which was used?
14 diopter.
14 diopter.
Yes,
14 diopter. So what was the diameter of the cornea? They usually have the bigger cornea these days.
No, ma'am. We have the bigger cornea, but the cornea was within the normal limits of 11.5 in the vertical and 12 millimeter in the horizontal diameter.
So in your case, if we want to prevent the endothelial damage, what can be the other options in the surgical management?
Yes, ma'am. In order, because in these patients, because the cornea was already decompensated, we could have planned the patient from a posterior approach in which we could have planned for the pars plana vitrectomy, and the cornea could, the lens could have been extracted. But as we saw in our case, there was presence of the adherence, so we had to approach from the anterior.
Okay, but there is some other option also in which you can take out the lens from the cornea, that is by doing ICC, and then you could have planned that is iris fixated or that lens.
Scleral fixated lenses. Yes, ma'am.
In that case, we don't afraid to that the lens will go into the posterior cavity. In that approach, the corneal endothelium can be preserved, I think so. That is all from my side.
All right. Thank you, judges. Thank you, Dr. Komal. I would now like to move on to the next presentation. Dr. Shivani Garg from MLNMC Prayagraj. Dr. Shivani?
Yes. Am I audible?
Yes, you are. She'll be presenting under the mentorship of Dr. Prajita Chaudhary.
Dr. Shivani, I like to tell you that the time limits are 4 minutes and try to cover within that, because the judgment criteria will also be including anybody exceeding the time limit will get a deduction of 5 marks for that.
Okay. Can I start?
Yes, Dr. Shivani.
Thank you, ma'am. Good afternoon, everyone. I am presenting a case on Sturge-Weber syndrome under the supervision of Professor Aprajita Chaudhary, ma'am. A 4-year-old female child diagnosed with Sturge-Weber syndrome was referred to our department for the evaluation of a large size of cornea. The patient complained of severe diminution of vision, both eyes, for the last 1 year, which was severe, gradual in onset, and progressive in nature. There is no history of ocular pain, redness of eyes, ocular surgery, trauma, any laser procedure performed, intravitreal injections, headache, convulsions, and spectacles used. There is no significant family history, no significant past history. In personal history, patient is mixed vegetarian by diet with normal bowel and bladder habit. On general examination, there is reddish discoloration of skin involving face, neck, and upper limb, more on the right side of the body, and suggestive of a port wine stain, and this lesion didn't respect the midline. On further examination, vision in both eyes was finger counting 2 meter. On retinoscopy, -1 diopter spherical in both meridian in both eyes. There is no improvement seen on best corrected visual acuity. On conjunctival examination, there is no congestion, no chemosis, and no conjunctival vessel dilatation. Bluish discoloration of sclera was seen with no episcleral vein dilatation. Cornea was clear and transparent in both eyes with corneal diameter of 13 mm vertically and 14 mm horizontally in both eyes. On anterior segment OCT examination, center corneal thickness was found to be 591 micron right eye and 571 micron left eye. On anterior chamber examination, Von Herrick grade 3 with no abnormal content present in both eyes. On gonioscopic examination, angle dysgenesis was seen. Intraocular pressure with IOP with applanation tonometer was found to be 30 mm Hg both eye. Pupil was round and sluggishly reacting to light. Perception to light was present and projection of rays was accurate in all quadrants. On fundus examination with direct ophthalmoscope was cup disc ratio was 0.9 vertically in right eye and 0.8 cup disc ratio vertically in left eye. On OCT disc, RNFL thinning was seen in superior, inferior, and temporal quadrant with sparing of nasal quadrant in both eyes. On CT scan, brain revealed subtle subcortical calcification in left temporo-occipital and right parieto-occipital region without any volume loss. In spite of these findings, patient didn't have any neurological manifestations. On the basis of clinical and CT scan brain finding, my provisional diagnosis is Sturge-Weber syndrome with bilateral glaucoma with bilateral port wine stain. On treatment, patient is on topical dorzolamide thrice a day, prostaglandin analog once at night, lubricating eye drop UID, and tablet methylcobalamin OD. On further follow-up, intraocular pressure was found to be 20 mm Hg, both eyes. Facial port wine stain can be successfully treated by laser. The laser should be applied superficially to avoid potential problems such as decreasing cerebral venous outflow through port wine stain vessels. Due to the wide spectrum of clinical manifestation of Sturge-Weber, management of this condition require multidisciplinary teams including pediatricians, neurologists, ophthalmologists, cosmetologists, physiotherapists, radiologists, and dentists. Prompt diagnosis is essential to prevent further issues, and patients and their parents must receive professional psychiatric counseling. Thank
you. Judges, please note, Dr. Shivani was well within her time limit. Dr. Sanjay, if you'd like to start the discussion.
Sure. Dr. Shivani, you have mentioned that you gave the management as topical anti-glaucoma drops and the pressure reduced from 30 to 20. Do you think this is sufficient?
No, sir. Target IOP was not maintained.
So what should be your next step of management?
For the next step, we can do some trabeculectomy procedures, surgical procedure.
Does trabeculectomy have a good outcome in long term in these patients?
Sir, in case of Sturge-Weber syndrome, surgical success rate was found to be lesser, 66%, sir.
How much?
So 66%.
So what are the other options which are better, or do you have any other options for these patients?
So we can do goniotomy with trabeculotomy.
For these Sturge-Weber syndrome, do you think that would be helpful?
No, sir.
Do you know any other management?
Sir, we can add sir other medical management, sir.
No, medical management would never bring it down to the required target intraocular pressure. I am talking of any other surgical management which can be done in this patient.
No, sir.
Thank you.
Dr. Rajwinder, ma'am.
How the CCT was measured?
Sir, ma'am, on anterior segment OCT exam.
Anterior segment OCT. Okay. So, any contraindications for the use of prostaglandins?
Ma'am, if patient is allergic, मैम अगर पेशेंट को मैम आफ्टर सब मैम प्रोस्टाग्लैंडिन आई ड्रॉप पेशेंट को मैम प्रेजेंट विद कंजक्टिवाइटिस एंड फर्दर रेडनेस ऑफ आईज
Or something related to uveitis? You want to name that?
Yes, ma'am.
In uveitis, the prostaglandins are contraindicated, na?
जी मैम.
Hmm.
Ma'am, in case of uveitis, ma'am, prostaglandins was not contraindicated.
So what are the surgical options? As it is, the patient is a child, so we have to preserve a long-term just management of trabeculectomy. So what can be done before that?
Ma'am, before trabeculectomy, ma'am, we have to maintain IOP before surgical procedure, because after trabeculectomy there are chances of sudden reduction of IOP, which can lead to suprachoroidal hemorrhage and choroidal effusions.
How you calculate the target IOP?
Ma'am, target IOP, ma'am, ma'am, it is defined as IOP that prevent further further progression of visual field loss and optic disc changes.
Okay. In this, you have done the OCT, na?
Yes.
So yeah, there was the RNFL loss.
Yes, ma'am. RNFL loss was seen in superior, inferior, and temporal quadrant in both eyes.
Okay. Is there any role of GCL ganglion cell layer in glaucoma these days?
Yes, ma'am. But
okay, thank you.
I don't know about it.
No. Dr. Vanita, you can ask a question.
What are the different types of Sturge-Weber syndrome?
Ma'am, according to Roth scale criteria, there are 3 types of Sturge-Weber syndrome. Type 1 includes the CNS manifest leptomeningeal angioma with facial angioma, and patient may have or may have glaucoma. In type 2, only facial angiomas was present and patient may have glaucoma. In type 3, only leptomeningeal angiomas was present and usually patient doesn't have glaucoma.
Type 3 will be having the CNS presentations.
Yes, leptomeningeal.
And what are the common findings you see in your patient, in Sturge-Weber patients, which is missing in your patient?
Ma'am, mainly, ma'am, in childhood, in infancy period, patient present with neurological manifestations such as seizures, convulsions, and in case of
your patient was not having CNS symptoms, that understood. What is the ocular findings which are common in patients with Sturge-Weber syndrome, which was not there in your patient?
Ma'am, episcleral hemangioma, choroidal hemangioma, patient may present with, and ma'am,
and did you do the gonioscopy for this patient? What was the status of the angle?
Ma'am, ma'am, angle structures, ma'am, appear indistinct. Maybe there may be angle dysgenesis present.
What was the finding in your patient?
Ma'am, angle structures doesn't appreciate.
Okay, the gonioscopy was done and the angle structures was not visible. That means the angles were closed. What was the cause of the secondary glaucoma in this patient? The Sturge-Weber patients, they have a variety of a secondary glaucoma. So what is the reason for having the secondary glaucoma in your patient?
Ma'am, in my patient, there may be an angle and anterior chamber angle dysgenesis, because Sturge-Weber ma'am mainly 2 type के होते हैं, either ma'am elevated episcleral venous pressure or anterior chamber dysgenesis. In case of ma'am elevated scleral venous pressure, ma'am usually on gonioscopy we have seen blood in Slim's canal, but in my case, blood in Slim's canal was not present.
Good. Thank you so much.
Thank you, ma'am.
Thank you so much, judges. That was a very interesting discussion. I would now like to call upon Dr. Samvida Parihar from BHU Varanasi. Dr. Samvida.
Good afternoon, all.
Good afternoon. She'll be presenting under the mentorship of Dr. Deepak Mishra. Dr. Deepak Mishra, sir. Good afternoon, sir.
Yeah, Minu, I'm here. Good afternoon,
Good
Vinita
afternoon,
ma'am,
sir.
Sanjay boss, Rajvinder ma'am, Nilima ma'am.
Hi, everyone. Hi, Deepak.
Good afternoon.
Good afternoon, Dr. Deepak.
Good to see you all after a
Yes.
long time.
Same here.
Dr. Samvida, you can
Please.
start with your presentation now.
Good afternoon, all.
Ma'am, I am in my village, so maybe network is lost in between. So kindly excuse me if network is lost. Otherwise, I am here since morning, 8:30. Okay.
Because we were seeing you in between.
Sure.
You can start, Dr. Samvida.
My patient, Mr. Santosh Kumar Pandey, a 40-year-old male shopkeeper by occupation, presented with chief complaints of gradual progressive diminution of vision left eye since 1 year, along with on and off redness with heaviness left eye since 1 year. Despite the patient presented a private practitioner, despite which he was given an oral topical medication to be used at bedtime. And however, the patient did not find or appreciate any relieving of symptoms. So he presented to us. There was no history of trauma, no history of floaters, no history of flashes of light or halos, no history of any use of topical or oral medications prior to the complaint. And there was no history of frequent change of glasses. The past history was insignificant. The personal history was insignificant. There was no history of any substance abuse, and even the family history was insignificant. However, the patient gave history of using spectacles for near vision. The general examination was insignificant. The visual acuity of the patient in right eye was 6/6, whereas in left eye it was 6/24. With no improvement with pinhole, the BCVA of the patient right eye was plain 6/6 with left eye -1 diopter sphere improving up to 6/18, and near vision it was improving with 1+1 diopter sphere. The ocular examination or torchlight examination revealed that the adnexa and conjunctiva no abnormality was detected. The cornea was clear in both eyes. However, in temporal torchlight examination, an eclipse sign was seen in the left eye AC. The pupil was sluggishly active in left eye, and the findings of the torchlight were confirmed on the slit lamp examination, where it was seen that the adnexa and conjunctiva were within normal limits. The cornea was clear in both eyes. The iris architecture was normal. But on AC examination, it was seen that in right eye, it was 1 Herix grade 3, whereas left eye, it was 1 Herix grade 1. The rest of the AC was clear, and lens revealed glaucom flecken in both eyes. On IOP examination, right eye was 22 mmHg, whereas left eye was 24 mmHg, taken at 10 o'clock in the morning with Goldman's applanation tonometry. And conioscopy revealed Schaffer's grade of 2 in 2 quadrants in the right eye, along with PAS, whereas it revealed grade 0 in 3 quadrants, along with grade 1 in 1 quadrant. On fundus examination, both eye the media were clear. On right eye, the disc was normal in size, shape, and color with vertical cup-disc ratio of 0.4. The macula was normal with foveal reflex was seen, whereas in the left eye, the disc, it was normal in size, shape, and color along with NRR pallor and the vertical cup-disc ratio of 0.6. However, no RNA field effects or vascular changes could not be appreciated. The macula was normal with a normal foveal reflex was seen. On doing the ancillary examination, it was seen that the right eye, the perimetry done under central 30-2, the theta fast revealed the field was reliable and within normal limits. Whereas in the left eye, it was seen that there was significant total deviation and a pattern deviation depression in 30-2 as well as 24-2, whereas 10-2 revealed that the mean deviation was minus 17 decibels that remains in advanced glaucoma stage. The central corneal thickness taken by ASOCT revealed that the CCT of right eye was 532 and left eye was 492, which signifies that either IOP was underestimated in the left eye, whereas the ASOCT also revealed that there was thinning, narrowing of the angles at right eye as well as in the left eye. Right eye was around 15 degrees, whereas left eye was around 11 degrees. Based on my findings and examination, The provisional diagnosis was right eye primary angle closure with left eye primary angle closure glaucoma. The patient has been planned for laser peripheral iridotomy. The patient has not, the plan of management is this, and with this, I would like to conclude my case. Thank you.
Right. Thank you, Dr. Samvida. She was well within the time limit. Now I'd like to invite Dr. Rajwinder to please start the discussion, ma'am.
Okay, it was nice, well-documented case. So what are the risk factors for primary angle closure glaucoma?
The risk factors include the patient factors, that is increasing age, female gender, or history of any comorbidities like glaucoma or hypertension, whereas the ocular risk factors include increased intraocular pressure, decreased angle, narrowing of the angles, along with hypermetropia, increased lens thickness, increased lens vaulting, and decreased corneal diameter.
Is he was hypermetropic?
No, ma'am, the patient was not hypermetropic. Actually, that is why a unique case in the sense because no risk factors along with narrowing of the angle was seen in this patient.
So you have asked some systemic history, drug history also?
Yes, ma'am. All were insignificant. The patient did not have any family history. The patient did not have any history of oral or topical medication usage. The patient did not have any history of comorbidities, any systemic evaluation.
Which drugs can cause a secondary angle closure glaucoma?
Ma'am, secondary angle closure can be caused by systemic medications like topiramate, antipsychotics, antidepressants, and even it has been shown that topical pilocarpine can also lead to acute angle closure.
So as you were telling us, that patient was myopic.
Yes, ma'am. But there was no history of any spectacle use for distance vision prior to 1 year.
Or how you can rule out that it was a recent myopia or it was an old myopia?
Ma'am, had it been an old myopia and the patient was not using spectacles, there could have been amblyopia in that eye. Could be. And along with that, even the fundus can reveal any myopic changes if the patient has high myopia.
Because it is very important to rule out that it is a pure primary angle closure glaucoma or it is a secondary angle closure glaucoma, because these things help. History is very important in these cases.
So
what will be your management?
The patient was planned for laser peripheral iridotomy, and if that opens the angle, but even if, despite of that, since there is advanced glaucoma in left eye, so I would like to know what the target IOP is, and thereby the patient should be undergoing a medical management. If the patient is controlled under medical management, well and good. If not, then surgical management.
How we do the peripheral iridotomy?
Ma'am, peripheral iridotomy is done using Nd:YAG laser with around energy of 2 to 4 millijoules with at least 1 to 3 pulses per burst and a size of around 150 to 250 micrometer at 11 o'clock or at 1 o'clock, identifying the crypts and such that at least in 1 or 3 shots it should be completed.
Why it is done in 11 o'clock and 1 o'clock only?
Ma'am, because if, for example, if we do the PI at 12 o'clock, once the patient undergoes PI, there might be release of bubbles that might occlude our visibility. And whereas if it is done at 3 and 9 o'clock, there might be chances of diplopia in the patient because that the iridotomy is half covered with the lid. So it is better to perform laser PI at 11 o'clock or 1 o'clock.
That is all from my side. Thank you.
Thank you.
Thank you, ma'am. Dr. Sanjay, sir?
Yes, I would like to know, you have mentioned glaucom flecken in both the eyes in your examination. So did the patient give any history of redness and pain or any other evidence of acute attack in the past?
So the patient did not give any history of acute redness. Initially, the patient presented with redness 1 year back to some private practitioner, but that was a self-aborted phenomena. The patient only complained of mild redness along with heaviness. There was not an acute emergency. The patient did not complain of acute pain and redness. So probably it was a case of chronic or intermittent angle closure.
Okay. What was the finding as far as neuroretinal rim is concerned in your case?
So the neuroretinal rim in my case in the right eye is normal, whereas in the left eye there is NRR pallor along with concentric thinning of the NRR, and there are no focal notching or any defects seen in the NRR, or no vascular signs could not be appreciated as well.
Do you think NRR pallor goes in favor of glaucoma?
No, so not specifically. It might be secondary to a neurological cause or maybe due to hypoperfusion. So the disc findings do not typically seem to be that of a glaucoma.
Okay, one more question regarding management. You were asked about management, and while you described also, you said management of left eye only to the
No, so
madam also, and while presenting also, you said management of left eye only. What do you think should be the management in the right eye?
So since both of the angles, left eye shows angle closure, whereas the right eye also shows Schaffer's grade 2 along with PAS, therefore prophylactically also the patient should undergo YAG PI in right eye as well.
Yes,
So
you did not mention that. Your management is incomplete until and unless you do PI prophylactically in the other eye also.
yes.
And what do you think? You said PI in the left eye in the management. Do you think considering your gonioscopic findings, that would be sufficient?
So no, so probably if after PI also, I think the patient most probably would need either medical management, and if not suitable, then probably a surgical management as well, because since there is advanced glaucoma in that eye, there are chances that target IOP might be very less, which might not be achieved only by RPI. So I would also advise a patient medical management as well.
Thank you. Thank you.
Yes, sir. Dr. Vinita, ma'am, any questions?
How do you define PSC, PSCG, and PSCS?
Primary angle closure suspect is when there is 180 degree or more of appositional angle closure with no peripheral anterior synecdoche or no raised IOP or no disc or fundus changes, whereas primary angle closure includes when there is 180 degree or more of appositional angle closure along with either PAS or increased IOP with no disc or field changes in favor of glaucoma. Whereas primary angle closure glaucoma includes all of the three. There should be at least 180 degree or more of appositional angle closure along with either PAS or increased IOP along with disc and visual field changes.
And how do you grade a glaucoma as a mild, moderate, and severe glaucoma?
A mild, moderate, and severe glaucoma can be confirmed using a perimetry based on the fields, based on the mean deviation as well as pattern standard deviation. Initially, in the early changes, the mean deviation should be less than -6 decibel, whereas in moderate it is between 6 to 12 decibels, and in severe it is more than -12 decibels.
And why did you do both 30-degree, 30-2 and 24-2 for the left eye in your patient?
Ma'am, because based on the disc changes, I was not expecting that the patient might have such severity of glaucoma field defects. That is why initially I decided to go for a 30-2, and then when there was increased mean deviation, that is why I underwent 24-2 and subsequently 10-2.
Not needed. If you do a 30-2, or you could have done a 10-2, which you did, but then it gives more or less the similar information. So whatever you have confirmed on a 30-2, not needed that you should go for a 24-2. So 30-2 and 10-2 could have sufficed. Or 24-2 or 10-2. Thank you.
Thank you.
Thank you so much, ma'am. Thank you, Dr. Samvida.
I would now like to call upon Dr. Ekagrita Shukla from BHU Varanasi. She will be presenting under the mentorship of Dr. Deepak Mishra. Dr. Ekagrita, are you here?
I think we are behind time.
Yes, ma'am. Dr. Ekagrita? Yes, ma'am. Okay. You can start presenting your case. You can share your screen. Yes, ma'am.
So good afternoon, everyone. My case is a typical presentation of optic neuritis with atypical fundus findings under supervision of Professor Deepak Mishra. I had a 26-year-old female, Mrs. Taranum Jahan, housewife by occupation, presented to our OPD on 1st of April with chief complaints of pain in right eye since 4 days, sudden diminution of vision in right eye since 2 days. History of present illness was that she was apparently asymptomatic 4 days back when she developed right eye pain, which was subacute in onset, constant dull aching in nature, exacerbated by eye movements, and it was associated with right-sided headache, which was subacute in onset, dull aching in nature, not associated with nausea, vomiting, photophobia, or phonophobia, and it was relieved on painkiller medications. 2 days later, patient developed diminution of vision in the right eye, which was sudden in onset and rapidly progressive in nature. For the above complaints, she visited nearby ophthalmologist who referred her to BHU. Diminution of vision in right eye was not associated with any history of redness, watering, photophobia, burning, forehead body sensation, colored halos around light, nausea, vomiting, or contact lens fear. Past history, there is history of full-term vaginal delivery 3 months back, and there is history of 2 to 3 episodes of fever with chills 1 month back, but there is no documentation. Patient took the over-the-counter drugs and was relieved. And there is no stress significant past history. In menstrual history, the patient is not having menstrual cycle. She is breastfeeding, lactation amenorrhea is there. There is no significant personal history. In negative history, there is no history of pain with chewing, scalp tenderness, proximal muscle and joint aches, anorexia, weight loss. There is no history of transient visible obscurations. There is no history of diplopia, nystagmus, tingling or numbness. There is no history of dysphagia, dysarthria, sphincter disturbances. And there is no history of any flashes of light with eye movements or altered perception of moving objects. There is no history of worsening of symptoms with exercise. There is no history of shock-like sensation upon neck flexion or intractable hiccups or severe itching and vomiting. There is no history of double vision, nausea, vomiting, or bilateral vision, transient vision loss upon rising. And there is no history of oral ulcers, small joint pain, dryness of mouth, photosensitivity, dyspnea, or skin rashes. And there is no history of any contact with pets, any trauma or ocular surgery, and no history of any lifting of heavy weights. General examination and systemic examination within normal limit. And ocular examination, in right eye, the visual acuity was PL present with defective projection of rays. Left eye was normal. Color vision in right eye couldn't be assessed due to low vision. In torchlight examination, adnexa, conjunctiva, cornea was within normal limit. In right eye, relative apparent pupillary defect was seen. Left eye was normal. Set-line examination, there were no abnormalities with IOP was 12 mm in right eye and left eye 14 mm. AC was normal. In fundus examination, we saw that there was disc edema, which as the disc appeared elevated, slightly pale with central hyperemia with blurred margins. There were few large peripapillary flame-shade hemorrhages present inferiorly along the major vessels and a few hemorrhages superiorly and temporal to the disc. Vessels coming out of the from the center of the optic disc are obscured by the swelling of the surrounding retinal nerve fiber or around the disc. There is a large boat-shaped subhyalite hemorrhage of around 1/3 disc diameter in vertical height and 1.5 disc diameter in horizontal width present directly over macula, approximately half disc diameter temporal to the disc. There are exudates present in macular area like macular fan with retinal fold surrounding the macula, and there are multiple small frame-shaped hemorrhages seen in rest of the fundus along vessels, superior, inferior, and nasal quadrant of the fundus. Left eye was normal. So in summary, I had a 26-year-old female with unilateral right eye painful diminution of vision with right eye RAPD and fundus showing features of papillitis along with involvement of macula with exudates and hemorrhages. In my provisional diagnosis, it is right eye optic neuritis with pre-existing veno-occlusive event due to pre-eclamptic toxemia. And there may be DD of right eye neuroretinitis of infective etiology. It can be chronic relapsing inflammatory optic neuritis, or it can be anterior inflammatory optic neuritis. In investigation, I took OCT RNFL, which showed the increased RNFL edema in right eye. Right eye macula showed pre-macular hemorrhage, pre-retinal hemorrhage. Vitreoretinal interface showed a membrane-like structure with underlying hypoechoic area, suggestive of hemorrhage with disorganized retinal layers and loss of foveal contour. CT scan done showed enhancement of the right eye, suggestive of right eye optic neuritis. Investigation showed eosinophil increased, rest well within normal limit with increased homocysteine levels. So we underwent conservative management for ocular thing and neurology consultation of the patient. Thank you.
Thank you, Dr. Ekagrita. Judges, please note the participant was
took just under 4 minutes.
She was super speed. It was super speed.
Yes, ma'am. Okay. So, ma'am, if you'd like to start the discussion.
Actually, I want to know if any blood pathologies they were ruled out.
Yeah, ma'am, we did the investigations. Blood parameters only the eosinophils, like in fact, eosinophils and lymphocytes were raised, and serum homocysteine and ESR was found to be raised. Rest were normal.
What was the hemoglobin of the patient?
Ma'am, the hemoglobin was around 13 milligram per deciliter.
Okay. So, any history of dengue-like picture?
Ma'am, only she gave a history of undocumented history of non-specific history of fever and chills, which was not documented, and it was relieved on taking paracetamol.
Okay, no the test was not done.
No, she did not undergo any investigation or test for that.
That is all from my side.
Thank you, ma'am. Dr. Sanjay, sir.
I can't hear you.
Sir, your mic is not on.
Okay. I would like to know whether you have done any VEP for this patient.
Sir, we did not do VEP at that time.
What could be the VEP findings in a case of optic neuritis?
Sir, latency period will be raised and amplitude will be decreased.
Okay. In a patient of optic neuritis, we do another investigation. What is that? Suspect to rule out something.
To rule out.
What is the commonest cause of optic neuritis?
The demyelinating disorders.
So to rule out that, what investigation?
CSF, sir, CSF analysis can be done.
No,
MRI.
Yes, MRI. Have you done any MRI for this
Sir,
patient?
we referred the patient for neurological reference, and they did order MRI. It was found to be normal. Only the optic nerve enhancement was seen.
But since you knew that, you should have mentioned that.
Yes, sir. Yeah. Yes.
Okay. Another thing, did the patient give any history of diminution of vision during the episode of fever or during pregnancy?
No, sir. No, sir. I specifically asked that. During pregnancy, she had no complaints. She just developed the complaints 4 days back only. It was very acute and rapid.
And not even during the episode of fever?
No. I asked that during fever, did you have any? She was like, no. She only had diminution of vision complaint since 4 days. She said like that.
Okay, thank you.
Thank you, sir. Thank you, sir. Dr. Vinita, ma'am, any questions?
What is the fundus picture of the other eye? You have shown only the fundus picture of the right eye. What was the picture in the left eye?
Other eye was normal within normal limits. Disc was normal. There was no.
Looking to the fundus picture, it looks like a grade 4 hypertensive retinopathy.
Yes, ma'am. Actually, that's why, ma'am. With complaint of the patient correlated with optic neuritis, but the fundus finding appeared like veno-occlusive disease. So that's why it was an atypical.
See, in the postpartum period, there are a lot of changes happening. You have postpartum optic neuritis, but basically it looks like more of an eclampsia induced changes. So probably we should go for a carotid Doppler. We should check for the blood pressure, and also you can check for the other eye. Most of the postpartum females, they have various kinds of syndromes like Press syndrome, HALP syndrome. So you should look for the kidney also. Most of these patients, they have a kidney involvement. So it doesn't look like an optic neuritis. Just because she has a poor vision, we cannot label it as an optic neuritis. The fundus picture looks like grade 4 hypertensive retinopathy.
Ma'am, actually, patient specifically complained of pain in eyes along extraocular movement, and RAPD was also present. That's why history-wise we suspected.
Any poor vision will give you an RAPD, and then definitely there was an enhancement of the optic nerve. So most of these patients, they have an encephalopathy associated also, which is acute reversible encephalopathy in the postpartum period, which is called as RSVP syndrome, something like that. Some syndrome is there, which is acute reversible encephalopathy. So you should look for such things. I don't think your diagnosis of optic neuritis fitting into the picture which you have shown. And you should be very vigilant in seeing the picture of the other eye. There might be some changes of hypertensive retinopathy.
Ma'am, there was presently no feature. This was also normal, and AVR ratio along with CMT, everything was normal. And BP
was the blood pressure on presentation?
Blood pressure was normal, ma'am. First, after seeing the fundus, the first thing we did was checking blood pressure and CBC and GBP, everything. But ma'am, it appeared normal. That's why.
And then urea creatinine.
Yeah, ma'am. LFT, RFT was also normal.
There's no kidney.
Yeah, we closely follow up the
And
patient.
what about the liver function test?
Ma'am, it was normal. We closely follow.
Some of them have the platelet affected, some of them have a liver affection, some of them have a kidney affection. So that way you have to probably think of, does it fit into the criteria of optic neuritis? Thank you so much.
Or if it all things are coming normal, then you should have shown in the case report presentation.
Yes, ma'am. The
That is
patient
very important because without them we cannot label it as a optic neuritis. So these things are important to rule out the HELLP syndrome, the eclampsia associated hypertensive retinopathy. So these things are very important in pregnant related these fundus pictures.
May I say something, ma'am? Dr. Deepak here.
Yeah.
Yes, sir. Yes, sir.
Yeah. What happens, ma'am? What all of you suggested, investigations were within the normal range. That's why we are in the dilemma that what happens. Exactly, the fundus finding is looking for what ma'am said. It's like eclampsia. After eclampsia, fundus feature is more suggestive of the veno-occlusive disorder. But when we look for that, the retinal pathology, means the optic nerve pathology, it also going in a favor of optic neuritis. That's why we take the help of the neuro people, and we are keep on watching in this type of things. So there is chances that some cases we find out that they may present as a, means initially they look like a veno-occlusive, but later on it is a chorioretinitis type of the picture which will leads to this optic neuritis. And after that, in means 3 months of the follow-up, these optic neuritis gradually converting into the optic atrophy. That's why we presented this case here, that it is not a common find, means it is not a one line of finding, means when we find out veno-occlusive picture and we label them or treat as a HELLP, or there is clear-cut diagnosis of optic neuritis, so no need of taking another things. It is a mixed type of presentation when the patient came to us, and gradually what we suggest for this is we cannot label one disease, either veno-occlusive or optic neuritis at the time of presentation. That's why we presented here that there may be chances that mixed symptoms appear. It may be because of the pregnancy related, or maybe of the some infections we see in history of fever, which we can't rule out. That's why the DD is important, and the purpose of presenting these cases to we know the all spectrum. It is not only the one disease or one thing we can label clear cut by taking the signs and symptoms.
Dr. Deepak, I suggest you should go for an angiography and also the carotid Doppler. These two things should be done.
What was the outcome of pregnancy?
Sure, ma'am. Sure.
The child,
It was normal.
Vaginal delivery with normal, the child is normal breastfeeding.
Dr. Deepak, Dr. Sanjay here.
Sorry.
The neurologist did not do the VEP?
Hello.
Hello. The neurologist did not do the VEP?
No, sir. They recommended, and we are waiting for that test and other thing, because at that time VP was not active at our place. There are some faults. They referred it patient to someone private clinic, but they didn't did at that time. But rest of the MRI and other investigation, already neurologists do it.
No, that would have helped us a lot. The VEP findings would have helped
yes,
us.
Even VEP and Doppler angiography, what ma'am suggested, both are the helpful, sir. But seeing the patient condition, how much she can afford, we are looking for the investigations since the patient of the poor background to at our own place, which is mostly economical and free. That is the reason.
Thank you.
Tracking with the suggested investigations by our judges.
Thank you.
All right. Thank you so much,
Thank you, sir.
judges. And judges, please note that the last participant, Dr. Akash Singh, also is not able to join us today for presentation. So with this, we have actually come to the end of competitive session 2. I would again like to thank all the participants, their mentors for participating, and my most gratitude to Dr. Vinita Ramnani, Dr. Rajvinder Kaur, and Dr. Sanjay Thakur, sir. Thank you so much, ma'am and sir, for joining us and giving us your valuable time.
Thank you for the opportunity. All PGs presented very well, and the program is being organized and crafted very well. So thank to you, Dr. Manupriya and the team. They are doing an excellent.
Thank you for making that.
Thank you, ma'am. Thank you.
It was an interesting collection of cases and very
Yes,
well
sir.
organized by your team and Dr. Nilima and Dr. Mohita.
Thank you, sir.
We all learned many
right.
things. Today also, we also learned so many things. We have
Yes,
seen
ma'am.
wonderful bouquet of cases.
Yes, ma'am. Yes, ma'am. Very nice presentations also. All right. Thank you, judges. So now moving on with the program. Dr. Gayatri Ahuja, ma'am.
Yeah, I'm here.
Ma'am? Yes,
Yeah,
ma'am. So next we have a talk on mentoring and networking by Dr. Gayatri Ahuja, ma'am. Ma'am is the head of cataract and refractive surgery wing at Ahuja Eye Center, Aligarh. She's done her MBBS from GMC Nagpur and PG from Army Hospital, New Delhi. And she's done a cataract and phaco fellowship from Geeta Netra Chikitsalaya and a short-term fellowship in refractive surgery from Netradham, Bangalore. She has an experience of around 2 decades in cataract and 1 decade in refractive surgery. Her other areas of interest include keratoconus and dry eye, and she has been an active member of various societies like the Aligarh Ophthalmic Society, WOS, AIOS, and ISC KRS. We welcome you, ma'am. Thank you for taking out your valuable time.
Thank you so much, Dr. Manupriya, for that introduction. And I would also like to thank the whole team of WOS, Dr. Mohita, Dr. Nilima, and the whole team for giving me the opportunity to be here today. And okay. So my topic for today is mentoring and networking. Now, I think the concept of mentoring is as old as the human race. There can be no better example of a mentor-mentee relationship than Lord Krishna and Arjun, with Sri Krishna always guiding Arjun, nurturing his growth and unlocking his hidden potential. And this tradition has been going on since years. And in the present day, we have our very own WOS with exceptional mentors in the form of Dr. Mohita, Dr. Nilima, and many others, proving that wherever such mentoring climate prevails, the organization sails. Now, mentoring is basically a reciprocal relationship between an experienced, highly regarded, empathetic person, the mentor, and a less experienced junior faculty member, the mentee, aimed at fostering the personal and professional development of the mentee. And the primary role of the mentor is ensuring professional growth and providing psychological and emotional support to the mentee so he can perform to his fullest potential. Now, there is a definite difference between coaching and mentoring. In coaching, the aim is to provide academic and professional assistance with a sole focus on competence. It's a standardized process and the coach is the driving force here. In mentoring, a helpful personal and reciprocal relationship is built while focusing on achievements with emotional support being the key. It's a personalized process and the mentee is the driving force here. So now what makes a good mentor? A good mentor is one who has the willingness to share skill, knowledge, and expertise, motivates others by setting a good example, demonstrates a positive attitude and acts as a role model, and provides guidance and constructive feedback, taking a personal interest in the relationship.
And what exactly do mentees look for in mentors? And the first and the most important thing is experience. The confidence that he knows what I'm talking about, has experienced it already, is not intimidating and easy to approach, shows genuine concern and interest, gives subtle guidance but ensures that I make my own decisions, will give honest answers, does not blame, remains neutral, and gives very constructive feedback. Now, there will be times when we feel, why should I mentor? What is in it for me? Well, you should mentor because you learn from your mentees, build leadership and management skills, review and validate your knowledge and achievements, feel satisfied, proud, energized, and get an opportunity to meet new colleagues. So basically, it's your chance to pay back and leave a legacy and get the satisfaction that you are leaving the world better than you found it. So there are different types of mentoring relationships. The formal ones usually at workplace for developing careers, and the informal ones usually occur spontaneously. And these are largely psychosocial, help to enhance the mentee's self-esteem and confidence by providing emotional support. So whatever the kind of mentor-mentee relationship it might be, the 6 C's to a successful relationship are to connect, to communicate, to collaborate, to circulate, to cultivate, and to celebrate. So these form the backbone of any kind of a relationship. There are different stages of mentoring: the initiation stage, the cultivation stage, the separation stage, and the redefinition stage. The initiation stage is where 2 individuals enter into a mentoring relationship. Potential mentees look for experienced, successful people whom they admire and perceive as good role models. And potential mentors look for talented people who are coachable. Then comes the cultivation stage, the primary stage of learning and development. And this is where the mentoring functions at its peak. Career-related functions emerge first and the psychological functions later as interpersonal bond develops and relationships mature into very strong friendships. Then comes the separation stage, which generally describes the end of the mentoring relationship and could be due to various reasons. The duration of the training period is over, the feeling that there is nothing left to learn, the mentee wants to establish an individual identity, the mentor wants to send the mentee off like parents send off an adult child. And the last is the redefinition stage. Here, the focus is no longer on the mentee's career development, and if both navigate through the separation stage maturely, the relationship usually evolves into a deep social friendship. Now, there are red flags in this relationship as well as in all other relationships, and we need to steer clear of them. These include the mentee may be over-dependent, seeking micromanagement instead of advice and counsel, may expect personal favors from each other, the mentee may expect more involvement or credit in mentor's work, and the mentors and mentees may have performance issues. In the context of medical education particularly, mentorship is an important part of medical training and valuable to both the mentor and the mentee. A career in medicine is characterized by challenges. It is invaluable to have a point of contact to guide through them and also to share the euphoria of the successes. Formal programs ensure that a mentee will find a mentor, while informal mentorship allows for better alignment of interests and a more fulfilling relationship. Effective mentorship can prevent burnout, which is prevalent in the medical field. And the last, but the most important, mentorship should not be confined to arbitrary institutional boundaries, and gender should never be a concern here. So now coming to networking, it is aptly said that your network is your net worth. Networking is the exchange of information or services among individuals, groups, or institutions. Specifically, the cultivation of productive relationships for employment or business creates interconnected groups for the mutual benefit of all members of the system. While discussing the notion of mentorship and networking, people tend to use them interchangeably. Both offer undeniable benefits in career advancements and play different roles in different periods of career and life, and both share plenty of similar aspects, but there are some key differences between the two. Mentorship is a deeply nurtured and developed relationship between the mentor and mentee with a high level of trust, whereas networking is a broader and a more general way to build up professional relationships. And here, the interactions are very surface level. In mentorship, the benefits include both external outcomes like skill development, network expansion, and internal outcomes like self-awareness and confidence. The connections take time to develop through accomplishing common goals. Through networking, you can meet a wide range of people and gain insights into trends in industry developments. And this helps build a wider support system and increases your visibility faster. But both are equally important for a successful career. Now, the importance of networking, it strengthens business connections. You can tap into your network for ideas and share knowledge. You can raise your professional profile by being visible and grow your personal brand. Get access to job opportunities, career advice and support. Build confidence and relationships and get a new perspective about things. A few tips for improving networking skills. Whenever you're in a group or in a meeting, always join the crowd, support the conversation. Don't use one-word replies. Remember names. Don't end abruptly. Always exit in a friendly way and always follow up. Maintain your network and most importantly, network all the time. In the context of the healthcare professionals, networking helps in meeting new people, including industry leaders, in effective patient referrals to specialists in the area, in staying updated with new research and technologies and upgrading skills, in getting career opportunities, in creating a sense of inclusion and support, and establishing a community to safeguard interest, which is extremely important in today's day, in sharing resources and reducing financial burdens while achieving common goals. A few effective ways for healthcare professionals to make new connections include joining professional organizations related to healthcare, attending conferences, workshops, and other networking events, interacting with your patients' healthcare providers, volunteering as medical professionals, considering cross-training, and using social media to build professional relationships. So the take-home message here is that while both mentorship and networking are valuable for career growth, they offer different benefits and should not be treated as the same. Understand the benefits you are looking to gain and then choose the tool that is the most appropriate for your needs. While mentorship is more focused and personal and provides in-depth guidance, networking offers a broader perspective and helps you build a diverse network of contacts and resources. Understanding their differences and how they work symbiotically can help make informed decisions about how to approach your career growth. Thanks for your patient listening.
Thank you so much, ma'am. That was a very, very helpful talk. And I would just like to say something because like I finished my PG just 1 year back. And on behalf of all the residents or because a lot of PGs are participating today. So I know that in the beginning, when you start attending conferences, you start presenting your case presentation paper, poster, anything, then it can be a little intimidating to be presenting in front of such senior ophthalmologists and such stalwarts of ophthalmology. So I would like to encourage the PG residents to attend the conferences first. And I have attended, I think I've been attending WOS conference, annual conference for about 2 to 3 years now, and even participating in these online meets and webinars. And WOS has been such an amazing platform because the kind of support you get here, that is just amazing. So I would really like to encourage all the residents to come for conferences and to participate in events like this. Even if you're not confident, even if you're doubtful, this is how you will get to experience and this is how you will get to meet a lot of people. And you will get to know about their journey and they will guide you in such nice ways.
Thank you so
That's
much,
just I
Manu.
wanted to say, ma'am.
And I think you have summed it up very well. And I don't think there's anything left to say after the way you have summed it up. And there is no doubt that WOS is a revolutionary thing as far as the women ophthalmologists in the country are concerned. So thank you so much. And I won't take any more time. Thank you very much.
Thank you so much, ma'am. All right. We will now move on to the next talk. Dr. Vibha Singh, ma'am. Dr. Vibha, ma'am. I think ma'am was just here. She was sharing her screen also. Dr. Vibha Singh, ma'am, are you here?
Hello, am
Yes,
I audible?
Yes, ma'am.
Can
Yes,
I
ma'am.
share my screen actually?
Yes, ma'am, just give me 1 minute, ma'am. All right, so now we have a talk by Dr. Vibha Singh on fellowship experience and making the best of it. Dr. Vibha, ma'am, is a senior specialist phaco-refractive surgeon at ESI Oplan, New Delhi. She's an alumnus of BRD Medical College, Gorakhpur, at the Regional Institute of Ophthalmology, Sitapur, ESI Rohini, and Hindu Rao College, Delhi, and even Tirupati Eye Hospital, Noida. She has been a member of ARC, UPSOS, AIOS, DOS, WOS, and ISCKRS. She's a co in the PIIN study at Tirupati Eye Center, Noida. She's also working as coordinator and investigator in red eye disease at Tirupati Eye Center, Noida. And she's an active participant in the project DST and Lambda at the Tirupati Eye Center, Noida. Ma'am, I would like to welcome you.
Thank you, Dr. Manupriya.
Thank you so much for taking out your time. Yes, ma'am.
Just a minute.
Ma'am, you can share your screen, ma'am. Thank you, ma'am.
Thank you, WOS and Dr. Mohita ma'am, to give me this opportunity to present the topic. Is it okay?
Yes, ma'am.
The how to make most of our fellowship. So I just start my topic. Not moving actually. That's fine. There is no conflict of interest to declare, and there is no financial support from any source for this presentation. So, just in a short introduction, in this progressive world, in this progressive world and a competitive world, there is a growing technology advancement in a healthcare. It is always a dream of all young ophthalmologists to get a brilliant academic and surgical career after post-graduation. So before the fellowship in today's scenario, senior residency was norm, but fellowship opportunities were not as popular as today's. In the current scenario, after finishing post-graduation, the majority of doctors in a dilemma whether to do senior residency, fellowship, or opt for an international platform. But in this scenario, where we can see the ophthalmology is a lucrative branch where the maximum career opportunities are there. It is very ever-growing dynamic specialty and had lots to offer. The healthcare industry had undergone revolutionary changes in the last decade of immense opportunity to open up for the ophthalmology sector also. So in a short, there are two types of fellowship. It is a comprehensive or subspecialty. We can discuss fastly the merits of the fellowship. The fellowship allow you to fill up the deficit in your training program previous in a junior residency, or sometimes we did fellowship after senior residency also. It gave a holistic approach to managing the patient, clinical research, and the surgical exposure, and that forms a base of specialty fellowship. And the fellowship also provide the future opportunity to write various exams such as the ICO, MRCS, and the FRCS. But there is demerits of fellowship also. You may get fewer opportunities to teach postgraduate. And after finishing one fellowship, if you want to have experience in another one, you again have to spend 2 years to do another fellowship. So I just summarize in 10 points to how do you make most of your fellowship more helpful for your career. First, when you decide to have a fellowship, you understand the eye care institute or organization requirement before beginning of fellowship. Either it is a domestic or it is an international fellowship. You have to checklist the formalities like work contract, medical examination, payment agreement, visa requirement, housing guideline, and insurance information. The specific requirement of fellowship will vary based on the nature of your fellowship. Second, you have to research the hospital where you are going to spend your 2 years. Either it is a tertiary care hospital or training center or any other hospital. The first, you reach out your hiring manager or mentor for the fellowship program, organization board, mission and goals during during your tenure of fellowship, because what you want in fellowship, what your mentor wants, because both sides should be clear. It is a long duration of time where you are going to spend your precious time of life for your experience. Furthermore, find other organizations that do work or research similar to your fellowship program and subscribe their email update or follow their social media posts, because today's scenario, you can have anything, if information on social media, it is always available and updated. So meet the people, they are best one with whom you can have a knowledge about the previous experience. Prior beginning any fellowship, during the first few months, take a time to meet with alumni of fellowship program to get a first-hand account to what fellowship is like. You can better understand how to navigate your fellowship experience. Beginning new fellowship can be stressful initially, especially if you are moving to a new environment. So it is always important to start mapping out the network that is exists to support fellows and start taking time to get a first-hand perspective on what experience they had. So after starting a fellowship, as being student life, we are doing homework. That's why before doing any fellowship, you have to do pre-work. Make sure you have to be an active participant in every training, similar to taking any class, thus listening the lecture. Training is not same as experiencing one. You do want to miss out any valuable insight from facilitator, peer, and any potential guest speaker, because you always have a classes and speakers in your fellowships. Most may make attending trainees top priority and always come prepared with question and comments and likes to speakers also. They encourage both of them for speakers and listener. Organize your commitment and side project before your beginning of fellowship, because we are going to have a large part of life in your hospital. You are also having your personal and social life. To get most of your fellowship, it will be important to make both of trainings and social activity associated with the program priority. This means figuring out what side projects to be on hold for that time, or what you can continue to work while focusing on the program. And most importantly, be flexible. Many learning opportunity or fellowship present when you are least expecting them, because everybody wants more surgical experience. But if you are doing good at all things in research, OPD, so sometimes you will not be in OT, but they will call you for the case if you are doing good. Whenever it will be on the job, your reflections from the people around you or the training, it is imperative you to be go open to learning and experiencing things you never anticipated. Sometimes you said to go to research, or what role you thought to you would play in an organization unexpectedly shift and evolve. Sometimes you just मतलब just सरप्राइज की अच्छा आज मुझे भी केस मिलेगा. So everybody has its own experience. Means you can have experience with the previous fellows, but everybody has his own experience in life, in fellowship also. While every fellowship program has a curriculum and expected learning outcome, it is also important to set your own intention and think about learning outside of them in the program. Your mentors and seniors are there to guide you, protect you, but the ultimately responsible for what to get. You are the best person who knows what you want from your fellowship. If you want to learn some new skill present in the hospital, or someone is there who know better than you, you can ask. She or he can teach you. So you do not have to wait someone else to guide your experience. Or always focus on building strong relationship with other fellows, because you invest a building or strong community outside of networking. As ma'am told earlier in a previous discussion, it is the best thing to have a best network or community building. It is important part of fellowship, and after finishing a fellowship also, because your peer will be a powerful part of your network, and they are the people who will go in 5 to 6 years when you are looking for a new job or career change. Use your fellowship to meet as many as people to figure out next step. You will not be getting most of your fellowship if you do not take the time to meet many people from the other hospital you are interested in. So there is no shyness in to say before meeting any people, hi, I am the fellow. I would like to learn about your background, or I just want to learn from you. Learning from new place or opportunities is critical. Opening doors to next opportunity. So this is a photo which is close to my heart. They are the best people who are just going. They are just every morning when you are in fellowship, they are going to say, "Ma'am, aaj ho jayega. Don't worry, sab ho jayega." Enjoy the ride of your fellowship. While I just want to mention at the end of it how important it to enjoy all the ups and downs. They are come along the fellowships and enjoy meeting new people with similar passion of your interest. Enjoy the social activities, all conferences, scientific session, live surgeries, and enjoy learning more about yourself along the way. To conclude the topic, post-graduation and fellowship program has taken a leap forward in our country in the quality as well as quantity. Has improved in every year. We are producing brilliant, hardworking, competitive, highly focused young ophthalmologists. Many leaders of the various ophthalmological societies are present in the meeting right now. It is imperative to orient all the fellows or all the trainees or all the new ophthalmologists towards the path of sustained career success. Thank you so much. These are some photographs. These are respected teachers who always guide me to do more, and my journey is still going. I just want to take the name. He is a Dr. Vijay Bajal, sir. He gave me my first SICS case in RIU Sitapur when I was not in OT. Yes, she is a Dr. Bitik Chaudhary. She is a HOD of Hindura Hospital. She is very good in research. He is Dr. Deepak Mishra. He is well-known figure in SSTC. We learned the tissue welding and lots of things with them. She is a Dr. Seema Bajaj. She is a HOD specialist. At the time I was doing senior residency, he taught me many oculoplastic surgeries. And she is Dr. Lakshmi Singh. He is a HOD of Dr. Era Medical College. She is very good at research. And this is my first photograph when I entered in RIU Sitapur to join ophthalmology. And all photographs of Dr. Mohita Sharma ma'am, under which I did my fellowship. And she needs no introduction. Thank you so much for kind listening. And if anything, any question or any query, I would like to take.
Thank you so much, ma'am. If any of the judges or anybody would like to say something.
So we have our next speaker, Dr. Devi Aishwarya Das is with us now. And she'll be speaking on Project Red. Ma'am, I hope you have joined.
Yeah, I'm there.
Right. Okay. I'm just waiting for screen share to stop. Then I can.
No, I think I've started screen sharing.
Okay. Can I give a? Can I take
Yeah,
5
yeah.
minutes, ma'am?
Yes, yes. Yes, please.
You'll have to stop your screen share.
Okay, okay. I have to stop. Okay. Let's stop.
Yes, yes, yes. I can do it right now, ma'am. And I should tell that ma'am is a very dynamic speaker, and she has been speaking in last few competitive sessions of every this state, and she will cover the Project Red. She is senior consultant ophthalmologist at Cuttack with an experience of 20 years. Her specialization is in cataract, general ophthalmology, refractive surgery, and LASIK. She has done her fellowship in comprehensive ophthalmology from Shankar Nethralaya and LVPI, done more than 15,000 cataract and other surgeries, including LASIK and corneal oculoplasty surgeries. Previously worked in JPM Rotary Eye Hospital for about 12 years. Her achievements include Adarsh Chikitsak Award in 2019 and Gold Medal in Honors in Ophthalmology and Physiology. So I welcome you, ma'am, today, and we all are waiting for your talk on Project Red.
Thank you. Yeah,
Yes,
so
you can share your screen now.
yeah. So before I share my screen, is it showing?
It's visible, ma'am. You can start
Yeah.
with your talk.
Yeah. So before I start, I would like to know from where you picked up that introduction, because that is quite old. Okay, anyways. So right now I work for Dr. Agarwal's, and I do cataract, cornea and refractive surgery. And today I'll be speaking on Project Red. So as you know, Project Red deals with the rare eye diseases. So like every other journey, this journey of 1,000 miles also began with a single step. So what is this Project Red? The Women's Ophthalmology Society initiated the following agenda to establish a national registry of rare eye diseases as well as rare aspects of common eye diseases. For this, we need to store data on demographics, clinical picture, course, counseling, treatment collected, and all this is collected and stored. This group was established in 2019. Financial disclosure, this is supported and funded by CIPLA. So this was the first publication done by Dr. Mohita et al. In IGO on what is Project Red. So what are the objectives of this group? To form a common cloud-based template customized to each disease under study, to give a common platform to all ophthalmologists working in any sector to record and report their cases, to find drugs or treatment modalities for these diseases from the existing therapeutics, as well as to initiate new drug discoveries. These all can be made possible subsequently, and to provide genetic counseling, rehabilitation, and support to patients and their families. So these were the objectives of this group. So there is no self-interest here. So this is in the way of creating a national registry. So till now, what has been done? The diseases have been identified. The ethics committee was formed, WOS had its own ethics committee formed, and clearance was taken. Investigators have been enrolled, team leaders and group coordinators were earmarked, and pro forma for patient data entry was finalized. And then team leaders, coordinators, and investigators have been sensitized via Zoom meets, which is done on a continuing basis. Now, almost every week, we are having one meet. So data entry has also begun. For this, a personalized link was given to each investigator. Then team leaders have access to the group data. Then after the data are collected, so we have kept a deadline of September 30th. The data compilation and analysis will be done, and then a central repository will be created. So what are the diseases that are currently being taken up under RED? The RP, Stargardt's, corneal dystrophies, ocular tumors, pediatric glaucoma, myopia, NTG, and the last has been now shelved because of logistic issues and difficulty in maintaining records during days of COVID. So right now we stand our data entry, which has begun, and for the time being, all data that are entered by 30th September are to be included for analysis. However, this is a continuing process, and we are open to including more investigators and gender no bias. So we can take male investigators also. If anybody is interested, they can enroll. But as of now, the data entered till 30th September will be included. So this is the link and username and password, which you can change after entering into the database. And subsequently, genetic testing and counseling will also be undertaken. And this will also, as part of objective of Project Red, this will also help create a national repository. And subsequently, we can do a genetic analysis to look into the rare eye diseases that still do not have a genetic basis or understanding. And then genetic counseling, rehab, and patient support programs will be started subsequently. For this, MedGenome is providing technical support. So this is all that I have to say for now. So we have lots of miles to cover before we can actually say we have done anything. And as I stop sharing, I would like to make a request, like if anybody is an investigator here, please make an attempt to make an entry of at least 1 to 5, any number of cases. You all must have been given your investigator link. And I am looking into the data that are fed into the 4 anti-segment diseases, and Dr. Anupama Kiran is looking into the posterior segment as well as ocular tumor groups. So with this, I end my talk. Any questions?
Thank you, ma'am, for this informative talk, and um, um, we thank you for giving your time for this session. Thank you, ma'am. Now, I'd like to invite Dr. Mohita, ma'am. She has just joined, and I'll give a brief introduction of her. It gives me immense pleasure to invite our WOS Secretary, Dr. Mohita Sharma, ma'am, to give a keynote address on WOS, where we are today. Dr. Mohita Sharma needs no introduction. She is an identity in herself, a name in ophthalmology, a leader, a teacher, mentor, guide, and words have no limit for her. She is a progress in ophthalmology. Just to give some information, I am sharing my screen. We all know her. She is Dr. Mohita Sharma, ma'am. And she is founder and chairperson of Tirupati Eye Center and Research Institute at Noida. Her specialty is ophthalmology, retina, cataract, and LASIK for past 30 years. She is General Secretary of Women Ophthalmologists Society of India, Women Ophthalmologists Worldwide Network. She is General Secretary of UPSOS, President Rotary Club of Noida, General Secretary GNEC Alumni, ex-President and Secretary Noida Ophthalmological Society. She is an ex-secretary of IMA Noida also, invited speaker for more than 400 national and international conferences. There are many awards to her name: WHO Honorary Award, Champions of Change Award, President Appreciation Award, Gold Medal by RSI in 2016. And there is a line of awards to her name. There are awards, multiple awards every year to her name. So this is just a small list presented in front of you. And I'll just like to invite her for her talk, as we are running a bit short of time. And ma'am, I'm stopping my screen share here and will request you to please start with your talk. Mohita ma'am.
Yeah, good afternoon, everybody.
Good afternoon, Mohita ma'am. Welcome to the UP program, ma'am.
Thank you. So, good afternoon, everybody. Yeah, you wanted to be saying something, Gargi?
I was saying that I wanted to tell you all that it's her. She was continuously busy today, also participating on behalf of various ophthalmologists in All India representation, and now she could manage to take out time for us. So I am thankful to you, ma'am, for this.
Thank you, Gargi, for the kind introduction. And thank you, Dr. Nilima Mehrotra and Dr. Smita Agarwal, our state heads, for putting this all together. Thank you to the young girls, Manupriya and Gargi, for conducting it so well, for having all the patience of your messages not being answered. Sorry for the busy schedule in the last few days. And but WOS is something which is close to not just my heart, but it is close to everybody's heart. And WOS is a society where everybody thinks it's their own society, and that's how we work and that's how we participate. And it's a pleasure to be with everybody. To all the residents, this is a different kind of a program today, because the whole idea is that we make you present under the guidance of your mentors. Now, somewhere we have been talking, and somewhere we keep hearing that the students are no longer what they used to be, and the students are very changed, and students are very demanding. That's what everybody keeps saying. But then we thought that maybe we need to bring about some changes in ourselves, where we reiterate the mentor-mentee relationship, and where we make the mentors realize how good it is to be mentoring others, and the mentees realize how good it is to be being mentored. They all already know that, but let this go out of our minds, that the mentor-mentee relationship is no longer what it used to be. It will always remain to be, it will always continue to be what it was all once upon a time, because we all know once anybody becomes a mentor, we've seen in our mentor-mentee programs, once we connect them to a mentor, it's a lifelong mentor-mentee association which happens. And it's a pleasure for both mentors and mentees. So thank you to the mentors also. Thank you to the judges for taking out your time. Now, whenever we talk about what is called a glass ceiling, we hear this term often, glass ceiling. So when I looked into the net, what a glass ceiling means, I was asked to present something on glass ceiling somewhere. Somehow they catch me for presenting anything related to women. So I found that all the photographs had men on the top and women on the bottom, or as you can see on the right side, 2 women and 1 man on the bottom, and the ratio becomes opposite on top of the glass ceiling, which means that this glass ceiling is a term which is for women in general, and for women ophthalmologists also. So does this glass ceiling actually exist? Yes, we realized it's a universal professional challenge which all women ophthalmologists feel, because we thought this was in India. When we went across the globe, we found that this is a universal challenge where there is a leaky pipeline. When as residents, when you start, you all are equals, but once you go ahead in your life, your surgical career and your family career coincides, and somewhere down the line you find yourself not doing as well as your male colleagues, or you find that you were not able to achieve how much you wanted. And many of us then go into a state of inertia. And the whole idea of WOS is to take you out of that inertia and give you opportunities, as well as to show you role models who have done that and who have done very well in their life. Now, it is also often said that many women are most of the ophthalmologists today are women, especially in those who are joining ophthalmology. But I would say, even if it was 100% women in ophthalmology, the challenges remain the same. So here we are to deal with challenges, and that's what we are trying. So now we looked into a lot of literature, and we found that everywhere women were faring a little less than men, whether it was industry ties or it was research, it was leadership in societies, it was chairs in conferences, it was even remuneration at a few places. So WOS was established in 2015 with all this in mind. But we have today around a little more than 2,500, almost 3,000 members, 22 state chapters, and 7 annual conferences have already been done. And the whole idea is that you should not be a part of the crowd, because this makes your soul suffer, and you have to be different. And the day you decide to be different, maybe the day you decide to also join WOS, because this is a day written in your stars, a date with destiny, and you would become more extraordinary by becoming different. That's the whole idea. So all our programs are based on mentor-mentee concept, where you are not alone in your professional journey. We started with this mentor-mentee program where there were 26 mentors, both men and women, and they started mentoring mentees. And then after that, there is no looking back on these, because all our programs are based on the same concept. You get a lot of speaker opportunities, just like you are getting today. These are all photographs that I'm sharing of various activities that keep happening all throughout the year. And if you want to be a part of them, any of you, whether seniors, juniors, we are most welcome to be a part of it. And it's your own group of women ophthalmologists who will never pull you down. They will support you in whatever you are doing. So we have a lot of first-time evers, like first-time ever mentored live surgery that we have done in WOS, where the juniors do the live surgery and the seniors are mentoring them. We have a lot of PG sessions, and all our conferences are based not just on clinical skills that you learn at so many conferences, but 50% program is also dedicated to life skills, which is also important in today's world. So we do WOS state chapter meetings, and the topics which we are covering nowadays in these are skill enhancement, women's health, finance management, and research. So there are certain things where women need more support, which whether it is finances or it is health or it is research, apart from skill enhancement and surgical, more exposure, and that is what WOS is working on. Project Archana is something which Dr. Anjali Mehta from Delhi is working on, and this is to do with dissatisfied patients, angry patients, violent patients, and mobs, which we often see nowadays and which has not been a part of our curriculum. Project Shakti, Dr. Jimmy I'm sure she has talked about it. Very passionate about this, Dr. JV is, and this is to do with your workplace challenges. And these may be small challenges, these may be bigger challenges, but we are part of this project. You get over these challenges and you are able to perform better. Women in Research, or WINR group, is a group, is a wing of WOS which is working on research. You can be a clinician as well as a researcher. You don't have to be a pure researcher, and that is what it gives you in the form of opportunities to be a part of research. These are all opportunities which are listed in the WINR website, where there are special calls for women researchers also. The RED group, the ambitious rare eye disease group, Dr. Aishwarya talked about. Dr. Aishwarya, Dr. Rupma, two ladies who are Anupama Kiran. These are two ladies who are working very passionately on this RED group, and you still have a chance to become an investigator in this group. So I will skip through RED. And WOS Care is another initiative of WOS being headed by Dr. Shweta Walia, and which is to do with short-term fellowships. Now, once you're out of your residency, you start wondering, what should I do now? You may be able to do long-term fellowships, but you may also need short-term fellowships and short-term trainings in certain subjects. For example, we often see that many times you pass your residency and you don't know how to do a cataract well. So there may be a short-term training opportunity for you. You may have never seen a LASIK. There will be a short-term LASIK training opportunity for you. So because you have to be, ultimately, you may super specialize in one thing, but you have to be a comprehensive ophthalmologist along with super specialty. We started an initiative called Women Ophthalmologists Worldwide in 2020, and this has 29 countries involved in it. This was the first conference of WOW. And this, if you become a member of WOS, you're automatically a member of WOW. You just have to go and fill up a form there, and it's complimentary for you. And then you get a lot of opportunities to network with international women ophthalmologists. Then this was the last WOS annual conference in 2023 at Varanasi. And in 2024, we started with sessions within conferences, as well as our state chapter meetings, as well as our resident programs, which are virtual, which is happening now. And I've already told you about Project Archana. So these are all the plethora of things that are happening at WOS. And we invite you to the annual conference, which is happening in October 4th to 6th in Delhi. And as you can see on the right side, the instruction, it's all based on instruction courses. It's a theme-based conference in which there are clinical ICs as well as non-clinical ICs, something which you will not hear anywhere else, but you would really needed for professional and personal growth. And apart from SSTC and all other things that happen in any conferences. So WOS is an opportunity where women ophthalmologists like you and me can become extraordinary in their profession. And we all work on the concept of givers gain, which means more we give, more we get. So everybody here, when you attend any event, you will find that they're all in the mood to give to you rather than to take anything from you. Thank you.
Thank you, ma'am, for your ever motivational, enthusiastic talk. And there is a lot to learn always. And I must say that when I did my PG, I too was a bit clueless about getting more surgical experience and training. And I met ma'am at the WOS platform, and she, under her guidance, I did my first PECO training, and it was a really good one. And today, whatever I am doing is just because of her guidance.
And I must say, we feel so proud that Gargi is practicing in a place called Bulandshahr in UP, which was totally, it was male dominated, and it's a smaller town, very difficult to practice there, and to be, as a female, to be recognized by patients. But today, a lot of patients come and tell me about her. And when I see the good cataract surgeries and otherwise the good work that she's doing, it's a real proud feeling. I feel that WOS is serving its purpose, what it should be doing. She's a true example of one such person. And I'm sure she can be a mentor to many now.
I salute to your group, ma'am. Thank you. Now we should start with our competitive session 3. I regret for the delay. We are already running 1 hour late, and I'd like to invite our judges. I hope our judges have joined. Dr. Shweta Walia ma'am, Dr. Sudipta Ghosh, Dr. Shanti Pandey. Dr. Shweta Walia ma'am, are you here?
Yes, I'm here.
I'll just go through a brief introduction, ma'am. So our first judge, Dr. Shweta Balia, ma'am, we all are so very well known. She is such a known person. She is the coordinator of the WOS resident competitive session, and she is Professor MGM Medical College Indore, Joint Secretary MP State Ophthalmology, Ophthalmic Society. She has more than 50 publications in national and international journals, contributed chapters to Hindi ophthalmology textbook, and innovated technique of sutureless glueless SFIOL in 2016. She has many awards to her name. Few include All India Talent Search Award by then PM Shri HD Dev Gowda, Best Teacher Award at Indore Annual Medical Publication Award, NICA Award. She was awarded Excellence Letter by Indore Collector and Minister Kailash Vijayvargi during 26 January parade for exemplary work done to promote eye donations in the city of Indore. I welcome you, ma'am. Our next, thank you. And our next judge is Dr. Sudipta Ghosh. Ma'am, are you there?
Yes, I'm here.
Okay, okay. And she is.
I'm working at Narayana Tagore Hospital. I've
Yes.
done my shift from Melbourne 2 years and Sydney, followed by Sydney. And then I'm at Narayana Tagore Hospital and I'm working under the department of a multi-speciality hospital. And I cater to comprehensive ophthalmology patients as well as glaucoma and cataract patients. Thank you so much.
Correct, ma'am. Thank you. Thank you so much, ma'am. And our third judge, Dr. Shanti Pandey, ma'am. She is professor in HOD ophthalmology at Government Doon Medical College, Dehradun. I hope, ma'am, you have joined. Dr. Shanti Pandey, ma'am. Okay, so let's start with our first speaker. We have 6 speakers in this. We have 6 speakers here, and from 3.
Dr. Shanti, ma'am? I don't think she's in the meeting.
I also just tried to call her, but her phone was not received. Maybe she might be on the way somewhere. She must.
Just try calling her again once.
In the meantime, I'll just tell that in this session 3, we are having 6 speakers from 3 medical colleges, and are you, Dr. Manupriya, are you trying to get in touch with her?
she's not picking.
Meanwhile, we could start. She could join later.
That will be right.
Go ahead, Arghya.
This is the first presenter is Dr. Jyotsna Shri from SRMS Bareilly under the mentorship of Dr. Nilima Mehrotra. Dr. Jyotsna, are you there? Dr.
Yes,
Jyotsna?
ma'am. Hello. Good afternoon, ma'am. Yes, ma'am. I've joined.
Welcome, Dr. Jyotsna.
Thank you, ma'am.
Please start your screen share.
Oh, yes, ma'am. Yes, ma'am. I have shared my screen.
So you can, are you ready with the talk so we can start the talk?
Yes, ma'am. Just a second. I have started.
You already know the rules. We are having 4 minutes for this presentation. Okay? Okay.
Okay. Good afternoon, everyone. Thank you for this opportunity. I'm presenting the case of Mr. Ali, 62-year-old male, laborer by profession, resident of Bijnor, Uttar Pradesh. Prior consents were taken for the disclosure of his identity. He presented to our OPD with painless nodular lesion at right lower lid for 8 years, progressive right eye diminution of vision for 1 year, and discharge and redness in right eye for 2 months. History of presenting illness was a small mass was noticed in 2016. First medical opinion was sought in 2018. In a tertiary care center in 2021, lesion was biopsied and surgery was advised, but patient refused. Meanwhile, numerous healthcare providers consulted were consulted, and he was finally referred to our center. He gives no history of diplopia, trauma, ocular surgery, fever, or watering. He gives no significant past history. Family history is insignificant. In personal history, he gives history of prolonged exposure to sunlight was present in past, which was occupational. Examination was done. His vitals were found to be normal. General examination and systemic examinations were found to be within normal limits. In ocular examination, right eye showed uncorrected visual acuity to be 624, and extraocular movement was restricted in all gauges. In right eye, on inspection, an ulcerative lesion of size 4 into 2 centimeter was found, extending medially from nasal breech to the lateral canthus. Borders were well defined with rolled edges. Surface was ulcerated with crusting within. Base was had sloughing with pigmentation in between, and margins were irregular. Palpation was done to confirm the inspectory findings, and ulcer was found to be non-tender with firm consistency and surrounding induration, and it appeared to be fixed to the underlying bone. In right eye, congestion was present, conjunctival congestion was present, and lens showed early cataractous changes. Fundus was found to be within normal limit in both of the eyes. These are a few pictures of the patient. Investigations were sent. Routine blood investigations were within normal limit. Viral markers were non-reactive. Incisional biopsy and CE-CT orbit were done elsewhere. CMRI was done in our center, which was reported as a lesion in right lower lid, measuring approximately 10 into 15 into 10 millimeter, and it was heterogeneous on post-contrast enhancement. On CT correlation, there were focal cortical erosion in floor of orbit, and infiltration was seen into the extracorneal fat plane with loss of fat plane with anterior aspect of medial rectus muscle. These are some of the images of the MRI. So management was decided in a multidisciplinary tumor board meet, and it was decided to proceed with the surgery. These are some of the intraoperative pictures of the patient. Skin incision was marked. Upper incision was marked 2 mm beyond the eyelash line. Skin incision was deepened. Upper eyelid dissection was done. Periosteum along the orbital rim was incised till the orbital apex. Maxilla was resected en bloc with the orbital contents. Bone cuts were outlined as shown in the picture. Bone cuts were taken. Curved enucleation scissor were introduced posterior orbit to cut the optic nerve. Hemostasis was achieved, and specimen was sent for histopathological examination. These are some of the post-operative progress images of the patient. Histopathological examination report showed basal cell carcinoma 4 into 1.7 centimeter of size. Underlying bone was eroded, and posterior margin was found to be positive. This is picture of the histopathological slide of the patient. So it was decided to proceed with adjuvant radiation therapy for the patient. So to summarize this case, this is a case of advanced basal cell carcinoma where extended orbital exenteration with medial maxillectomy with reconstruction was performed. A timely diagnosis would have given a better outcome, and it shows the importance of multidisciplinary approach in such patients and counseling them for early diagnosis and treatment. Thank you, ma'am.
Judges, please note the participant was well within the time limit. Dr. Joseph, you can stop sharing.
Yes, ma'am.
So, judges, Dr. Shweta, ma'am, you have to ask any question.
Excellent presentation, Dr. Jyotsna. Everything was covered and I think accidentally managed. But I would like to ask, what are the differentials for any mass with an SR?
Ma'am, a mass, basically, it was a skin lesion. It could have been squamous cell carcinoma or a melanoma or any benign tumor involving the upper layers of the skin.
Any other infection that also has an SR or a necrotic tissue?
Ma'am, cutaneous tuberculosis can also show with, very, very rarely it can show with such similar presentation.
Okay. Okay. Nicely managed.
Thank you, ma'am.
So, Dr. Sudipta, ma'am.
Yes. Dr. Jyotsna?
Yes, ma'am. Good
Yeah,
afternoon.
very well. Good afternoon. Very well presented. What would happen if no intervention would have been done in this patient? Because it was a long-standing case. The patient is already 71-year-old. He's living with this for probably 10, 15 years almost down the line, right?
Yes, ma'am. Around 8 years, ma'am.
So what
Yes,
happened? Leave it alone?
Ma'am, further optic nerve involvement would have happened. The lesion could have metastasized, which is very rare in basal cell carcinoma cases. It could to the most commonly to the cervical lymph nodes, and then maybe to the brain or lungs.
The patient had good vision. 624 was a workable eye, but we had to enucleate the eye.
Yes, ma'am.
So in such cases, was the patient aware that something of this sort was going to happen to him?
Ma'am,
Like
the
you are
patient
going
was.
to enucleate the eye during.
Ma'am, initially for 6 to 7 years, he tried to avoid. He was in 2021 in another tertiary care center. He was advised for surgery and to proceed with the surgery, but it was also a case of neglection towards his disease. And further, when at the end of 8 years, when he knew nothing can happen, then he was very much matlab, eager and ready to go with enucleation or exentration, whatever is required.
How
Because
many
at
years
this
post-op
time,
now?
yes, ma'am.
How many years of post-op now? 2024? Like when was the OT done, operation done?
Ma'am,
When was the surgery done?
Ma'am, it was done last month. He presented in July in
Last
our
month.
department. Yes, ma'am, on 13th July. And now his radiotherapy is to be started next week.
Yes, that's what I'm coming to. So what is the next procedure that you are planning to do?
Ma'am, he is to be kept on radiation therapy, basically EBRT, for next week onwards. And it will be handled by the radiation therapy department.
Okay. Any role of chemotherapy in such cases?
Ma'am, no, ma'am, rarely.
Any history of metastasis? Currently, no.
No, ma'am.
Any? What is your plan for cosmetic purpose?
Ma'am, our first initially, matlab, the main approach was using glasses maybe for now, because our main motive was to stop metastasis of any kind. So our main motive was to do surgery on time, and the patient was for that time he was counseled. So we were concerned to avoid any kind of metastasis to any nearby structures.
Can you go back to the post-op picture?
Yes, ma'am. Sorry, ma'am.
Post-operative picture.
Yes, ma'am. I shared. Yes, ma'am. I shared one.
Post-op.
Yes, ma'am.
After exam.
Ma'am, this is post-op day 3.
अरे प्रेजेंट करना है
What is that long thing from the nose, from the eye to the nose?
Ma'am, that is the paramedian flap that was taken from his forehead, and the flap was put over because to make a cover, to cover the area.
Why is there so much of pigmentation over his forehead?
Ma'am, it was the skin graft because flap was taken from it. So skin graft was put over there. Gradually, it will heal.
Now, why is it? What is the black thing? Is it pigmented, or what was used to take the flap?
Ma'am, it was the extra skin which was not sutured, which was the extra skin outside the margin. So it is gradually necrosing and falling off.
Okay. Right. Okay. Well done. Thank you so much.
Thank you, ma'am.
Our third judge, Dr. Shanti Pandey ma'am, has just joined. Welcome, ma'am. Ma'am, can you hear us?
Yes. Good afternoon to all. Good afternoon to all. And Dr. Jyotsna, what is your final diagnosis?
Ma'am, it was a case of basal cell carcinoma.
Okay, basal cell carcinoma. In your case, upper lid involvement is more or lower lid?
Ma'am, lower lid involvement was seen, but gradually yes, ma'am, lower lid involvement was there.
Gradually. And how you have confirmed the diagnosis? What you have done for that? Prior to do the reconstruction and incision surgery, how you have confirmed the surgery prior to that? कैसे confirm किया आपने diagnosis? आपने
Ma'am,
diagnosis
incisional biopsy was sent, histopathological
what you have done
slide.
the incisional biopsy during the excision procedure, and what measures you have taken if you are suspecting the BCP, then how much extra skin you have removed, and from where you have done the taken the rotational graft.
Yes, ma'am.
Okay, temporal rotation. And क्या इसमें आपको temporal side से क्यों लेना पड़ा? क्या upper lid का involvement कितना था? How much lid you have excised in this?
Ma'am, I can show whole of the lower lid. This area was involved. So we had to raise a flap to this area so that it could cover
How
all
much
of the.
normal? Do you use the frozen section biopsy during the excision?
Ma'am, frozen section biopsy was sent, and that time it was shown the posterior margin and everything was showed to be cleared. It was on histopathological slide examination when the reports came that posterior margin was found to be positive, and that's why now radiotherapy has been planned for the patient.
Okay. Okay. Thank you very much. Nice presentation. Thank you.
Thank you.
Thank you, Jyotsna. We are moving towards our next speaker. Dr. Anugya Singh was supposed to present, but because of some emergency conditions, she is not presenting today. In her place, Dr. Akansha Vash will be presenting from SRMS Bareilly under the mentorship of Dr. Nilima ma'am. So, is Dr. Akansha ready?
Good afternoon, everyone. Yes, I'm here in the.
So, Akansha, you can start sharing your screen.
Yes, ma'am. A very pleasant afternoon to everyone. Myself, Dr. Akansha Vesh. I am JR1 in Department of Ophthalmology from SRMS Bareilly. I am presenting a case report on ocular surface squamous cell neoplasia under the guidance of Dr. Nilima Mehrotra ma'am. I am presenting the case history of Mr. Ramchand, 47-year-old male, who is electrician by occupation, resident of Bareilly, who presented to the OPD with the chief complaints of mass in the right eye since 3 months, along with foreign body sensation in the right eye since 3 months. The case is discussed after prior consent from the patient. The mass in the right eye since 3 months, which was gradual in onset, progressive in nature. It was painless, associated with foreign body sensation. There is no history of diminution of vision, itching, discharge, diplopia, trauma, ocular surgery, proptosis, redness, no systemic ailments, no weight loss, no history of blood transfusion. Past history, there's no history of diabetes, hypertension, asthma, TB, thyroid, no history of any CVS or CNS disorder, no history of any skin lesion or any other systemic disease, no history of any previous hospitalization. Family history is no similar complaints in the family. Personal history, patient is mixed by vegetarian by diet, normal sleep-wake cycle, normal bladder bowel habits, no addiction to alcohol, tobacco, or any other substance abuse. Moving to the examination, the patient is sitting comfortably on the stool with average built-in nutrition, well-oriented to time, place, and person. Vitals are within the normal limit. Moving towards the systemic examination, the systemic examination and general examination are within the normal limits. Ocular examination. Uncorrected visual acuity is 6/6 in both eyes. Near vision N6 in both eyes. The intraocular pressure done by Goldsman tonometry is 14 mm in both the eyes. Extraocular movements full and free in all gazes. Examination, lid normal. Conjunctiva, the right eye conjunctiva shows pinkish white mass, approximately 2.5 to 1.5 centimeter, about 1 centimeter nasal to the limbus. The cornea in both the eyes is clear. Anterior chamber is normal. Iris is normal color and pattern. Pupil is round, regular, and reactive in both the eyes. Lens is clear crystalline lens is found. Fundus is within the normal limits. with the CDR of 0.3:1. FR is present and macula is healthy. Differential diagnosis could be pterygium, limbal dermoid, conjunctival intraepithelial neoplasia. Investigations were sent, which include CBC, ESR, stool examination, RBS, bleeding and clotting time, PT-INR, APTT. All of them were within normal limits. The patient was managed with excisional biopsy, and biopsy was sent for histopathological examination. Preoperatively, we gave eye drop moxifloxacin and dexamethasone 0.1% 3 times a day, along with an eye ointment, hydroxypropyl methacellulose 3 times in right eye. Surgical management was done, wherein right eye excisional biopsy was done under local anesthesia. This is the post-operative picture, day 1 of mass excision. On histopathology, excised cyst was sent for histopathological evaluation. The report suggestive of tissue lined by keratinized stratified squamous epithelium with focal dysplasia, hyperchromatic nuclei with irregular nuclear membrane, inconspicuous nucleoli, and moderate amount of eosinophilic cytoplasm. Individual cell keratinization and occasional keratin pearls were noted. The surrounding stroma showing dysplasia with mild lymphocytic infiltrates. Post-operatively, the patient was given eye drop moxifloxacin and dexamethasone to be instilled 4 hourly in both the eyes. Eye drop, eye ointment, hydroxypropyl methacellulose 0.3% 8 hourly. Tablets Fixim 200 mg BD for 5 days. Prednisolone 40 mg OD for 7 days. Tablets Serratiopeptase and paracetamol BD for 5 days. And pantoprazole 40 mg OD for 7 days. Summary, a 47-year-old male presented to our OPD with right conjunctival mass. Blood investigation and imaging was done to rule out systemic involvement. It was managed surgically by right eye mass excision. Biopsy sent for histopathological examination revealed squamous cell carcinoma. The overall prognosis of OSSN with perfect margin clearance is good with less recurrence rate. To conclude, ocular surface squamous neoplasia is a disease affecting the limbal stem cells and can have conjunctival, corneal, or conjunctivocorneal involvement. Timely and adequate medical and surgical treatment usually salvages the eye in majority of the cases. Thank you.
Excellent presentation, Akanksha.
Judges, please note, the participant took 4 minutes and 15 seconds.
Dr. Akanksha?
Please continue.
Excellent presentation. I would like to know what was the size of that mass?
Ma'am, it was around 1.5 to 2.5 centimeter.
And how much free margin did you take while excising it? And ideally, how much of normal conjunctiva has to be taken while you are excising it? Am I audible?
Yes.
Beyond the mass, how much of normal conjunctiva needs to be excised when you are going for excision in OSSN case? Okay. Do we have any other anti-mitotic drugs that can be used for such OSSN case? Can you name any 1 or 2 drugs?
Ma'am, mitomycin C can be used and 5-fluorouracil can be used.
And in what concentration?
Ma'am, mitomycin C is used, ma'am. It can be given topical or it can be given subconjunctival. When it is given topical, then ma'am, around 1 million international unit per ml is used. And for subconjunctival, 3 million international unit per 0.5 ml is used.
We don't give it subconjunctivally. We either use it in pledget form, but I'm asking what concentration of mitomycin C is used. Do you know how much milligram of powder is available, and how do you reconstitute it to form the drops or the liquid for application when you are doing excision? Okay, okay. Thank you, Dr.
No problem.
Akanksha. Over to other judges.
Akanksha, are you here?
Yes, ma'am.
We can't see you actually. Can you please stop sharing your screen? And we want to see you.
Yes, ma'am. Yes, ma'am.
Yes. Can you stop sharing your screen?
Akansha, stop sharing your screen. It will be on the top. Done.
Where are you, Akanksha?
Yes, ma'am.
Okay. Akanksha, lovely presentation. Where did you get the background from? Your presentation background? I'm seeing Manupri. I don't see Akanksha in the screen. Akanksha, you need to speak.
Akansha, you need to speak.
Yes, ma'am.
I don't see you.
Ma'am, my camera is
Say,
not.
अभी अभी फिर से गई.
Yes, ma'am.
So which year are you?
Ma'am, first year.
First year. How many months now?
Ma'am, 11 months.
11 months. So you, in your differential diagnosis, you said OSSN and pterygium.
Yes, ma'am.
So on clinical examination, can you differentiate between the two?
Yes, yes, ma'am.
How?
Like, ma'am, pterygium is typically present as a triangular fold of conjunctiva that encroaches the cornea.
And
And we, ma'am,
pterygium can be two types. Can you tell me?
yes, ma'am. Pterygium can be of progressive type or regressive type.
Do you usually operate the regressive one or the progressive one?
Ma'am, the progressive one.
Right. So what do we do actually in a pterygium?
Ma'am, it is excised, ma'am. If the pterygium is encroaching the cornea and it is obscuring the visual axis, then we try to remove it to maintain the visual.
What else do we do?
Ma'am, to prevent recurrence, we
Very good.
usually cover it with some amniotic membrane graft or subconjunctival conjunctival
Conjunctival
enamel
autograft.
grafting, amniotic membrane grafting.
Very nice. Perfect. Can pterygium recur?
Yes, ma'am. Pterygium can recur.
So to prevent recurrence, what can we use? You just said the answer previously.
Ma'am, mitomycin C injection.
Very good. Very good. Good. So in this case, what you presented, there was no involvement of the cornea, you said.
Yes, ma'am.
Okay. So what made you think of squamous cell? Usually we don't send the pterygium specimen for histopathology. So what
Yes,
made you send this? Was it the look?
Yes,
Was
ma'am.
it the look of the lesion?
Yes, ma'am. It was pinkish white in color, whereas
It wasn't looking very healthy.
No, ma'am.
So any findings in the other eye?
No, ma'am. Other eye was within the normal limits.
Okay. How long was this lesion in the eye?
Ma'am, 3 months.
3 months. And what did the patient notice that it was progressing?
Yes, ma'am. He complained with foreign body sensation.
Foreign body sensation. Okay. Okay. Any other pathology? No other pathology anywhere else.
No, ma'am.
So after excision, what happened to the patient? How is he?
Ma'am, he is fine now. He is doing better.
Better.
Regular
Any
follow-up.
other post-operative medication he needs to be on the long run or something of that sort? Any idea? Long term कुछ करना है उनका? Like follow-up वगैरह?
Yes, ma'am. He is on continuous follow-up to look for.
Can these squamous cell things recur?
Yes, ma'am. They are prone to recur.
Very good. I liked your presentation. Very well done, PowerPoint. Excellent.
Thank you, ma'am.
All the best.
Thank you.
Thank you.
Dr. Shanti, ma'am. she's not. Yes. Okay. I think so. There is some net. Shanti ma'am is here. Ma'am, any question from your side? Shanti ma'am, you have muted yourself. Any question from your side? Ma'am, you have muted yourself. Dr. Shanti ma'am, you have muted yourself.
Yes, ma'am.
Okay, good afternoon to all. I think all
Good
the
afternoon, ma'am.
questions and all the part of this presentation has been covered. My question is this: for the final diagnosis, I think it was the OSSN.
Yes, ma'am.
OSSN is the final diagnosis. Tell me what technique we use to excise the OSSN. Suppose we are suspecting the OSSN, not the pterygium, then what technique we use for that? And what extra precaution we take? We just we excise as a simple mass, and any other technique we use for that. And what treatment, what drug we prescribe? We usually prescribe after the excision of this.
Ma'am, usually topical lubrication is very important.
What technique we use during the excision? Okay, fine. Yeah, it was a nice presentation. Thank you very much. Thank you.
Okay, thank you, Dr. Akansha. Now, we are moving to the next speaker, who is Dr. Sanchita Gupta from Sharda College, Noida, under the mentorship of Dr. Charu Malik. Dr. Sanchita.
Good afternoon, everyone. My case presentation. So a 54-year-old male presented with the chief complaints of sudden onset of painless loss of vision in his left eye after heavy weight lifting 3 days back.
Can you please put it on full screen?
Full screen.
Click on the
Just a
play
second.
button. Click on the play button down, the orange one.
Is this fine?
No.
Just a second.
Slideshow. You just press
Yeah,
this.
I have put it on slideshow only.
Okay, play button. Very
Just a
good. Very
second.
good.
Yeah. Is this okay? Actually, it's not. I have clicked on the play button, but still not
Right hand
sharing
side lower corner. Is there?
completely. Yeah, I did that only. This play button, and I'm clicking. It's showing on my screen. If you can give me a minute, I can do it. I've done maximize. Wait a minute.
Please start, Charu. Sanchita.
Okay, all right. I'll start. So a 54-year-old male presented with complaints of sudden onset of painless loss of vision in his left eye after heavy weight lifting. I think it's still not moving. If you can give me a minute, I'll do it on.
It's moving. It's moving.
I'll just do it like this. Yeah, I'll do it like this.
Okay.
So a patient was apparently asymptomatic 3 days back when he developed loss of vision in his left eye after heavy weight lifting, which was sudden onset and profound in nature and painless. There's no history of similar complaints in the past: hypertension, diabetes, hepatological disorders, and trauma. His personal history was normal, and family history was insignificant. His medical history was also insignificant. On systemic examination, his general condition was fair, with PP of 128 by 72 mmHg, and there were no pallor, scrubbing icterus, cyanosis, lymphadenopathy, and petechiae. Test of the systemic examination was also normal. So my right eye anterior segment and posterior segment was normal. The fundus was normal. In the left eye, the vision was 1/60 with no improvement, and the rest of the anterior segment was normal. The fundus examination revealed a board-shaped pre-retinal hemorrhage covering the macula as well as along the inferotemporal arcade was present, which was around 3.5 disc diameter in its horizontal extent, 2 disc diameter in its vertical extent. There was also a vitreous hemorrhage seen along the nasal border of the disc. So we went ahead and got investigations done, blood investigations. Blood sugar was normal, blood pressure monitoring was started. ESR, complete blood profile, RFT, coagulation profile was within normal limits, and PET blood smear did not reveal any abnormalities. We came to a provisional diagnosis of right eye, no abnormality, and left eye premacular hemorrhage secondary to valsalva retinopathy. So for management, in order to quickly resolve this hemorrhage with consequent restoration of visual acuity, retinal anatomical changes, NDI hyalodotomy was performed with the aid of a Goldmann 3-mirror contact lens in the most protuberant part of the subhyaloid hemorrhage with the drainage of hematic fluid by adaptation action. YAG laser was delivered with energy starting from 2.5 millijoule with no therapeutic success at first. Thus, the energy was gradually intensified with increases of 0.5 millijoule with the rupture of posterior hyaloid occurring at a final power of 4 millijoule. This was the picture that was seen after 2 minutes after NDI hyalodotomy. 1 week after the procedure, the patient had substantial improvement in the visual acuity of 6/18, and the fundus examination revealed delimitation of the former hemorrhage without the presence of blood in the foveal area. And 1 month, the visual acuity was 6/9, and fundus revealed a small residual hemorrhage inferior to the macular area and resolution of the vitreous hemorrhage. So Valsalva maneuver was first defined by Antonio Mario Valsalva. It is the location of the hemorrhage can be ILM or subhyaloid, and this situation usually emerges from the increase in intrathoracic or intra-abdominal pressure, which associated with the absence of walls in the venous system rostral to the heart, provides an increase in intraocular venous pressure with consequent rupture of superficial retinal capillaries. Overall, pre-retinal hemorrhages secondary to Valsalva maneuver are self-limited and may last from a few weeks to months until complete resolution. And given the slow resolution of hemorrhage, there is a close and prolonged contact between the inner retina and hemoglobin or iron, causing damage associated with its proximity. This process results in decomposition of the ILM with subsequent migration, proliferation of glial cells into vitreous cavity and subsequent formation of ERM, resulting in long-term visual decrease in visual acuity. So we need to do this only when the bleeding area exceeds 3 disc diameters. We can also go ahead with other mode of treatment like observation, but again, that may lead to adverse events. And we can also go ahead with a surgical intervention using fast planner vitrectomy. So the take-home message with this is a prompt diagnosis of Valsalva retinopathy and further management via NDI laser can allow us to treat the patient with expectant result of good visual prognosis. It offers a simple, relatively safe, non-invasive treatment option for drainage of subhyaloid hemorrhage. Thank you.
Thank you, Dr. Sanchita. Judges, please note that the participant was well within the time limit. We can start the discussion now.
Dr. Ma'am, Shweta ma'am.
Excellent presentation, Sanchita. I just want to know that how will you confirm that whether the hemorrhage was sub-ILM or subhyaloid? How will you confirm that?
So, ma'am, clinically, if you're going to do it clinically, so the subilum is a very sharp demarcated and it has a glistening reflex. But if we have to confirm it, then we can go ahead with an OCT. So OCT will reveal if it is an subilum, so there will be a very highly reflective layer will be there. And if in case it is subhyaloid, then there's it is a patchy but not that reflective layer above the hemorrhage can be seen. So that is how we can confirm our diagnosis.
So in your case, you had done OCT?
No, ma'am, we had not done the OCT because we were at a peripheral center when this patient had visited us. So we did not have an OCT there.
My question is, will the sub-ILM hemorrhage also resolve with the laser?
Ma'am, the sub-ILM hemorrhage, ma'am, if we are giving, so it will just drain because if it is both, usually it is subhyaloid and sub-ILM as well. So that is why it will, if there is both of them. So that will also resolve in case if we are giving a laser. But the confirmatory test will only be able to tell if we are doing a vitrectomy and then a biostaining of the layer is to be done. And then we can go ahead, we'll be able to confirm.
Yes, the sub-ILM, for sub-ILM hemorrhage, usually ILM peeling is needed to drain the hemorrhage. It doesn't drain with the Nd:YAG laser. What frequency of Nd:YAG laser is used?
Ma'am, 532 nanometer we use.
532 double frequency.
Yes, ma'am.
It is a normal Nd:YAG laser that is used for capsulotomy that is used. That frequency of that is?
Ma'am, 256.
1064. It's okay. Good. It was nice presentation.
Okay, ma'am. Thank you, ma'am.
Good presentation, Sanchita. Well done.
Thank you.
And your excellent documentation was very nice, the photographic representation of your case. What can be the other causes for a formation of subhyaloid hemorrhage?
Ma'am, it can be because of hypertensive retinopathy. Then it can be because of sickle cell anemia, anemic retinopathy. Apart from that, we can have ruptured macroaneurysm. And even in cases of venous occlusion and diabetic retinopathy, that can this picture can be then. Also, trauma can lead to subhyaloid hemorrhage.
Can you name some intravitreal injection?
Ma'am, for this case?
Any intravitreal injection which we inject in cases where there is macular edema or CSME?
Ma'am, ranibizumab, we give ranibizumab. Then apart from that, we can implants are there, so that we can give all injections. Ranibizumab is there.
One more thing.
Tricot we can give.
You said you like the blood will subside with gravity, right? What instruction would you give to the patient?
We will ask the patient to, ma'am, to sit in a erect position, and so that the gravity can do
propped up position.
But propped up position, and not.
I just missed that. The initial vision on presentation was?
Ma'am, 1/60.
Okay. Okay, well done. Good. Thank you.
Thank you, ma'am.
So, Dr. Shanti ma'am is there. Ma'am, unmute yourself, please. Dr. Shanti ma'am, can you hear us?
No.
So, okay.
Let's move on to the next speaker.
We are moving on to our next speaker, Dr. Arpita Singh from Sharda College, Noida, under the mentorship of Dr. Holmes. Dr. Arpita, you can start your screen sharing.
Okay, ma'am. Ma'am, is my screen visible?
Yes, very much
Okay,
visible.
Good afternoon, everybody. I'll start my case presentation. An 18-year-old male, Hindu by religion, resident of Greater Noida, came with a student by occupation, came to our OPD with chief complaint of reddish painless growth and foreign body sensation in his left eye since 6 months. Patient was apparently asymptomatic 6 months ago when he noticed when he noticed small red mass in his left eye, which was painless and was gradually progressive. It was associated with foreign body sensation. There was no history of trauma or ocular surgery in past. There was no history of fever or weight loss. There was no history of any vascular abnormality in skin or any other mucosal site in head and neck. No history of similar lesion on other surfaces in his body. The personal history was normal. Family history, there was no significant family history. In general physical examination, the general condition of the patient and the systemic condition was within normal limit. Coming down to the ocular examination, head and chin posture was normal. Facial symmetry was bilaterally symmetrical. Orbit did not have any tenderness. Since the right eye was completely normal, we'll move ahead with the left eye examination. The visual acuity in the left eye was 6/6. Color vision was normal. The eyeball was of normal shape and size and orthophoric. EOMs were full and painless. Eyelid was normal in position. Movements, skin lashes, and lid margins all were normal. In conjunctiva, there was a multilobulated bright red, smooth, and vascular lesion measuring approximately 5x5x4 mm with tortuous dilated and gorged vessel at the base of the lesion. In the infratemporal region of bulbar conjunctiva, the lesion was mobile with the conjunctiva and was non-pulsatile and did not increase in the size on Valsalva maneuver. All other anterior segment examination of the left eye as well was normal. So this was the mass. We can see it was present in the infratemporal part of the bulbar conjunctiva, and this is a more clear picture where we can see a multilobulated mass in which we can see around the base there were tortuous and dilated vessels, and it did not increase in size on Valsalva. The fundus examination of both the eyes were within normal limit. So my provisional diagnosis was right eye within normal limit and left eye subconjunctival cavernous hemangioma. We also did a B scan to rule out any intraorbital involvement. So B scan was clear. Investigation which we got done was CBC, ESR, tridot, bleeding and clotting time, chest X-ray, Montauk's, and B scan all were within normal limit. We moved on to the management with eye drop timolol 0.5% twice a day in left eye, and then we planned for an excisional biopsy. On histopathological examination, the section showed large pools and spaces lined by a single layer of endothelial cells and are separated by fibrous stroma. Large spaces filled with blood and hemorrhages were seen with dilated vessels. So this was the post-excision picture. This was day 4 of post-op, and as we can see, the lesion site looked healthy, and the patient did not have any complaint. So my differential diagnosis were conjunctival capillary hemangioma, conjunctival papilloma, ocular surface squamous neoplasia, and pyogenic granuloma. Thank you.
Judges, please note the participant was well within the time limit.
Dr. Shweta ma'am, you can start with your discussion.
I have just one question. It was excellent presentation and everything was covered. Why was timolol started in this patient?
Ma'am, it is being seen in hemangiomas patients, mostly in capillary hemangiomas. We can either go ahead with systemic or with topical beta blockers. These have effect in vasoconstriction as well as they decrease the growth of the proliferation of the capillaries. That is why we started with topical timolol.
And for how many days it has to be given before we notice this change?
Ma'am, we just, sorry ma'am.
Continue.
No, ma'am, our ultimate treatment plan was for excisional biopsy, and we gave it for 7 days, and then after that we planned the patient for the OT.
Okay. Good.
Dr. Sudipta ma'am, you can
Yes,
ask your questions.
excellent presentation.
Thank you.
What you mentioned something about the role of Valsalva maneuver in increasing size. What did you want to rule out?
Ma'am, capillary hemangioma as well as varices, conjunctival varices.
What happens?
Ma'am, when we ask the patient to perform the Valsalva, the size of the lesion or the growth increases.
How is it? Okay. Now, what was your final diagnosis ultimately? You gave a differential diagnosis at the end. What was the final diagnosis?
Subconjunctival cavernous hemangioma.
Okay. And is there any recurrence in such cases?
Yes, ma'am. That's why we keep the patient on follow-up of 6 months, and because there are very less cases which have been reported, so we do not have exact what is the recurrence rate or how soon the recurrence occurs. So that's why we keep the patient on follow-up of 6 months.
Are you aware of the surgical steps?
Yes, ma'am.
Can you tell me?
Yes, ma'am. Ma'am, in this patient, we took a margin of 1 mm from all the from the circularly, and then we excised the mass, and we made sure that also we made sure and mitomycin was put or in other cases we can also go from amniotic membrane graft also. In my case, ma'am, we only went for mitomycin C, and then
how did you control the bleeding?
Ma'am, we planned for cauterization, but the mass did not bleed as we were anticipating, so we did not go for cautery.
And what about the feeding vessels?
Ma'am, there were dilating vessels. So when we removed the mass, they did not bleed, and we did not have to use the cautery. We just had to use mitomycin.
So you left that area bare?
Yes, ma'am.
So the sclera was showing?
Yes, ma'am. I have a picture also.
Yeah, show me.
So this was the post-op photo, ma'am.
Yeah. Okay. Got it. Well done. Thank you.
Thank you, ma'am.
Dr. Shanti Pandey ma'am, Do you have any question to ask? Okay, then let's start with our next speaker, Dr. Yashasvi Tripathi from Hind College, Barabanki, under the mentorship of Dr. Deepti Tiwari. Dr. Yashasvi, are you ready? Dr. Yashasvi, unmute yourself.
Good morning, ma'am.
Hi. So are you ready with your presentation? Then you can start sharing your screen.
Good morning, ma'am. Good morning, everyone. I will be talking about cases of third nerve palsy in young individuals under the mentorship of Dr. Deepti Tiwari. Clinical findings of an acquired third nerve palsy depend on the affected area of
Yashasvi, I am interrupting you. Your screen is not showing here. Your slides are not visible.
my network is one second, ma'am. Ma'am, is it visible now?
No, not yet. Have you I mean, have you shared the screen? You have clicked on share screen?
Yes, ma'am.
Dr. Yashasvi, there will be a green icon in the center of the screen down below the picture, below your picture. Just move the cursor around, it will appear.
Yes, ma'am, I have shared.
Then after that, you have to select your PowerPoint slides.
Okay, it's coming.
Yes, now you can start.
Good morning, everyone. I'll be presenting case on third nerve palsy in young individuals under the mentorship of Dr. Deepti Tiwari, ma'am. Clinical findings of an acquired third nerve palsy depend on the affected area of the ocular motor nerve pathway, can be divided into partial and complete palsy. Partial palsy presents with complete ptosis, eye position in downward and outward with inability to adduct, infraduct, or supraduct, as well as a dilated pupil with sluggish reaction. Partial third nerve palsy may be common and can present with variable duction, limitation of the affected extraocular muscle, and with variable degrees of ptosis. There are many etiologies like vasculopathic process, trauma, compression, infiltrative, toxic, like chemotherapy, and etc. My first case is a 22-year-old female who presented with drooping of left eyelid since one day, gave a history of fever with rigor, holocranial headache, pain in neck, which increased on neck bending, photophobia since 6 days. She had upper respiratory infection tract symptoms since 7 days, and she was a diagnosed case of viral meningitis. On examination, her vision was 6/6 in both eyes, near vision N6 in both eyes, IOP 13 and 14 in right and left eye. Left eye showed complete ptosis, left eye was down and out, and ocular motility examination showed restriction of adduction, elevation, and depression. Left eye was mid-dilated, pupil was mid-dilated and non-reactive to light. Right eye was normal on examination. Fundus and field were normal. Rest of the systemic examination was also normal. A diagnosis of post-viral left third nerve palsy was made, and MRI showed thickening and enhancement of third nerve as shown by the arrowhead. Third nerve palsy resolved completely in 1 month on treatment with oral steroids, and she was followed up every 2 weekly after that. My second case is of a young girl who presented with sudden onset of painless third nerve palsy with complaints of drooping of right upper eyelid since 1 week, and she had a history of pain in both knees with mild swelling and generalized body ache since 1 month. She was a diagnosed case of SLE. On examination, her visual acuity was right eye was 6.9, which improved to 6.6 with pinhole, and left eye it was 6.6, and near vision was N12 in right eye and N6 in left eye. On examination, in right eye, exotropia was present with limitation of adduction, elevation, and depression. Pupil was dilated and gave no reaction to light, and left eye was normal on examination. On investigation, complete blood count was normal. ESR and CRP were raised. Vasculitis profile showed increased anti-nuclear antibody and increased anti-double-stranded DNA antibody, low complement C3, C4 levels. Blood biochemistry and CT head came normal. She was given IV methylpred and for 4 days, and 4 days later, third nerve palsy recovered completely. She was also followed up every 2 weekly after that, which led to complete resolution of her symptoms of palsy. Thank you, ma'am.
Judges, please note, the participant took exactly 4 minutes. She was within the time limit.
Dr. Shweta ma'am, you can start with your discussion.
So what were the pupillary findings in your case?
And pupillary in the patient, SLE patient, pupil was mid-dilated and it was non-reactive to light.
And the first case?
Ma'am, it was dilated and it was also not reactive.
Okay. So the pupil was involved.
Yes, ma'am.
My next question is, how do you differentiate the supranuclear lesions from rest of the lesions in third nerve palsy or any nerve palsy?
Ma'am, in cases of complete third nerve palsy, there will be pupil will be dilated. There will be complete ptosis.
I mean, if the lesion is supranuclear, then what differentiates it from nuclear or the lower level lesions?
Ma'am, in case of nuclear palsy, there will be contralateral superior rectus will be involved, and due to dorsal rostral damage, there will be ipsilateral dilatation of pupil. Whereas in cases of fascicular involvement, we can have non-Thangle syndrome, Claude syndrome, where red nucleus can be involved, leading to a ipsilateral third nerve palsy with contralateral involuntary movements. And in Claude syndrome, there can be superior cerebellar peduncle can be involved, leading to contralateral ataxia, tremor, and ipsilateral third nerve palsy. And ma'am, in fascicular lesion, we can also lead to a manifestation of Weber syndrome, which will lead to ipsilateral third nerve palsy with contralateral hemiplegia. Ma'am, I can't hear you.
Okay.
Which year are you?
In supranuclear lesions, there is gaze palsy.
Yes, ma'am.
While in rest of the thing, gaze palsy is not there. So supranuclear lesions, they have characteristic gaze palsy.
Yes, ma'am.
Okay, excellently managed.
Thank you.
Dr. Sudipta ma'am.
Yes.
You can ask your questions.
Where I can't see her. Where are you?
Dr. Yashasvi?
Yes, ma'am.
We can't see you.
Ma'am, can you see me now?
Yes. Tell me, what do you mean by total ophthalmoplegia?
Ma'am, total ophthalmoplegia where there is no ocular movement, full ocular restriction, movement restriction.
In which conditions can you find this?
Ma'am, in brainstem lesions.
And? In both your cases, pupil was involved, right?
Yes, ma'am.
In what cases can we see third nerve palsy with pupil sparing?
Ma'am, pupil sparing third nerve palsy is seen mostly in vasculopathies like diabetes mellitus and hypertension, where there is vasa vasorum involvement, which leads to sprouting of the nerve endings, which leads to sparing of pupil.
So, as an ophthalmologist, what treatment did you give from your part for this, was the case managed by the neuro department?
Ma'am, the patient was referred to us from neuro department. So we started her on IV methylpred therapy for 3 days, followed by also for the SLE patient was also managed with hydroxychloroquine. And along with that, after 3 days, we switched her over to oral steroid therapy.
Any role of any eye drops?
Ma'am, we gave her lubricating eye drops because SLE also leads to dry eye and KCS, keratoconjunctivitis.
Was there any activity in the anterior chamber in the SLE patient?
Ma'am, when the patient came to us, there was no activity in the anterior.
No. Okay, thank you so much. Thank you.
Dr. Shanti Pandey, ma'am, any questions from your side? Okay. Now our last speaker for this session is Dr. Deepti Gangwar from Hind College, Barabanki, and her mentor is Dr. Astha Trivedi. Dr. Deepti, are you ready with your presentation? Dr. Deepti? Okay, good. So we all can see your screen, Dr. Deepti, but I think so you have not unmuted yourself.
Yes, ma'am.
Okay. So are you ready with your presentation? Dr. Deepti, are you ready?
Yes, ma'am. Yes, ma'am.
Okay, then you can start. Dr.
Please
Deep,
start.
you can start.
I think her slide is not moving.
Yes, ma'am. Slides are not.
There's no play button.
I can't see my slides over here.
Can you just open your PowerPoint? You
Yes.
don't need to open the Zoom.
Okay,
wala.
ma'am.
Yeah.
Okay, ma'am.
And then just put it on a PowerPoint.
Now it has come.
Yes.
Good.
Good afternoon, everyone. Myself, Dr. Deepti Gangwar from Hind Institute of Medical Sciences, Barabanki, and my chief guide is Dr. Asa Trivedi. And I'm going to present myself on sudden proptosis in after a trauma. Coming to introduction, orbital subperiosteal hematoma is a rare condition in which there is collection of blood within the potential space between periosteum and the bones of the orbit. Rapid expansion of this hematoma may cause compression of optic nerve, hence prompt diagnosis and appropriate treatment can prevent the visual loss. Orbital subperiosteal hematoma occurs most commonly due to facial trauma and less commonly secondary to any non-traumatic causes. I'll be presenting a 6-year-old boy who presented to our OPD with the chief complaints of sudden protrusion with downward displacement of the right eye following fall from a height of 6 feet 10 to 12 days back. There was no history of diplopia and bleeding from nose or ear. There was no history of unconsciousness and seizure. On examination, the visual acuity in right eye was 6/9. In left eye, it was 6/6. With pinhole, it was 6/6 in both the eyes. Color vision was 17/17 in both the eyes. IOP, whereas in right eye was slightly higher than the left eye. It was 15 mm of Hg, and in left eye, it was 12 mm of Hg. There was downward displacement of 5 mm and forward protrusion of 3 mm in right eye. There was subconjunctival hemorrhage in the superior and temporal to the limbus. There was restriction in elevation in the right eye, and there was resistance on retropulsion of right globe. Rest of the ocular movements were normal. The pupil were normally reactive to light in both the eyes. Fundus was normal in both the eyes, and neurological examination revealed no abnormality. On investigation, we did ultrasound orbit and NCCT head along with the orbit. They were on ultrasound, there were heterogeneous echogenic lesions in superior orbit. NCCT revealed a hyperdense biconvex lesion in the superior orbit, and there was no bony discontinuity or fracture. Thus, after clinical investigations and clinical examination, we confirmed the diagnosis of post-traumatic subperiosteal hematoma. So we started the patient with the IV steroids, dexamethasone 4 mg BD, and IV antibiotics for 3 days, and was then shifted to oral steroids and antibiotics. As patient came late 10 to 12 days after, and there was no visual compromise, patient was managed conservatively. And after 1 month, complete resolution of hematoma with normal position eye was there in this patient. Discussion. Traumatic subperiosteal hematoma of orbit commonly occurs in young patients, and it is almost always present in the superior orbit. Periorbita in children is not tightly adherent to the underlying bone except at the optic canal, orbital fissure, orbital margins, and orbital foramina as compared to adults. Orbital subperiosteal hematoma is caused by rupture of diploic veins between the periosteum and the bony orbit. Rupture causes a local hemorrhage with the subsequent hematoma formation between the periorbita and the bone. To conclude, the subperiosteal hematoma of orbit must be considered in the DD of unilateral proptosis after trauma, and steroids forms an important tool in early resolution of hematoma, especially when there is delayed presentation. Thank you.
Judges, please note the participant was well within the time limit.
Dr. Shweta ma'am, any questions?
Excellent presentation, Dr. Gangbar. I would just like to know what are the various surgical spaces in orbit?
Surgical spaces.
One is subperiosteal, the one that you had discussed. What are the other 4?
Ma'am, retrobulbar.
Intraconal is one.
Yes, ma'am. Subperiosteum. Then extraconal, intraconal.
Good.
Then, ma'am, subtenons.
Good.
And
Subarachnoid.
yes, ma'am, subarachnoid.
Good, good, good. The case was very nice. Good. Over to other judges.
Dr. Deepti,
Yes, ma'am.
you mentioned about color vision. Why did you want to check color vision?
To check there is any optic nerve involvement there or not. If there is
Was there
optic
RPD?
nerve, no, ma'am.
Okay. And what about diplopia?
No, ma'am. There
Any
was not much
restriction of
restriction.
not
Ma'am,
much
there was,
restriction?
yes, ma'am. So there was no
Okay.
diplopia as such.
So there was a protrusion of the eyeball, right?
Yes, ma'am.
How did you measure?
Ma'am, with Lude's exophthalmometer.
What happened? Like what is the procedure?
Ma'am, it's a transparent thicker scale. So we keep at the orbital margins, both the orbital margins, and we check on the scale how much eye is protruded. That.
Did the patient have lag of thalamus because of the protrusion?
No, ma'am.
Could you measure the intraocular pressure?
Yes, ma'am. It was slightly higher in the right eye. It was 15 mm of Hg, and in left eye it was 30.
Okay. In what other conditions could you get this kind of a picture?
Ma'am, other DDs. Ma'am, in orbital cellulitis, in case of dermoid cyst, in case of capillary hemangioma. Ma'am, if it is bilateral, then thyroid, and unilateral lymphangioma, then
space occupying lesions.
Yes, ma'am. Any space occupying lesions? And lymphangioma, hemangiomas, or any kind of tumor. Metastasis from anywhere to the eye can also lead to.
So you are
proctors.
the investigation done was CT scan or MRI?
I'm CT.
CT scan. Okay. Good. Thank you so much. That much should be okay.
Thank you so much, ma'am.
Dr. Shanti Pandey ma'am is not available right now, and with this talk we come to the end of our competitive session 3. I like to thank the speakers and cheers to them for the wonderful presentation and rapid fire question answer round. And I'd like to thank the judges, Dr. Shweta ma'am, Dr. Sudipta ma'am, and Dr. Shanti ma'am for taking out time for their session. And thank you for this wonderful participation. So we are moving towards our next talk by Dr. Suvida Meher ma'am. And I'll give a
Just
brief.
before you start for the next one, I just wanted to just reconfirm. The first presenter's name was?
Dr. Jyotsna.
Dr. Jyotsna.
Second was, first
Dr.
was
Jyotsna presented the basal cell carcinoma.
Yes,
Yeah.
ma'am.
Yes.
Akanksha West presented?
OSSN. He
OSSN.
presented in the place of Dr. Anugya Singh, actually.
Oh, is it? Okay, okay, fine.
She
The
she was
next
a
speaker
co-author. Dr. Anugya was actually sick and she's admitted in the
Yes.
hospital.
The third speaker?
Dr. Sanchita Gupta, ma'am.
What did she present?
1 minute. Dr. Sanchita, if you are there, you can also answer.
I presented premacular hemorrhage secondary to valsalva retinopathy.
I didn't get you at all.
Ma'am, I presented premacular hemorrhage secondary to valsalva maneuver.
Right. The subhyaloid hemorrhage was yours, right?
Yes, ma'am. Yes, ma'am.
Okay, fine. Next was?
Dr.
Arpita.
Ma'am, mine was subconjunctival cavernous hemangioma.
Hemangioma, correct.
Yes,
ma'am. Next?
Dr. Yashasvi, ma'am.
She presented on third nerve palsy, I guess.
Yes, ma'am. Third nerve palsy in the young.
And the last presenter was on proctosis,
Yes, ma'am.
Okay.
Yes,
Thank
ma'am.
you so much. Excellent presentation by all of you. Keep it up. We shall meet soon. Thank you.
Thank you, ma'am.
Thank you, ma'am, for giving us time.
No, thank you.
Now, our next talk was by Dr. Pragati Garg, but because of the delay in our session and her simultaneous commitment at the other place, she is unable to participate right now. So we are moving to our next talk by Dr. Suvida Meher ma'am on yoga and eye. Ma'am, you are ready? I'll give a brief introduction. Just a minute, ma'am. Just give me 2 minutes, ma'am. So, Dr. Suvida Meher ma'am is also a known face in Women Ophthalmic Society. She is the director of Purna Eye Center, Bareilly. Did her MBBS from GSVM Medical College, MS from KGMC. She did her fellowship in FACO, Medical Retina, Glaucoma and Uveitis from Sagarmat Eye Hospital, Lahan, Dr. Agarwal Eye Center, Chennai, LVPEI, Hyderabad, and Bachu Ali Eye Hospital, Mumbai. She had multiple presentations earlier also at UPSOS, AIOS. She is a certified yoga instructor with RYT 1200 hours training, and she has been honored with Uttarakhand Nari Shakti Samman 2024. I welcome you, ma'am, for your
you so
talk
much.
and here on our resident session of UP.
Am I audible?
Yes, ma'am.
Yeah, I would request Manu to start off my slide because I
Yes,
don't
ma'am.
want
Yes,
any
ma'am.
delay. It's already
Yes, ma'am.
very late.
Ma'am,
Everyone must be hungry.
Dr. Gargi, can you stop sharing your screen, please?
I did.
1 second, ma'am.
Yeah, I'll make it short. At the onset, I'd like to thank Dr. Nilima and the organizers for my last minute entry. So, and since it is the last entry, I'll make it short. I have made it into a video rather than a PPT presentation. So how did I come to know that we as an ophthalmologist should be taking into account if the patient is doing yoga or not? Because I myself ended with PVD when I was doing inverted headstand because I did something wrong. So, but everything is fine. So now I would like you all to know that how yoga can impact our eye health both positively as well as negatively. Why it is relevant for we as an ophthalmologist? Because we need to provide informed advice to patients who are doing yoga or are interested in yoga, because most of the yoga instructors, they themselves don't know it, because as far as I know, there are very few yoga instructors who barely ask regarding any health issues, leave alone your eyes. So the better part of the yoga is, of course, pranayama, but that basically includes alom-vilom and the Brahmari pranayam that are good for circulation, but all of them need to be done in a proper manner. The meditation, especially the deep meditation, breathing exercises, and relaxing techniques like MSRT, they reduce your stress level, and in turn, it's beneficial in your intraocular pressure. Then you can have relief from eye strain, especially post-computer syndrome, by doing certain eye exercises. Potential pitfalls that we need to be very aware, because a lot of time the patients are doing yoga without proper instructions, especially when it comes to intraocular pressure, inverted poses, especially headstand, shoulder stand like pitch mayor, etc. They can raise your intraocular pressure by overall raising the blood pressure as well as the orbital pressure. So this will in turn will exacerbate your glaucoma. Floaters, definitely. Sometimes the floater with rapid eye movement that are in periphery, they come into the center, and and the patient suddenly feels them, and then they eat up your head that I've got this problem or that problem. And of course, most of the time it is harmful, but a lot of time it might create problem for them. Now, what are the recommendations that you as an ophthalmologist should be telling your patients for safe yoga practice? Because this is very important, especially in patients having certain eye issues. Coming to that, the first thing is glaucoma again. The first and foremost, any inverted poses, they should be avoided. And if the patient has been doing, it should be made clear to that patient that if the patient has glaucoma and it is progressive, he or she should avoid and go into gentler poses. The gentler poses are like, Trikonasana and then Pranayama, all the poses where you're either sitting or standing, because it has been found that intraocular pressure is best when you are either in the sitting pose or in the standing position. In reverse inverted poses, it is usually not the good thing to do. For myopics, especially with the one having retinal pathologies, again, they should avoid forward bends and seated forward bends like Paschimottanasana. And again, moderate and gentle poses like tree pose, Vajrasana, Sukhasana, they should be doing that. In any pose where they are, and they should get to the eye examination regularly done, even if they don't have any retinal changes, because sometimes you tell them that you are absolutely fine and they end up doing all kind of poses and they might cause more harm than the good. Retinopathy, especially having clear changes in blood vessels, again, they should avoid poses like as seen, because these poses most of the yoga teachers are telling their students or advising them to do it without proper instruction. Again, gentle yoga practices. In any yoga practice, it is important that you should be focusing on your breath, on your breathing, because the breathing has to be gentle. In any condition where you're holding your breath for a longer time, that is definitely going to create more issues, health issues, rather than benefiting you. In floaters, again, the pranayam that involves rapid inhalation and exhalation like Kapalbhati and Brahmari, they should be avoided. And the same goes for glaucoma also, because they are extremely intense, rapid movements involving both eye as well as head. Again, gentle, steady movements, even if it involves rotating your head or your eye, it should be gentle. It should not be rapidly, which is important, and which the teachers they themselves don't know, and they are doing the same thing. So the patient has to understand that he should not be doing what his teacher, yoga guru, is doing. Now, post surgeries, most of the surgeries, especially phaco, is like you can go ahead with everything, but still from our side, we should be advising patient to take it slow and don't go into extreme yoga poses immediately post surgery, especially if they had and have been doing it since before. Well, and most of the time it is like, it's not that harmful, but still a minimum 14 to 15 days or at least 2 weeks is a good thing to tell them not to do. And they can again go with the gentle flow. Especially they should avoid, again, Kapalbhati Bhastrika has to be done under instruction and after proper precaution. Because once I had a patient who ended up with a lot of floaters. It could have been PVD that accidentally occurred after phaco surgery, and he still attributes it to his phaco surgery. Then during practice, emphasize to your patient, first we have to ask the patient that if he or she is practicing yoga or not, because a lot of time they think yoga is for all and it is not going to create any problem. Then there is one study which was actually done by optometrist Satish Kumar and S. Atra, and I thought I should explain it to you, because with the present age of a lot of computer work and screen time, there are a lot of symptoms of eye strain, neck pain. So they did this study, and they included those people who are doing prolonged computer use and a lot of table work reading, and they had symptoms of headache, eye strain, dry eye, and blurred vision, especially after finishing of their work. So what was the objective? Objective was they evaluated the undergraduate optometry students, and they divided into two parts. That was the control and exercise parts. Mainly they did to tell their patients the control part, that the patients who were asked to do yoga ocular exercises that were like 30 minutes per day, 5 days a week for 6 minutes. And the control group, there was no intervention. Baseline examination was done, and validated questionnaires were filled up by the study groups. And it was these exercises, they were explained to the study groups, and they did it regularly for 6 weeks. And these are like, you can get it in any YouTube with a proper instruction being given by the teacher. And they are actually very useful if done regularly. And definitely, as the result was that the exercise group, there was significant reduction in eye fatigue, and control group, there was increase. The first, why was the benefit there? Because of enhanced ocular muscles function, increased blood circulation, and improved blink reflex, which usually blinking is the first thing we forget while we are doing a lot of screen time. So in conclusion, I would like to emphasize upon that as an ophthalmologist, it is our duty to explain it to patient first, to ask the patient if they are doing yoga or not, because they won't tell you. And if they are, then explain them that they should be doing it in a proper manner, least they do more harm than the good. So since yoga has become a daily part of our life, so a balance is important, be it life or mat. Thank you. I made it very, very short so that everybody is like, doesn't goes off to sleep.
Perfect, ma'am. Perfect. So,
thank you so much, ma'am.
And now we are moving towards our next session, which is a CIPLA sponsored session on dry eye, and it will be presented by Dr. Manupriya. Manupriya, are you ready with the presentation?
Yes. I'm ready. Is my screen visible?
Yes, it's visible.
All right. Good afternoon, everyone. I won't be taking much of your time. And I'm very sorry for the delay also. We are running a little short. All right. So this is a CIPLA sponsored talk on the dual polymer advantage in the management of dry eyes. So as we all know, dry eye is very prevalent in the whole world. 1 in 4 patients attending the clinics report symptoms of dry eye. And an even higher number of patients are there who don't even report any symptom of dry eye. So the prevalence of DED is high and ranges from 5 to 33% of the adult world population. So in India, a study was done in LVPI, which found the incident to be 16,482 in a span of 8 years. Now, as we all know that according to the TOFS dues to classification, now the tear film, the reason for dryness is basically tear film instability, hyperosmolarity, and ocular surface inflammation and damage. So dues to a 4-step approach towards management of dry eye, in which step 1 is basically the education regarding the condition, modification of local environment, dietary modifications. Then we also use ocular lubricants of various types and lid hygiene and warm compresses. The step 2 includes non-preserved ocular lubricants, punctal occlusion, moist chamber spectacles or goggles, overnight treatments, lippy flow, as we know, topical corticosteroids, topical cyclosporin, topical secretagogues, etc. Step 3 constitutes of oral secretagogues and autologous eye serum, serum eye drops, therapeutic contact lens, and soft bandage contact lenses. Step 4 includes steps like amniotic membrane grafts, surgical punctal occlusion, and other surgical approaches such as tarsorrhaphy and salivary gland transplantation. Now, as we all know, artificial tears have been the mainstay therapy for the management of dry eye disease since a very long time. So they basically enhance the lubrication and prolong the retention time on the ocular surface. And a variety of viscosity enhancing agents are frequently incorporated to the artificial tears. Now, the evolution of tear substitutes. Now, the first generation tear substitutes consisted of saline-based isotonic or hypotonic solution with preservatives. The second generation included natural and synthetic polymers, methyl cellulose derivatives, and synthetic polymers with gentler preservatives or preservative-free products. The third generation included those that incorporated hyaluronic acid. And the fourth generation includes those artificial tears which have a lipid component. Now, the most commonly used viscosity enhancing agents, as we all know, are polyvinyl alcohol or polyvinyl povidone, HPMC, CMC, polyethylene glycol, and sodium hyaluronate. Now, coming to polyethylene glycol and even HP guar, it's a hydroxypropyl. Hydroxypropyl guar. It is basically a natural polysaccharide used in artificial tears. So it is a pH-sensitive product. It forms a reversible cross-link with borate, resulting in a gel matrix with mucin. It spreads over the conjunctiva and the cornea, and then it binds to the hydrophobic sites of damaged surface of the epithelium. So therefore, this HP guar particle provides lubrication, retards the tear film desiccation, enhances the stability, and serves as a natural bandage to allow repair of the surface epithelium. It improves the retention time of the formulation on the ocular surface, and it provides increased relief from the symptoms of dry eye. Now, HP guar particle also has a mucomimetic action. So it basically acts on the mucin layer, and it helps in tear film maintenance, and therefore it protects the corneal epithelial layer. Now, coming to another molecule, that is sodium hyaluronate. As we all know, sodium hyaluronate is a naturally occurring substance found in all connective tissue of the body, along with our vitreous and aqueous humor, and it is obviously also present in the ocular surface in the tears. What does sodium hyaluronate do in dry eye? It effectively binds water and resists dehydration. It promotes epithelial wound healing, and it also promotes the viscoelastic property. So therefore, it enhances the residence time of the drug on the ocular surface. Now, how can it effectively bind to water? So it basically has a greater capacity to hold water than any other natural or synthetic polymer. Hence, evaporation of water from HA eye drops is slow and the beneficial effects are prolonged. Now, how does sodium hyaluronate promote corneal wound healing? So fibronectin is an extracellular matrix protein which stimulates epithelial cell migration and accelerates corneal wound healing. So hyaluronic acid binds to the fibronectin, making a complex which enhances wound closure and wound healing. Now, what is viscoelasticity, which is a very important property? It is basically a shear stress, that is the force between the tears and the surface and the ocular surface. So what happens? Hyaluronic acid has a very good viscoelastic property. During blinks, the shear stress causes the molecules of HA in a solution to align with one another. As a result, the solution becomes elastic and relatively non-viscous and therefore spreads easily. Now, between the blinks, the molecules of SH form a tangled meshwork and the solution becomes less elastic and more viscous. Consequently, the tear film is stabilized. Now, what will happen when we combine our polyethylene glycol or HB-GOR along with sodium hyaluronate? So basically, first it provides prolonged lubrication. It acts as a mucomimetic. It accelerates corneal wound healing, and it also improves water retention due to the hygroscopic properties. So therefore, there is increased tissue hydration and lubricity, and it protects the ocular surface from damage associated with dry eye. So there is basically synergistic effect of the two drugs when they are combined together. Now, they also protect the ocular surface from damage associated with dry eye by improving the tear film stability better than individual polymers. How the sodium hyaluronate improves the lipid layer thickness. Then polypropylene glycol as well as sodium hyaluronate acts as a viscosity enhancer. Then HB-GOR improves the mucomimetic action, and sodium hyaluronate also accelerates corneal wound healing. Now, there are few clinical studies which I'll go through quickly. Now, there are few studies which show the immediate effect of this combination drug on tear film stability. So, in the next two slides, we'll see the result of instilling the drop. And after 60 minutes of instilling the drop, the T-BAT increased from 5.6 to 6.22. The study was done in 50 patients with dry eye. Then again, the tear meniscus height increased from 0.19 to 0.2 after 60 minutes of installation of the polymer. Now, as we all know, that dry eye is a very important and very frequent complication after cataract surgery. So 1/3 of the patients undergoing surgery experience dry eye symptoms. Symptoms may be combined with reduced tear film stability and increase in ocular surface staining, which can persist even up to 3 months after surgery. Now, this is a study showing improvement in ocular discomfort with the combination drop post-cataract surgery. As we all know, according to the SPEED score, now this study was done in 3 groups. In group A, the drug was given from preoperative period only. In group B, from post-operative period. And in group C, this drug was not given. So as we can see in group A, the SPEED score is decreasing. And a decreased score means that the patient doesn't have dry eye. A score more than 8 signifies that the severity of dry eye is increasing. So as we can see in groups where this drug was not given, the SPEED score is increasing. Again, in T-BAT score, in the same 3 groups, as we can see in group A, the score is increasing. And in group C, where no drug was given, the score is decreasing post-cataract surgery. Now, there is effect of this combination drug on the corneal epithelium. So, as we can see, it confers greater desiccating resistance, possibly through hydration and enhanced retention in people who were using the combination drug. Then there is effect of the combination drug on the recovery of corneal epithelium. Now, the cells associated with HB-GOR HA formulation exhibited greater cell membrane barrier function than those associated with single polymer formulations, either only hyaluronic acid or only PG analogs. Now, this is another study showing impact of hyaluronic acid containing artificial tears on reepithelialization in an in vivo corneal wound model. Now, the percentages of cornea that were fluorescent negative 24 hours after debridement was highest in the combination group compared with other HA containing artificial tear product groups, as we can see in the table. And then there is another study which again compares the same thing in an in vivo corneal bone model. Now, in this also, the percentage area of revitalization was highest in the combination group versus those with other HA containing artificial tear products. Now, the key take-home messages from this are the dual polymer tear substitutes, that was those containing both hyaluronic acid and polyethylene glycol, provide increased tissue hydration and lubricity and protect the ocular surface from damage associated with dry eye. And they also increase the retention time on the ocular surface. They also help in maintaining the tear film stability post-cataract surgery. They provide significantly greater cell viability than the individual single polymer formulations on the desiccated corneal epithelial cells. They also help in re-epithelialization of the corneal wounds by accelerating wound healing process. Thank you, everyone.
Okay, Manupriya, it was a good talk. Now let's wait for the results. I think so they are almost prepared.
Okay. Dr. Gargi, we can have Dr. Smita to address.
Yes.
And then announce the results at the end.
I'll request Dr. Smita Agarwal, ma'am, to give the vote of thanks for today's competitive session. Ma'am, are you ready? Smita ma'am. Smita ma'am. Ma'am. Oh, I think so. She is busy calculating the results. She is not responding.
I think she's coming, Gargi. Her calculations are
almost done.
Almost done.
Hi,
so,
ma'am.
For everybody now, they will be sitting with their hearts racing, right? The results are there.
So almost everyone did very well. So
yes, correct. Very good presentations.
And there was a very nice answers to the questions. Rapid fire session of question answers was very well performed by all the presenters.
And one small thing which I would like to say by the time till Smita comes and joins and starts her vote of thanks to the residents is, there is what we call a rule of 6 for making slides in a PowerPoint presentation. Don't make more than 6 lines in a slide and not more than 6 words in one line. So, if you crowd up your slides too much, they don't look so good. So that way, you don't have to write everything which you want to speak about. So it is a good idea to practice the rule of 6 whenever you make your slides. So resist the temptation of making slides like textbooks, right?
Yes.
I'm here. So are we announcing the result first?
We are waiting for vote of thanks by you, ma'am.
Okay.
We are keeping the audience a little more
anxious.
Yeah.
Okay.
I'd now like to invite Dr. Smita Agarwal, ma'am, to confer the vote of thanks.
Gratitude is not only the greatest of virtues, but a parent of all other virtues. So on behalf of WOS UP chapter, we would like to extend our heartfelt gratitude to WOS India, a parent body, President Dr. Madhu Bhadauria ma'am, our Secretary Dr. Mohita Sharma for giving UP State chapter this opportunity. Special thanks to my hardworking friend Dr. Shweta Walia here for initiating and leading this concept of resident program countrywide and lighting us the spark within us and organizing these competitive sessions. A big thank you to all the honorable judges present today, Dr. Ragni Parekh ma'am, Dr. Reema Rawal, Dr. Nilesh Parekh, Dr. Neeta Ramnani, Dr. Rajendra, Dr. Sanjay Thakur, Dr. Shweta Walia, Dr. Sudipta Ghosh, and Shanti Pandey ma'am. We are grateful for your time, your attention, your wise judgment, and your thoughtful consideration, because without you, we would not have a winner. Thanks to our esteemed speakers for today, Dr. Jimmy Mittal, Dr. Gayatri Ahuja, Dr. Vivek Singh, Dr. Manupriya, Dr. Pragati, Dr. Suvidha, for taking out time on this busy Sunday and enlightening us with the talks. Thanks to all the mentors and the mentee residents for such a power-packed knowledge of battle today. Each one did their very best under their mentor's guidance. My special thanks to my co-state head, Professor Dr. Nilima Mehrotra ma'am. Her charisma and her leadership is truly inspiring. We form a great team. Thanks to my two pillars who shouldered the whole responsibility under our guidance, Dr. Manupriya and Dr. Gargi. I am at loss of words to express my gratitude for your contribution, your hard work, and your willingness to do things outside your comfort zone. I'm sure you girls are still having hunger pangs. और पता नहीं breakfast भी किया है नहीं किया है सुबह 9:30 बजे से बेचारे बैठे हुए हैं. Last but not the least, Mr. Bhageshwar ji and the team and Cipla people for arranging this whole session. Thank you once again. So now over to Nilima ma'am for the results.
Thank you so much, ma'am.
All right, so Smita has calculated the results, and as everybody has said, and she will jointly announce them with me, and as everybody has said that all presentations, all discussions were really very good. Questions were faced very bravely by our residents, and you know, what is important is participation and the confidence to present and to work on your case. You know, this way you remember these things better than you would otherwise. So, Dr. Smita, would you like to announce the first winner? Here, I would like to say that tell you all that the WOS members, the first winner goes to present in National WOS, right? But the first winner will be announced. So will be the second and the third. But the first of the winners who is a WOS member will get to present in WOS annual conference in Delhi in October. All right, but we will announce the winners nonetheless.
So should we start from the third winner first?
Yeah.
Yes, right.
So at the third position, any guesses? So on the third position, we have Dr. Josna Shri with 40.5 marks from SRMS Bareilly. And a big congratulations to Dr. Nilima Mehrotra ma'am for mentoring her so well. And she's a WOS member also.
Yes, thank you. This is really good. I don't know if anybody remembers, but Dr. Manupriya has also been a winner of this event earlier, couple of years back.
I do remember, ma'am.
Yes,
There were successive 2 years when SRMS Bareilly residents were always on the top.
Yes, yes.
I think last year also and last year also.
Right, yes.
Even Elia was the winner.
Yeah. Yes, yes. And Manupriya has been a winner also. Now we have Dr. Jyotsna. So Jyotsna, if you are online, congratulations to you. And then we have a tie at the second place. So the second position is a tie of Dr. Shivi Srivastav from LLRM Meerut, and Dr. Alka Gupta madam is her mentor. She is a WOS member. The other person who is tying at the second position is Dr. Ayushi Bansal from Rajri Medical College, Bareilly, and her mentor is Dr. Vimlesh Sharma. So she is also a WOS member. So congratulations to Dr. Shivi and to Dr. Ayushi. So we have 2 people at the second place, 1 person in the third, and the first one winner, the one at the top, will be announced by Dr. Smita.
Okay, so the first winner is Dr. Sanchita Gupta with 41 marks from Sharda, Noida. And Dr. Charu Malik is the mentor. But really sorry to say she's not a WOS member. So she really missed this chance. Dr. Sanchita, are you here?
Yes, ma'am, I'm here.
A big congratulations to you, and I just hope that you should have been a WOS member. इतना बड़ा chance आपने miss कर दिया.
Ma'am, this was told to us last night only that we have to be WOS members. So it was not possible for me to become a WOS member immediately. So that is why I had even requested that I will become a WOS member post the presentation. I had requested Dr. Manupriya as well. I had told her about this. So if it was possible after the presentation, I would have become, because it was a very short notice. That is why I could not become a member.
Actually, I'll have to point out a lot of people became members in the last 2 days only. So even if you had just applied for registration, like a lot of people asked me, and I even put it on the group, like we were even accepting acknowledgements, like just an acknowledgement that you are becoming a member. Those people are also included in the winners. Winners are anyways included, but it's just that you won't be able to present in the WOS annual conference.
You can present otherwise, you can send in your work, and I recommend you become a WOS member. And actually this information was given to all colleges also at the time of asking for
initially, the very first communication, this was communicated.
And Dr. Sanchita, anyways, you are a first winner with 41 points. The second winners, both of them are with 40.6 points, and the third winner is with 40.5. So, you know, it's a very close race. All of you have done well, and wishing you all the best in future also. So we will be getting back, and I think the certificates will also be soon available for all participants, including the speakers, judges, and of course, the presenters.
So I think we took a very long time, so it's time to something. So can we take a lead, ma'am, then?
Yes, I think now that the whole program is done, so we can enjoy the rest of the Sunday.
Okay.
Yes, ma'am.
Thank you, Manupriya. Thank you, Dr. Gargi. Thank you, Nilima ma'am, once again.
Yes,
Have a
thank
great
you
day
all,
ahead.
and very well conducted and very, very enjoyable academic session.
Yes, ma'am.
Thank you, Dr. Nilima ma'am and Dr. Smita ma'am, for giving us this incredible opportunity to be a part of this program.
Yes, we were happy to have you both, Gargi and Manupriya.
Thank you for
very well.
making us a part of your this program. Thank you so much, and we look forward for more of such togetherness in future also, ma'am.
Yes, and physical togetherness followed by fashion show.
Yes,
yeah, just gear up yourself for the WOS annual. It's just nearby.
Yes, ma'am. Okay.
Okay. Thank you all very much.
Thank you, ma'am.
Thank you. Bye.